2022'nin 5. oturumunu açmak istiyorum. Bu oturumun konu başlığı kanser tedavi merkezleri. İlk sunumunu yapmak üzere Sayın
Now I would like to invite Associate Professor Dr. Fatih Göksel for the first speech. We will talk about radiation oncology and proton treatment. Distinguished participants, first of all, I would like to thank the organizing committee of the Congress, and I would like to thank the participants. I will talk about the device planning and the radiation oncology services and proton. I will, before talking about the planning, we need to evaluate the current status. What is this current status about cancer? We need to understand what it is, and it is really hard to plan these processes or treatment methods. We have surgery, radiotherapy, and chemotherapy. As you know, cancers, 13% of all deaths are caused because of cancer, and 70% of them are happening in the less developed and developing countries. With the support of the early diagnosis and different treatments, we can treat 30 or 50% of all cancers. And 60 or 70% of all cancer patients receive chemotherapy in one part of their lives. And we need to see the trend here. But where are we? Where are we going to go? This is really important if we are going to plan. In 2020, when compared with 2000, there was a 65% increase increase in the cancer cases, and in 2040 there will be a 50% increase, and this figure will increase to 30.2 million cases, and the largest portion will happen in the least developed, less developed, and developing countries. For this reason, when we are planning for the devices and planning for personnel, we should consider this, take this into account. And industrialization and aging of the population are other main reasons, and this is an important health problem, and this will continue to increase its significance. And in global statistics, we can see that in the world, the deaths under the age of 70 are caused mainly by cancer in 57 countries, and in 55 of those, in 55 of some other countries, the cancer is the second reason of that for the people under the age of 70. What is the current status in our country? We have a relatively young population. Yes, in 2017, the population over the age of 65 was 30%, but in 2050 it will be 20% in Turkey. So it will increase, and 90% of cancer is happening after the age of 45. So in the upcoming years, the cancer cases will increase. What are we doing in our country? In 2011, we had the radiation oncology center. We opened up radiation oncology centers. I will talk about radiation oncology, and when we took them all into account, and we made a planning for oncology centers, the planning and the centers. So we also thought about the world realities. And what did we do? We had decided upon some steps. We don't want all centers to do every procedures. There are some steps. There are some centers where some actions are taken, and these are we have. Cancer early diagnosis, or we have oncologist service units and service hospitals. In our country, we have about 33 comprehensive oncologist centers, and we have oncological diagnosis and treatment centers, their number is 117, and this stepwise approach was relatively successful, and our ministry is conducting its actions in this way. In radiation oncology, when we get to planning, the personnel planning is important because you need to have qualified personnel. You should use the resources in an efficient way. The international literature's guidelines should be taken into account, and for 250 new patients, they recommend one radiation oncologist. So we took that into consideration as a whole for the country, but for hospital, we want to have one radiation oncology expert for per 100, 250 patients, or one technician per 60 patients. And for health technicians, dosimetrists is another issue. We don't have dosimetrists in our country, and health physicists are important for us. We're using health physicists, and planning measurements are done by them, and master degree is required, and doctorate degree education is required. Their number is quite low, and we signed some protocols with universities, and we increased the number. This is a rough number for the country planning. For the center, they recommend to have a more specific approach. And as a technique, when we go to the centers, if you have more than 25 patients, you need to have 4 radio technician. If you have 600 simulation, you have 2 for that. So you can see the specific planning here. And we consider the realities of the country, and we also think about the regional realities. Health physicist is important. This was the most important problem for us, and European Federation of Organization for Medical Physics made a decision, and the number of planning, annual number of planning, were taken into account. They have some coefficients, and we have the main general number of the expected number of personnel. And in this regard, we tried to increase the numbers by talking with Supreme Board of Education, and the number is about 600 radiation oncologists. And for health physicists, it is we require 400, and our number is about 350 and 400. So we have the minimum levels of personnel for oncological centers. And radiation oncology treatment devices and their planning are really important. We have Linux, MRI Linux, and intraoperative devices, particle treatment systems, and brachytherapy, then internal radiotherapy devices. These are the main devices we use, and in their planning, we consider international qualities, and in all around the world, we want to make sure that in our country, we want to make sure that the patients have an access to these devices, because these technological devices are costly, and if you should not go below some certain figures, and we have attraction points, as in some provinces, large metropolitan provinces. We want these devices to be used, and of course, it should be used for at least more than 300 patients. These devices have a technological lifespan of 10 years, and you can increase this up to 15 years with good maintenance. But these are technological devices, and in 15 years, there are no more state-of-the-art devices. So you should be taking this into account. You are buying this device, and it doesn't mean you will be able to use this 15 years. After 15 years, even though they do not have any problems. And some centers, we can use double devices, and there should also add the CT simulation device in order to have this standard radiotherapy to be done. Technological device is causing some faults, failures, and we do not want to take a break. And we want the patient, if there is a problem in one of the devices, the patient should continue with the second one. We don't want to take a break for the treatment. And so this double device is important for the patients. And we use Linux. These are the base devices for radiotherapy, and we recommend these devices to every centers, each center. And we can add some apparatus, and we can have stereotactic devices. And there are some devices which are produced specifically for stereotactic radiosurgery, and we have gamma knife devices, and we are sending them to comprehensive oncology centers. And we need patient support for them, and we need to have the physical infrastructure. So in our country, we have about 28 devices like this, and we don't have any problem in accessing the patients. And we also have some specific characteristics about the software support, and stereotaxi taxi can be done specifically. So there are some devices which are working on small tumors for 5 fractions or single fractions, and in the periphery we add some apparatus to the devices, and we can do it with them. In our country, we have about 84 devices like that, and in total, in 122 centers, stereotaxy can be done. And when we are doing the plannings, these things are important. We should take this into account. And what is important for us in up-to-date treatments, the irradiation. So where are we irradiating? Are we irradiating the tumor or normal tissue? We need to see that instantly. And there are current devices right now which are supporting that, but they are not close to that technologically, and we can see that we are irradiating them. And if the tumor is weakened, we can have another transfer planning, and this increases the treatment process time periods, and it has some problems. And we do not recommend these devices to every place, and it should be in advanced centers, because the indications are not coming from every side, every part. And we have intraoperative radiotherapy devices, and we need suitable surgical equipment and hardwares, and surgical oncologists should have knowledge and experience about this. Not all centers need this, because the number of patients are limited. You cannot use it all the time. In 7 centers, we have this device, and it is covering our need. We have brachytherapy devices. These are welded devices, and it has a lifespan between 3 to 5 months. And we you are sending them to the centers, not to the periphery. We recommend it. These are not really costly, but when they do not have the sufficient number of patients, the resources are wasted. So we are recommending them to large centers. So this was about the radiotherapy, and when we are planning radiotherapy, we look at the number of the patients and the capacity of the devices, and the resources, devices, and the personnel can be used in an efficient and an effective way. The resources are distributed in the system, within the system in a correct way. As the technology is improved, proton and carbon is finding its way in our agenda. And as we know, proton was first first came to our agenda in 1930s. But in the last 10 or 5 years, it has started to be used more frequently because it is costly and you need to have large devices established, installed. Because of all these reasons, it was not used very frequently in the past. But now it is not like that. It is we are using proton most frequently. What is the proton? Proton is positive hydrogen atom, and it is distributed more homogeneous in the tissue, and in the tissue we target, we need to think about the energy, and we can have the chance to give the tumor the dosage we want. In Linux, we have an entry dosage, and the exit, we also have an exit dose of 80%. And entry dose is minimum, and we don't have an exit dose. This is something really important because it gives us the chance to give the target higher dosage, and it helps us to protect the critical organs. So we can inflate the balloon, blast the balloon we want. This is a good technology. So advanced technology is important. Personnel and technical hardware is required. So we should use this for limited indications. What are they? Brain tumors, childhood cancers, and critical organ tumors. So every country should take into account all these aspects and make a calculation. In many countries, it is like that. We have indication limitations. So it is mainly used for tumors. In optic tumors, they are very small devices, and it has a very small energy. It uses very small, little energy, and it is used not very frequently, and we have 1 or 2 devices in many countries. Why is it recommended in pediatric tumors? Proton entry dose is low, and we don't have almost no exit dose, and it decreases the latent side effects, adverse events, and the integral dose of the radiation is decreased in children with the support of that, and this helps us to reduce the secondary cancer possibility. Especially there are some tumors which is easy to treat, which has a high possibility to treat, like the lymphoma, and the secondary cancer possibilities are increased in those patients. So proton, this kind of childhood cancers are great indications for proton, and you will minimize the secondary cancer possibilities. And in addition to this, we have brainstem or second irradiation, serial irradiation for the for the threshold, and it gives us to give high dose for meningiomas, for example, and it has a high impact, high effect. If Linux has an effect of 1, its effect is 1.1 or 1.2, so it is affecting our response positively. As you can see on the screen, we have an exit dose and photons. We don't have an exit dose and protons, and so DNA breaks can caused by photon, and sometimes they're unbearable, and it is affecting the treatment, of course. And you can see the treatments with photon, and you can see the craniospinal irradiation on the on the upper hand side, and lower hand side. You can see the proton. There is no dosage almost. So this means that we are not affecting growth plaques, and we don't have any problems in the forms. And we have PROSTA treatments. We have IMRT, rapid art, and proton. The uncolored part is the place where it is not receiving any dosage, so it has a clear superiority. And when we look at the lung cancer or breast cancer or pediatric cancers, we are targeting the tumor, and when the target is receiving the dosage we want, in the other parts, you can see that there is nothing received. And you can see the examples here. I want to make a comparison. We treated a tumor with photons and protons, and the dosage of the tumor is retracted, and they calculated the dosage received by the normal tissue, and the photons and protons excess up to 25 grays. So this is a huge dose. It means 12,500 tomography or 5 million lung chest X-ray, chest CT. So it is increasing. So using proton is decreasing the secondary cancer development. Let's look at the proton superiority. It has a break peak features characteristic. It has a low entry dose, and for radiological dosage, it is 1.1 when compared with photon. So proton has superiorities because of all these things. So what is the benefits, clinical benefits? If you are giving this to the tumor, it will have a positive impact in the survival. And what is limiting us? It is side effect. If we have little side effect, we can give the tumor the dose we want, and we are protecting the healthy tissue, and especially for the aggressive tumors, it is providing great local control, and it is decreasing the secondary cancer development because it is decreasing the integral dose, which is received by the body itself, and it is decreasing the treatment period, and especially for the second series of irradiation, especially for the brain stem, we can have a secondary treatment possibility. How the proton treatment systems are used in the world. This is we have one accelerator. There are rooms, chambers, which are connected to this accelerator, and their size is about 5-story building. They are really huge, and we need to have a plant. So we need to have to work them, operate them. And this is an accelerator. As far as I know, this center is in Switzerland. This is a large center. There is one accelerator and 1 or 4 or 5 chambers. So we have single accelerator. When something happens, the old other devices stop. And is it suitable to operate all 5 rooms, because we have one accelerator and radiation is going from one accelerator. So in conventional approaches, we are not operating all rooms, all chambers. If there is a problem, if there is a fault, all chambers are closed. The firms say that we can have 5 or 6 chambers, rooms, but operationally ideal number is 3. For 4, you can use it for research purposes, but if you're talking about a very large center with high patient numbers, it can be recommended when we consider the cost. These classical conventional systems have a high cost, and because of these reasons and with the advancement of the technology, we are now using different systems for LINAC treatment. We have one accelerator, one single single room proton treatment. What is the advantage? The rooms are independent. They are a single system, and if the device if there's a fault in the device, then it only affects this device, and operational costs are relatively low. What is the current status in the world? In 2013, the number was 36, and now it is 115. And 34 centers are currently being built. And if you make a decision right now, you're not able to finish the construction process before 2 or 3 years passed. You can see the fast trend in the proton therapy. I talked about the proton and radiotherapy. And International Atomic Energy Agency has 2 things for the equipment. Has 2 guidelines for the devices and the equipments. Thank you very much for your attention. This was my presentation. Thank you. Thank you. You have exceeded your time, but the discussions, the presentations are independent from each other. If there are any questions, I think we can receive those questions. You said that you recommend at least 2 devices in a center. Should they be twins? Should they be twin devices? If their versions are the same, you can directly refer the patient to the other device. If it is not like that, you have to plan it again. Your physicist will plan this with your physician, with your doctor. You will work for 1 day. Even if it is the same, if we have the same device, if it has the same version, you can do it. We experienced something like that. When a device is broken, there was the same brand device in another center. No, it doesn't. It is not resolving the issue. The version and everything should be the same. It would take 1 hour of the physicist, and then the doctor approves it, and then we do it. One in Ankara, and we have one in Ankara, one in Istanbul. It is planned in 2015, and it is still being recommended. It is planned by the ministry, but we don't know when it will be operational. And we want to plan at least approximately 8 centers by 2023. Private sector heads, you need to ask this question to the officials from Ministry of Health. Once it is planned and it is approved, how long the construction process take? For conventionals, 3, compact, 2 years. Thank you. Our co-chair for this session, Dr. Khaled, is with us. Maybe he would like to invite the second speaker. I received a message about this. Can we see him? I think he is not there. Okay, then warn me. Maybe if he's there before the third speech, maybe we can give the floor to him for introducing the third speaker. Now, I would like to invite the second speaker without delay.
Doktor Dilek Gürlek, Gökçebay.
I would like to invite Associate Professor Dilek Gürlek Gökçebay. She will talk about Hematology and Bone Marrow Transplant Center. I would like to welcome you all. I would like to welcome you all to this session, and I would like to thank you for this invitation. When we talk about this bone marrow, we are talking about this hematopoietic system and how to replicate it and how to multiply it through this transplantation. And we also use these type of sources, and this is why we use this hematopoietic transplantation. And for the first time, it was applied by Thomas and his friends in 1957. As regards to our country, it was applied by Professor Dr. Korkut Özerkan from Hacettepe University, and we are talking about stem cell. As I said, Hacettepe University is the first university that applied this system, and what we see that in line with the harmonization of the tissue, there is an increasing number of these operations. Of course, it might be the patient himself or herself as regards to the donors, and we call it also this type of transplantations. As regards to the operations at the European level, we see have autologous transplants, and they are used mainly for malign cases, or we may use it malign and benign cases. As regards to the cases of this type of course, there is need for the tissue issue, and we are talking about this marrow, bone marrow, and it might be their brothers and sisters or secondary relatives, or there might be similar cases, and we may use also this cordon blood. And there are several cases, and there are stem cell databases and banks in the country. And we created this center at the country level in 2015, April 2015. We have donors, and which scans our donors. And there are voluntary donors. They can donate to the Turkish Red Crescent, and they should be between 15 to 50 years old, and they may provide their information, and all these information are registered, and whenever it is matched to someone else, then we collect all this tissue, and we collect samples, and then we carry out the operation. As regards to the cases in Europe, of course, following the autologous donors, we see that brothers and sisters cases are number 2, and as regards to the centers of for relatives, it is number 3. And we also have these type of cordon blood transplantations, and as you can see, there is this decrease in recent years, because compared to other types, it is relatively difficult, and also it takes longer time. This is why we see that this trend that is related to the family members and also brothers and sisters. As regards to our case, there are 109 bone marrow centers, and of course we have pediatric and also adult centers. As I said, it is 109 in total. And there is an increasing trend, and we have this autologous transplantations, and it is quite similar to the cases in Europe. And as we see, this is non-relative donors cases, and also this harmonization in the tissue. During the COVID-19, we observed about 20% decrease in these cases as regards to the transplantation operations because of the restrictions during the COVID-19. But in 2021, we had more than 1,000 operations. Of course, it is important for the Turkish patients, and also it is important for the foreign patients who are visiting our country within the scope of the health tourism. As regards to the bone marrow centers, it should be at specialist centers, because there are certain risks as regards to the potential diseases or infections. In this sense, it is important to protect these people from infections. Similarly, we see that they need to stay at hospitals for 55 days, and of course it is related to the cost of the treatments, and it is a factor that increases the cost. In this sense, we have the circular on the operation of the bone marrow transplantation centers, and all the registration and also licenses are issued within the scope of this circular. In order to prevent problems, there is need for certain systems, and we are looking at HEPA filter systems and also a fresh air system, and there is need for taking certain measures within the scope of the operation. Similarly, there should be no contact, or there might be some other problems related to air-related diseases or also touching on surfaces. And all these patients must stay at hospitals in chambers or rooms for one person only. And ventilation is very important. It is very important to reduce the human mobility. This is why these type of centers are located at upper stores and stairs of the floors of the hospitals, and there might be positive pressure to balance the air pressure. Again, tuberculosis, if there are patients who are potentially at risk of such diseases through air flow, and there is need for negative pressure, and there should be no entry or exit points which are close to ventilation systems, and there might be generators and also other type of power banks so as to generate required energy and power. In order to prevent such diseases and communicable diseases, washing hands are important, and using disinfections is very important, and there is need for a sanitary kitchen and also facilities within these rooms. And when patients leave their rooms, they must wear N95 masks, and also they should wear certain gloves, certain types of gloves. And there is need for minimal approach to the design of all these rooms, and the type of walls should be covered with antifungal and antibacterial paints. And it is also important to design all these rooms. There might be infections which might be transmitted to patients through water, so the water tanks should be regularly controlled, and also the temperature should be controlled on a regular basis, and samples should be taken on a regular basis. As regards to the health officers, they must be experts of their issues and of their parts, and they must spend at least 1 year in another center in order to gain required and necessary experience. And there is also need for a coordinator to organize all these activities, selecting the donors and also collecting tissues and all cells, and all these issues should be carried out by the administrative and also clinical staff. Of course, nurses who are working in this part, they should be able to follow these neutropenic patients' cases, and also they should be able to recognize complications related to their cases. When we look at the circular, which has been issued by the Ministry of Health on such centers, what we see that hospitals which are able to carry out operations, there are certain other branches which must be active and which must be in serve. For example, biochemical and also hematology labs should be active, and also microbiology laboratory, and also there is need for blood bank which must be in service for 24 hours. And there are certain requirements of pharmacies and also chest service and also gastroenterology services, etc. All these branches should be there, and endoscopy, etc. and also there is need for an intensive care unit. Nutrition support is extremely important in this period because there might be some problems related to nutrition, which may lead to certain infections, or as a result of such infections, there might be some problems related to gastroenterology. And as regards to the bone marrow transplantation centers for children, we need to look at this circular as well. As I said, there must be one bed for one patient in each room. Isolation and also positive air pressure, which I already talked about, are very important. And collecting stem cells and also thrombocytes is very important. And transplantation of this stem cell and also how to process them is important because they may collect them from relatives, or we may collect and then we may need to freeze them. And it is important to have these isolation centers. And we may also need to have a separate clinical room. As regards to the international accreditation system, it is important and it's widely accepted at the world level. We have this FDA, which is the criteria for the bone marrow centers, and we are having more and more centers. And following this accreditation, all procedure should be carried out in line with the standards. This is what we have seen so far. And what we see that there is this increase in number of such centers. There are 38 out of 40 which are active today. And because of the sound problem, I'm unable to hear the speaker well. We are talking about more than 10,000 cases, and there are autolog transfers and plantations. And what we see that usually it is 7.5 years old. And when we look at the centers which carry out such operations at the highest numbers, we see it is mainly pediatric centers. It's the Akdeniz University, Ege University, Hacettepe University, and also such centers are carrying out numerous operations. As we see, during the last 5 years, there is this increase in such operations. During the COVID-19, of course, there was decrease in operations, but there is a continuous increase in such operations. Of course, the implications might be different for the malign cases. It might be leukemia or cancer cases, and we have no malign cases. We may have these transplantation cases that might be thalassemia or lack of immune, or there might be metabolic diseases. So it might be benign cases, and we use this stem cell transplantation. It is a study that we carried out. As we all know, following this war in Syria, there is a huge influx into Turkey. And in that period, from the MENA region, we received many people as well. And of course, there are some metabolic diseases. And when we look at the transplantations to these cases, we try to understand whether it is different than the Turkish patients. And we examined 174 migrant cases, and we also compared these cases to 64 children, Turkish children. We look at the similar cases, and 3 out of 4 cases came to Turkey because of war, and 1/4 came to Turkey for health purposes. And of course, majority of them came from Turkey, and the rest came from different Middle Eastern and North African countries. 66% of these patients was diagnosed in their countries. The rest was diagnosed in Turkey. Especially in this group, the level of literacy is too low. And as a result of our study, what we have learned that the complications are quite similar to the Turkish patient cases. We didn't observe substantial differences. Of course, as regards to the language barrier, which means interpretation is needed, and also long-term hospitalization is important, and also children who are migrant children who receive these treatments, there is need for more studies in this sense. I would like to thank you for your patience, for providing this opportunity to me, and thanks for your support. Thank you, Ms. Gökçebay. It's a very enlightening presentation, which we learned a lot. Any questions or comments from the participants? I just wonder, when we look at these, when we talked about this cordon blood, cord blood, what we see that you may keep it, there is no time limits. But of course, this paid cord blood bank is different, and it is stored there for your case only. But if you donate it to the Ankara University, then it is used forever, and it might be used for someone else. And there is, of course, you may still donate your cord blood. And usually they donate peripheric stem cell, and then you donate 2 tubes of blood, and then it is stored in the database. And then if it is matched, then they call you, and then if you want to donate, then they get it bone marrow or peripheric stem cell, etc. Any questions? Yes, please. Mike, please. Let me introduce myself first. İlker Telli. I'm a medical doctor. I'm working in Kozan Health Center, and I donated my bone marrow to my brother. And I, of course, declared that it took just 1 hour. And the officials informed me that they would keep this document for 1 hour. As regards to this process, so rather than being a donor, when you give it on purpose, do you have any training, and do you still record such declarations, and do you still keep such data? So if this is a brother or sister, of course we inform them and we get their consent. But I'm not sure if it is legally important to record all these procedures and keep documents. But if you donate your stem cell, of course we get your consent in written form, and then we keep them. But it is not a legally binding obligation. Thank you, Ms. Gökçebay, for your presentation. Okay, now I would like to invite the third speaker, Associate Professor Ayşe Ocak Duran. She will talk about the medical oncology centers. Distinguished participants, distinguished colleagues, and dear professors, I will talk about the oncology centers. And this is the outline of my presentation. I will talk about comprehensive oncology planning, and I will talk about cancer cases, and also I will talk about change in treatment algorithms. And I have 3 slides here, which I will talk about. And I will talk about cancer centers. I will talk about medical oncology centers. And I will talk about solid organ tumors. And I will talk about medical oncology. And I will talk about medical oncology centers. And I will talk about a unit which prepares chemotherapy. And I will talk about patients. And as you know, cancer is one of the most serious cases or diseases which results in death. And we have this and there is also increase in survival and recovery. In line with the global population, there is an elderly population, which means there is need for a more comprehensive oncology planning at the global level and also at the national level. As regards to the U.S. survival analysis, you can see data from January 2021. Any patient who has been diagnosed with cancer or who has been fully recovered from cancer or active cancer cases. When we analyze all these cases, I can't use my pointer here. We see this malign melanoma cancer, and we have as regards to female, it is breast and uterine cancers. Early diagnosis graphics show that in 2015 it is breast uterine cases. There are 9 different malign cases. And early diagnosis, if it is the first phase cases, and what we see that there is an increase in such cases or diagnosis of such cases. When we look at the age profile of patients, almost 50% of them is 65 years old or over 65 years old. And we also see some cases who are older than 85 years old, which means following the diagnosis of cancers, when we look at the period of these treatments, as you can see in blue dots, it is longer than 10 years. So we have cases for more than 10 years, according to data from January 2022. As regards to the cancer cases, in addition to the support centers, there is this increase in recovery and survival cases. So in addition to cancer treatment, there are some other treatment-related problems. As a result of the increase in survival rate, there is this recurrence risk, or it might be secondary primary cancer risks, or there might be another cancer risk related to treatment process and also planning about treatment of these patients for a long period. Of course, related to these treatments, there might be neuropathy or lymphedema or gonadal functions. It might be some problems related to eyesight, and there might be some other complications, and there is need for thinking about such complications in the long term. So anyone who has been diagnosed with cancer once may suffer from psychological stress because of the risk of facing another cancer. So there is need for a multidisciplinary approach, and there is need for a well-functioning oncology planning. So I may call it a comprehensive oncology centers in metropolitan cities. So there is need for solid organ malignity, or as Associate Professor Dilek stated, there is need for hematology units, and there is need for also bone marrow units. So we also use these type of systems, and there is need for radiation oncology, there is need for operational surgery oncology or urologic oncology, there is need for orthopedic oncology, nuclear medicine for diagnosis and also for treatment purposes, and there is need for nuclear medicine center, radiology for the diagnosis and also for other type of treatments. It is important to use such experimental radiology and of course pathology. These are the units, essential units for any oncology centers. Of course, when we talk about oncology centers, there is need for multi-parametric issues. In this sense, there are cancer centers in the US and in Europe. And what do we have in such centers? MD Anderson social support is important for those who are diagnosed with cancers. Adaptation courses is important for relatives, psychosocial activities, and it was surprising to me, spiritual support units are important as well. So if you want to join a spiritual support center, you just need to contact us, it says. And in such cancer centers, of course, for phase 1, phase 2, or phase 1, in order to provide services, up-to-date services, and in order to access new medicines, there is need for clinical research centers, and Professor Tuğçe will talk about all these issues in the following presentation. Of course, we have ambulance care system or hospitalized cancer systems are important. Psychological stress, which is very important for the patient and also for the relatives. In this sense, psycho-oncology center is important. Palliative care center is important. So from the diagnosis point to the end of life, it is important for any type of suffering or any type of diseases related, secondary diseases. Of course, it might not be the treatment purposes, but we may also talk about preventive oncology centers, and we may need to approach to the whole society in line with our policies of the Ministry of Health. It is important to achieve early diagnosis and also scanning, which is available in our country for different types of diseases. And if there is tumor which we diagnose at an early phase, it is important. And in multidisciplinary tumor consults are extremely important because cancer patients cannot be treated by an oncologist only. There is need for a curative system, and there is need for a more definitive treatments, especially for recovery cases. So multidisciplinary tumor consults are extremely important for this approach. This is why I'm calling it a comprehensive treatment centers, comprehensive oncology centers. And it is important to have a training center for nurses and also for the patients and also relatives. And of course, nutrition is very important, and chemotherapy, which we apply, which may result in vomiting or also having a dizzy life. So we may see these type of issues in the future. So nutrition is very important, and it might be applied to oral nutrition for some cases. Of course, so we may not have a stable cases whenever we are talking about an oncology case. That means he or she may face some problems at 3 or 5 in the morning. This is why there is need for an emergency service, an emergency unit, and also intensive care units. Of course, these are the issues that I'm thinking, and we may multiply them.
Oncology.
This is a slide from European Oncology Society. It is a quite plain slide. How the cancer care should be is the main topic. And it should start from the admission of the patient to the hospital, and we should have evidence-based treatment, multidisciplinary team, and working plan, which focused on quality chemotherapy, but of course a reliable chemotherapy, and from the diagnosis until the end of life, healthy, reliable, comprehensive treatment is a sine qua non. So you can see the individualized treatment for children and adult patients, and we discuss in multidisciplinary councils, and we can conduct tests. And once they receive the surgical treatment, they come to oncology centers, and in those centers, we are the main locomotive of for the patient. We stage the disease, and we design the treatment plan for the patient, and we talk with the patient and designate the main objective for the treatment. Chemotherapy, hormonotherapy, or follow-up plans are completed, and when necessary, we receive the support of radiation oncology, and then we follow up the patients. And for each tumor, we have guidelines for the follow-up. And after the follow-up, we can provide home care services. We can we can have support groups, and we need to protect the patient for tumor formation. And as you can realize, we have patient-based, hospital-based, and test-based. But on the left-hand side, we are talking about the support groups, home cares, follow-up. We have social support. And cancer is a social problem, actually. And we are conducting the hospital leg, but as you can see, there is many aspects of it. And I'm working in Ankara Oncology Hospital. I will show the photos of what I have just explained to you. And we have KETEM building, cancer early diagnosis and detection center. This is for early diagnosis. We have polyclinics for treatment, radiologic imaging, nuclear medicine clinic, and nuclear medicine treatments can be done. And we have multiple operation rooms, and we have beds and rooms, pathologist centers, and medical oncologists, working base, medical oncologist center. This is the medical oncologist center, and right next to it we have the outpatient clinic, and we have just one photo from radiology clinic, well, because we are using different methods of working. And for phase 2, phase 3, and phase 1, the clinical trial parts, multidisciplinary tumor boards, patient training, nurse training, meeting halls, and in all stages, psycho-oncological support is provided in this psycho-oncological unit. And we admit the patient, and there is a waiting room. We give the chemotherapy to the patients, and then they can receive this treatment as an outpatient. And we also have pharmaceutical counseling, polyclinic, chemotherapy preparation unit. I will talk about all these units. and we prepare. We have make reservation, make appointments for the patients, and this is the waiting room. And as you can see, and these are the doctor physicians' rooms. So these are where the foundations are laid for oncological treatment, and we plan our treatments. And in those polyclinics, we have a medical recommendation counseling center, and we are giving chemotherapy agent to those patients, and we have a chemotherapy preparation unit. As you know, chemotherapy is something we use for the patients, and they have statistic effects on the normal tissue, and it requires preparation. And when we need to provide the acceptable toxicity, give the toxicity, and we should not exceed this. We have some standards of like square meters, height, or air conditioning. We prepare these rooms, and they can prepare this automated or semi-automated or manual systems, and everyone should protect themselves because the devices are automated or semi-automated, and it prevents contact to a certain extent. This is where I received my oncological training. This is from a university hospital. Fully automated chemotherapy preparation robotic units. As you can see on the left-hand side, we have trained people here, and the doctor is recommending this chemotherapy, this plant by the physician, and the dosage are entered into robotic unit. I will show you a video of its preparation, and they prepare the process, and we call this the preparation of fully automated systems, and no one this is done totally by the robot, and as it is not prepared by people, we don't have any problems about the injury of injections, and we don't have the contact with the chemotherapy sets, and as it is prepared by robots, we can prepare multiple chemotherapies, and the large centers it is recommended to use these robots. Of course, they have disadvantages. They might be broken, and viscosity chemotherapy agents are not prepared. Some flacons are not prepared, are not able to prepare, or you need to open up the flacons and then put it into the device. And on the right lower picture, you can see some smaller places. So you can see some devices which can be used in smaller places. Manual chemotherapy preparation, pressured, negative pressure structures, and it is not taking the air from inside to outside. And we have air ventilation systems. This is where I work. These are the two robots and the robotic system. As you can see, a number of chemotherapies can be prepared at the same time. And in manual preparation part, we use our personal protective equipments. You can see two health technicians preparing chemotherapy. I will show you a video. If you do it full screen, I believe the video will work. This is fully automated, 6 parts, chemotherapy preparation tool. It looks like a box outside, and there are scales around the robot, and it takes the flacon, and then The remaining part of the device, the drug is not wasted, of course. It is used for the next patient. And the chemotherapy is prepared safely in this way. I want to talk about the chemotherapy nurse services because the training of the patients are really important as we are providing information to the patients, and we need to have the chemotherapy training nurses. And those are people who receive training for chemotherapy. And as doctors, physicians, we are working together with the nurses and we train them. And when there is a cancer diagnosis for a patient, how they should act, and they should also inform the patient about the possible side effects because of the chemotherapy or the time periods when they should be in the hospital, and or some misinformation about cancer is also corrected beforehand by this unit, and one or three nurses can work in this unit, and I believe it is quite beneficial for us. Outpatient chemotherapy unit is a really functional unit for us. And this changes, of course, according to the number of the daily chemotherapy patients. Approximately, we have 62 or 64 chemotherapy chairs, and we provide 80, 90 chemotherapy dosages. But this unit is not just composed of these infusion sets and chairs. We also can give an oncological treatment, and we also look at the vital findings about the patients, like pulse or blood pressure. And we check their keeping conditions. We use premedications for nausea or vomiting. We have premedication rooms, and each treatment is not IV chemotherapy. We have injection rooms. Intramuscular therapies are also be used, and we are using these injection rooms very frequently. We can see significant side effects. Sometimes we have patients in anaphylactic shock, and every day we have 3 or 4 allergic reactions. We hope them to be simple cases, but sometimes we experience anaphylactic shocks. So around outpatient chemotherapy units, we always have ECGs, or aspirators, or cardiopulmonary shock devices, and oxygen. We need to have a resuscitation room, and you can see it there. You can see the chairs and outpatient treatment center. It is like a TV chair, and they're very comfortable. They can stretch their legs, and we need to use these infuser sets. This is not a center only to administer chemotherapy. It is a must for all of us, for oncologists. Now we need liquid electrolyte or the replacement of liquid or electrolyte replacement. We can you do this in those units. We can inject or administer erythrocytes or thrombocyte suspension replacements, injections, and we can also observe the patients right after the treatment, but because the nurses can check their vital findings, and we observe the patients in this way. Thank you very much for your attention. Thank you. We have exceeded our time. I need to turn to the participants. Any questions or comments? Now, the microphone is not like the microphone. Are you talking about immunotherapy? Immunotherapy depends on the type of tumor. So it depends on the stage of the lung cancer. There are different agents of the immunotherapy. They have different effects, and it changes according to the type of the cancer. But as a general rule, I can say that in lung cancer, malignant melanoma, in kidney tumors, it is taking a dominant role. And my friend is receiving a therapy, and he said that I have 4 years of life. Please help me, he said. I don't know how he is informed about this. We don't say something like that. He is treated in Acıbadem Hospital. Maybe they experienced a significant toxicity about immunotherapy, but no oncologist, not 4 days, 4 years. Previously it was 2 years, now it is up to 4 years. Clinical trials results. According to clinical trials results, we are sometimes using adjuvant therapies who come after surgery. We have metastatic patients based on their tumor or state of the tumor. In these studies, we can say that to the patient, we have 36 months median survival for those patients. So. This changes according to the efficacy of the treatment, the patient, but in the clinical trial, median survival is 36 months. This can be said to the patients. I want to say something else. When saying the cancer patients that they have cancer, is it correct or not? We are an Eastern society, Eastern culture. I experience this very frequently in my own clinic. The patient relatives come and they give me a note and they say the patient does not know about the cancer, the diagnosis, and please don't say that. I say that we need to tell that to the patient, not in a devastating manner, but at least we should say that there is a mass in your body. If we are checking it, it doesn't look benign. But this is, of course, the Eastern culture approach. In Northern, in Western cultures, they say quite clear: this is the tumor, this is the type of the tumor. The life expectancy is 1 year or 2 years. We have the treatment for this, and the side effects of this treatment are like that. Of course, we should not be so straightforward or strict, but we should start informing the patient from the beginning. And my professor said that please inform the patients. Please don't know who is planning for who has a plan for their lives. Maybe they do not want to plan. Their plan was not to receive chemotherapy in a hospital. They want to go on a trip with his wife. So we should tell them, yes, you're correct, you're right. When the patient says that, when we say that we don't have anything, but when the patient knows that they know of the reality about their disease, they are helping the other people. And then everything is delayed, and he says, "You didn't help me because we are working in close contact with oncological patients. And I had 6, 7 cancer patients who lost their lives. May their souls rest in peace." Thank you. This topic can be discussed later. Maybe you can discuss this in the break, during the break, because we have all extremely exceeded the time. Thank you. Now I would like to invite the final speaker of this session, Tuğçenur Yiğenoğlu, will be with us. She will talk about the clinical research centers. We are behind the schedule, so I will make a 10-minute fast-forward presentation. And I first want to inform you about my own center in order to fulfill the purpose of the Congress, because one of the purposes of the Congress is to bring together the physicians working in the same field and increase the cooperation and collaborations. In Ankara, Oncology, Hematology, and bone marrow, we have a bone marrow center, and we are conducting more than 100 transplantations, and we had more than 2,000 bone stem cell transplantations, and they were coming from different countries, and we are serving international patients, and other physicians can come to our center for training, for hematology training, for stem cell transplantation training, and every Tuesday and every Thursday we have webinars about bone marrow transplantation, and there we have participants from Uzbekistan and Azerbaijan to these meetings. And if you would like to attend these kind of meetings, if there are hematologists who are listening to me right now, you can get my contact details from the organization firm, and we can have some observational studies. You can join these training programs, and you can attend webinars, and you can have my contact information from the Congress, from the organization, so that we have a chance for cooperation. I will have a 10-minute presentation. This is not about my own field of expertise. It is not about hematology. It is about Clinic Research Center. And I believe this is really important. This is not just about the development of the new therapies and access of the patients to the new therapies. I will show you something soon. It is about reducing the health expenses of the country up to 80%. So it can provide significant contribution to the countries. And we need to increase the number of the clinical research centers, and we need to engage the maximum number of patients to those centers. And this is a great service for the economies of the countries. What is clinical research? Clinical trial. It is a scientific research in order to answer an unanswered question. And in the beginning of 2021, we had 391,000 trials were conducted, and only 7,000 of them were in Turkey, and the clinical trial number is slightly over 10,000 currently. And when we look at the distribution, 37% of the trials are conducted in United States. And when we look at the Turkey, the registered clinical trial number was 5,734, and in the last 2 years, the clinical trial number has increased about 2,000 trials. And when we look at the current status in the world, the registered clinical trial number has increased by 10%, and it is increased by 25% in Turkey. So we have a success here. But we still room for improvement. We can do better. Are there any other countries that can do that better, like Japan, China, and Korea can be an example? In just 5 years, they have increased their rank from 26 to 7. We can do this. But in order to do this, in order to involve more patients in the clinical trials, in order to have more shares from the clinical trials, what should we do? Firstly, we should we should have a high number of patients in this field, and the ethical boards and the Ministry of Health should give the approvals, and there should be some incentives. Our costs should not be higher than the other countries, so that we can be preferable. The researcher is important. They should have some scientific studies in their past, in their background, and if they have studies like that, they are more preferable. And also, their workload, work burden should not be really high. Language is really important. Not just the doctors, the pharmacist, the nurse should have a sufficient level of should know English sufficiently. And in this center, this necessary equipments and the laboratory imaging techniques should be used. So where can we conduct these clinical trials? They should provide a safety for the volunteers, and it should be suitable for the follow-up and the conduction of the research of the trial in a healthy manner. And it should have sufficient personnel, equipment, and laboratory devices. This can be done in university health application and research centers, university R&D centers, and excellence centers of the universities, ministry training and research hospitals, and ministry excellence centers can be good candidates for these clinical trials. So why is it so important for us? As I said, clinical trials have a positive contribution for the disease, life quality, and cancer, as you know, is a very important mortality reason. And if we increase the participation to the clinical trials, we can find anti-cancer treatments faster, and the cancer patients should be informed about the clinical trials, and these clinical trials are really important for cancer treatment. It provides an access to new treatments. For example, we have the Spanish trial, and according to the Spanish trial, the clinical research, clinical trials, it is decreasing healthcare expenses by 79% in patients who are joining these clinical trials when compared to those who are not joining to those clinical trials. But we should be very careful about one thing. 20% of the trials are canceled because of insufficient participation, and opening up of each center is about 40 or 45,000 USD, and underperforming centers 5-year cost is 2 billion USD, and the total cost of 50% of the total cost is spent in vain, and it is not just something about the establishment of the comprehensive clinical research centers, clinical trial centers. The sustainability of them effectively is important, and we should have a systematic approach, and these clinical trials should be done or should be announced over internet. And in a clinical research unit, who should work? We need to have a unit responsible, and we should have a research pharmacist, field worker, and clinic research nurse, clinic research secretary, and when necessary, additional workers. What about minimum conditions, physical conditions? We need a working room, monitorization, and archive, research room, and according to the authorities in Turkey, what conditions are necessary for the authorities? According to the authorities, I will talk about these conditions. I will just show the photos of our clinical center and then finalize my presentation. And according to the Turkish authorities, in order to have a phase 1 comprehensive phase 1 center, we need to have a physical environment and sufficient field, sufficient environment for the physical equipment, and we need to have a room for the volunteer and the physician to have an exchange of information, and there should be a place for eating, and there should be a room where we are processing the samples, and we are storing them. Archive is also necessary, and lighting, sufficient lighting is important, and we should have a power source, and we should have the office hardware, and in order to dispose of the waste, we need to have the suitable systems according to the legislation, and the entrance to the center should be limited and closely monitored, and it should be registered, and the center's personnel should know about the volunteers. For example, they can have badges for the volunteers, and the heat temperatures of the storage areas should be monitored. We should have a monitoring system, and these values of the temperature and heat should be registered, should be recorded, and if this is over a certain threshold, there should be a warning system, and the calibration, maintenance, and repair of the equipment should be able to done in the center. And they should have a resting area. in order to prevent contamination, we need to take the necessary precautions, and we should have a area for the volunteers, and the access of the volunteers should be definitely limited to the documents or samples related to the trial.
So, of course, there is need for competent staff who can carry out all these activities and procedures, and volunteers cannot and should not access all these places, and we should keep all the records, and temperature and also humidity control should be carried out on a regular basis, as I said before. And if it goes beyond the range that we need or that we determine, then there is need for important steps to be taken. And there is also need for an archive area which must be isolated from all types of materials which can be easily broken if there is fire or if there is any rat, etc. And there is also need for limited access to all these data. All these data should be kept electronically as well. Laboratory should be licensed by the Ministry of Health. All the equipments should be completed and should be examined so that they can be calibrated, and samples should be taken from laboratory to the clinical areas in a safe manner. Of course, these are the requirements for any center that is in service for phase 1, and all these criteria, of course, declared by the public authorities. As regards to our center, we have 4 chief centers, and we have 12 field coordinators, and we have also nurses. As you can see, there are 2 patient examinations room, and we have 1 meeting room, and there is also administration office. And as the slide shows, there are archive areas which are made of metals, and there are also offices. There is 1 room and office for nurses, and there is also 1 centrifuge and also freezer for storing purposes. And there is also a pharmaceutical center which has, of course, limited access. We have also clinical research center which has been established in January 2019, and the team is composed of a quality control manager and also nurse and also medical doctors. And as regards to the medical doctor's office, there is an area through which the medical doctor can see all patients. And as regards to the nurse room and nurse office, there is an archive which has limited access, and of course there is also a centrifuge and also freezer up to -80. Thank you for your patience. Thank you for your presentation. I just want to check if there is any question. We can get 1 question because you used your time efficiently. I just want to ask 1 question. Why don't we have these clinical research centers at the level that we want? Of course, it takes time and it takes energy, and if there is an understaff issue, then we will not be able to increase our staff. But we are making progress in last 2 years, and I think that we will be in a better position in next 10 years because there is a huge potential. We are talking about 80 million people, and we are providing a quality health services, but it's all about reducing the other forms of workload. So clinical studies should not be based on the quantities. It should be about quality, and it means staff, including medical doctors and other staff such as nurses, etc. This is why we need quality services. And that is the end of the session. We are running out of time and we are behind the schedule. And I think we will be back at 1:30. And we will be back at 1:30 with oral presentation.
Evet, değerli konuklar, bugünkü öğleden sonraki ilk oturumumuzda serbest
Distinguished guests, our first session in the afternoon will be including some presentations. We have Dr. Usama Savami from the internal medicine, and he will share his work with us. Since we have limited time, we will only have 2 questions after this presentation. Please watch out the time. Dr. Savami.
First of all, thank you for this great opportunity. I will present a case report that we have performed in Palestine. I'm Dr. Usama Sawalmi, a third-year internal medicine resident from Palestine, from Nablus, An-Najah University. Our topic title is Successful Autologous Bone Marrow Transplantation in Active COVID-19 Patients. This was a case report. COVID-19 was first reported in China in late 2019, and in March 2020 it was labeled as a pandemic. As we all know that COVID-19 has affected many aspects of our lives, even from the social activities or from the health point of view. The social activities have dramatically affected in terms of the lockdown, limited activities, limited interactions between the society and the social people. On the health aspects, we have noticed that apart from the large number of cases that have overwhelmed the medical staffs in the hospitals, the large numbers of cases that occupied vast beds, most of the beds in the hospitals, it also affected many of the procedures, many of the management plans in terms of the scheduled management procedures, such as the cardiac care, such as the chemotherapeutic options. And here comes our topic. In the hematology point of view, none have recommended to proceed with the autologous bone marrow transplantations while in the COVID-19 era. So it was actually a very difficult situation for those patients, whether to defer their management options or to proceed with. There was a great debate over the world whether we should proceed with the chemotherapeutic agents, whether we should proceed with the stem cell infusion for the hematologic malignancy cases. Many have described that many have described the results of the autologous bone marrow transplantation of a previously infected patients, but none have described that an active COVID-19 patient should undergo a bone marrow transplantation. Before I present my case, I will speak in a brief regarding the hematopoietic stem cell transplantation. In history, it was first introduced in 1959 in a patient who underwent a whole body irradiation. He was a leukemia patient, was treated with whole body irradiation, killing every single cell in his body, mainly the immune system. Then he underwent a stem cell infusion. This was first reported in 1959. What is the mechanism of action of stem cell infusion in those patients, in the hematologic malignancy patients? As we know that they are what is called the stem cells. The stem cells are the pluripotent stem cells. Pluri means multiple, potent means capable of. So those stem cells have 2 main functions or 2 main capabilities. The first one, that they can proliferate and produce other stem cells. The other thing, that they have the capability of producing another types of cells. So they can differentiate. Unfortunately, in cancer patients, in leukemias and lymphomas, we have a malignant stem cells. Those malignant stem cells are not susceptible or not sensitive for the chemotherapies. So here comes the rule of the bone marrow or the stem cell infusions. We infuse a specific stem cells inside the body of those patients, so those infused stem cells can get rid of the malignant stem cells, and so this is considered as a therapeutic option for those patients. This was the first article who was published regarding the first case of stem cell infusion in 1959. In Palestine, the first case of bone marrow transplantation was performed in 2006. Now in our university hospital, we have a specific section department serving those patients with 13 beds dedicated only for the patients who will undergo bone marrow transplantation. We have transplanted up to 250 patients so far. We have a success rate reaching 85%, alhamdulillah. Going back to COVID-19 and the bone marrow transplantation, as I mentioned before, that there was a great debate all over the world regarding the stem cell infusion in the COVID-19 era, and many have suggested that you should have a negative COVID-19 swab before you proceed with the process of stem cell infusion. But our cases, we have obligated to proceed with the stem cell infusion. And why? We had a 29-year-old male patient diagnosed with lymphoma, a kind of hematologic malignancy. For 5 years, he received 2 lines of chemotherapy and an immunotherapy. In April 2022, he presented for his scheduled bone marrow transplantation. But unfortunately, he was found to have COVID-19 positive. So here was the problem. We delayed the procedure for another month in order to get rid of COVID-19. But again and again, we did a COVID-19 swab, but unfortunately, it was still positive. We performed a multidisciplinary team discussion regarding whether to proceed with or to postpone it again, and the decision was to proceed with. Why? Because those patients are at a high risk of relapse. So we weighted the benefits and the risks of undergoing the stem cell infusion in those patients and the risk of waiting or postponing the process for another period of time. Actually, the risk of relapse was higher, so we proceeded with stem cell infusion. During the course of management, the patient developed high-grade fever. He developed oxygen desaturation, for which we were following them along with the infectious diseases, intensivists, hematologists, along with also the infectious diseases team. The patient was experiencing what is called a cytokine storm. So we used many options of medications, including steroids, including monoclonal antibodies such as tocilizumab. And over a course of 1 month, we, alhamdulillah, could achieve a complete resolution of the infection, and the patient was discharged home on room air without oxygen supplementation. However, even at the time of discharge, the patient was still COVID-19 positive, and we followed him up for another couple of weeks till he was completely COVID-19 negative, and his cell counts were recovered, and the process transplantation was completely successful. Up to our knowledge, this is the first adult case who with a successful bone marrow transplantation in active COVID-19 patients. We have noticed in the literature that there were 2 pediatric cases, leukemic cases of active COVID-19 who underwent bone marrow transplantation. Unfortunately, one of them died and the other survived. But alhamdulillah, our 2 cases are now still alive with a good functional state. As I mentioned before, why we proceeded with transplantation with active COVID-19, it completely depends on the risks versus benefits of proceeding versus waiting or postponing the process of transplantation. Why it is unique? As I mentioned, this is the first reported cases in the world regarding undergoing transplantation active COVID-19 patients. In conclusion, successful autologous hematopoietic stem cell transplantation is possible among active COVID-19 patients despite the potential complications. The benefits of bone marrow transplantation among those patients with the high risk of relapse. We have to individualize our cases. We have to weight the risk versus benefits, and we also need further studies in order to get a recommendation. This is still a case report. Uh, Finally, we hope that we can meet once a day in Palestine. This is a picture from our previous conference in Nablus city in West Bank. In 2019, we established an international conference with participation from the Arab and the Islamic world. Actually, it was a very successful conference. We also held its regular meeting after the conference. We hope that we can meet once a day in Palestine. Moreover, I hope that we can also meet in our beloved city in Jerusalem. This is the Minister of Foreign Affairs of Turkey, along with the Turkish ambassador and Professor Mahmoud Hojam, Dr. Mahmoud Mustafa. He is joining us here. Jerusalem is our beloved city. I hope we can someday meet there. This is the best place where you can meet your beloved ones. Again, this is Professor Mahmoud with the Turkish ambassador. This is me and my father at Jerusalem. On the back, we can see that the Dome of the Rock. Finally, this is Abdul Hamid Saad Kulisi, Manarat Sultan Abdul Hamid in Nablus. This is our city, Nablus city. From the picture on the right is the past and the left is in the present. It carries the nobility of the past. It carries the originality of the present and the brightness of the future. The connections between the Islamic world without those borders. I hope we can meet someday in Palestine, in Nablus, after getting rid of occupation. Shukran jazilan. Thank you very much. Teşekkür ederim. Allah razı olsun.
Evet, biz de Doktor Üsame Bey'e bugün
We would like to thank Dr. Usame for this great presentation. This was a very brave initiative for a rare condition. I had the opportunity to join them in the conference in Palestine. You must see Palestine, every Palestinian city. I hope we will come together there again. As I mentioned before, we have limited time, so I will have 2 questions. Do you have any comments or questions? Okay, I think not. Then we will close the session here. Thank you for your contribution.
Merhabalar.
Hello. I wish a great weekend to all participants. I am honored to meet you at Muslim Health Union Congress. I would like to send my regards and thanks to Mr. Kazım Sezen, who has contributed to this event. This is a very important subject, and there are great developments in Turkey and in the world. First subject is the colorectal cancers. As a surgeon who is specialized in the field, I believe that colorectal cancer is an important point. Our speaker is Mr. Öztürk from Ankara Oncology Training and Research Hospital. Mr. President, distinguished participants, I wish you a great session.
Because we are two chair for this.
Sorry.
Bismillah ar-Rahman ar-Rahim. Alhamdulillah wa salatu salam ala Rasulillah. Ladies and gentlemen, I have the honor to welcome you to this science, in which we will discuss a different topic. First, I'm very sorry for my English mistakes because my study is in French and Arabic. On behalf of all of you, I wish invite Dr. Professor Öztürk.
Yes.
Öztürk from Ankara Oncology Hospital Research.
Medical oncology.
Medical research. I think all all doctors will present with you in the same hospital.
Sorry?
I
Yes,
think
yes.
all
My name is Öztürk.
you are in the same hospital.
Yes, yes.
Yes. Yes, we can begin, brother. Thank you.
Sunum planım. Şimdi Türkiye
This was an overview of my presentation. In Turkey, we see nearly 330,000 cases every year, and almost half of them end fatally. Distribution of sexes are similar to how it is in the world, and colorectal cancer is the third most common type of cancer following the breast and lung cancer. And in stage 3, the treatment options are 60%. I would like to explain that 3-month adjuvant therapies were considered for patients, and according the total analysis and subgroup analysis were made for the patients, and we considered patients under 3 sections, and it was shown that for the high-risk patients, this was not the same. In stage 3, we recommend Folfox or Califox for 6 months, and in low-risk patients, we recommend non-inferior Folfox treatment for 6 months because it's non-inferior. In stage 2 patients, there are some risk factors such as T4 and lymph node retrieval below 12, since perennial infiltration, lymphovascular infiltration, or poor differentiation risk factors. And we know that there are research on this. Here we can see that in high-risk patients, T4 or lymphoma dissection are high risks. In such cases, we recommend Capiox or Folfox treatment, Capiox for 6 months or Folfox for 6 months. Why was total neoadjuvant treatment introduced for patients? The reason is distal metastasis rates are low. Before surgical treatment, neoadjuvant treatment could be recommended. And as you know, there are different trials, rapid progy, and there are other research on this. Pre-surgical short-term chemotherapy or short-term chemotherapy are tried in these research, and in some research, chemotherapy was applied before radiotherapy, and we identified that in these patients, local relapse remained almost the same. When we look at the survival analysis of these patients, we can say that there's a significant difference in survival rates. When we look at the metastatic patient approaches, there are different factors such as age, comorbidity, and we know that there are RAS-BRAF, HER2 and those must be evaluated. As we know, there are molecular approaches such as RAS-BRAF, and recently new genetic markers have been identified, and they refer to different parameters. In RAS mutation, anti-VEGF treatments may be followed by EGFR treatments, and in other patients, anti-VEGF can follow the treatment. In a short summary of the approaches to different types of patients, if it's the left colon with anti-VEGF, if it's on the right side, if the tumor is on the right side, we prioritize VEGF, and then anti-EGFR can be used. And I will also mention BRAF and other types of treatments that can be used after chemotherapy. If there's microstatic stability, we can start with the immunotherapy directly. In the second stage, except the cases when we use VEGF, anti-EGFR can be used. And in BRAF mutations, especially in BRAF and 600E mutations, different agents can be used. Here's a summary of the initial therapy. It begins with anti-EGFR, and then it continues with anti-PO. And if there's no instability, then we can consider post-anti-VEGF therapies. And here is the treatment of stage 4 unresectable mCRC. If we use the targeted therapies, we can have a chance of survival without relapse. And we know that GNFR gene mutations, and we know that these targets are more useful for treatment of tumors on the left colon. Here is a summary of principal randomized phase 2 and 3 studies. In the phase 2 study, we can see the benefits, and I will come back to these studies. These are phase 3 studies, and their primary points are different. And in addition to FOLFOX, panitumumab can be added in order to increase the survival chances. And in another research, panitumumab was examined as being added to other ingredients. Here we can see the BRAF mutation is higher in all types of tumor location types. Tumors located in left side of the colon are most common in patients who apply with hemoptysia, and their prognosis is better. These are FIRE 3 CALGB research, and this FIRE 3 research examined the impact of cetuximab along with bevacizumab, and in CALGB research, they examined if bevacizumab or another ingredient should be added to the first one, depending on the location of the tumor. As you know, there was a paradigm trial research was done recently, and panitumumab was examined if it would work with bemaximumab. And when we look at the difference of left colon and right colon, if panitumumab is added in the first phase, the benefit is higher. And there are also research on HER2 treatments. There was Heracles and My Pathway. Median survivals were 10 to 14 months. And there was a research called Destiny CRC01 trial. And in this trial, primary endpoint was higher, and the survival of the patients in this section was 6 to 10 months. And when we look at the side effects, interstitial lung disease was higher. This is another research about tucatinib and trastuzumab, and this was an interesting research. Trastuzumab was added to tucatinib, and this was tried on patients who used these treatments. The survival was up more than 8 months, and the median survival rates were higher. It seems like it will become the standard soon, and we can say the rates are up to 40%. There was no specific serious side effect. And I would like to add one more thing about BRAF mutation. The prevalence are 8 to 12%. These are usually female patients, and on the right side of the column, and the prognosis are very negative. And this was another research. It covers the combination of encorafenib and cetuximab. And when we look at the survival rates, the analysis showed that when encorafenib is combined with cetuximab and binimetinib, there was no significant improvement. And when we look at the objective response rates, they were confirmed with this research. The first line research, breakwater, this still continues. And for encorafenib was added with corexinabab, and this research is continuing right now. And there are also research about immune checkpoint blockade therapy in patients with colorectal therapy.
Sadece bunun birkaç
I would like to skip this part with a few slides. This was a study about the pembrolizumab. There's a survival benefit in the first section in this group. in the group MSI high group. For the MSI high group, this is recommended. And there was another research called Checkmate 143. The impact objective response of imectibab was more than 100%. And one of the latest developments in the field, CRAS, there are two agents. First one is adagrasib. The phase 1 and phase 2 results are positive. And there's another research, Crystal 1 and CRAS, and the research continues about this. Thank you for your attention.
We are later in the time. I think we let a question after the final of topic. Thank you. We invite Dr. Ahmed.
Meme. Sayın Başkan, değerli katılımcılar, bugün bana ayrılan sürede meme kanserine yaklaşımda tarihten modern onkolojik tedavilere doğru bir pencere açmaya çalışacağım. Meme kanserinden ilk defa M.Ö. 1600'de Edwin Smith papirüsünde Antik Mısır'da bahsediliyor. Meme dokunulamayacak kadar şiş, kızarık, tır diye tarifleniyor ve dağlanması veya bir an önce kesip çıkarılmasının iyi olacağından bahsediliyor. 10. yüzyılda İbn Sina meme kanseri cerrahisinde ilk aletleri kullanıyor. İzleyen dönemde 13. 14. yüzyıllarda Fransızlar meme kanseri cerrahisi üzerine bir şeyler yapmaya çalışıyorlar. 19. yüzyılda anestezinin devreye girmesiyle radikal mastektomi operasyonu ilk defa Amerika'da William Halsted yapıyor ve çok kısa bir süre sonra da Dr. Cemil Topuzlu bu operasyonu gerçekleştiriyor. Yüzyıllarca tek tedavi cerrahi ta ki 1900
For hundreds of years, it was just one treatment, and the breast cancer treatments course is changing, and we were using some non-specific oncological agents in the beginning, but in 1964, Elwood Jensen finds estrogen receptor, and in 1969, Mary Cole had received a response for tamoxifen in breast cancer patients, which was previously used for birth control. And here we can look at the epidemiology. It is the second most frequent cancer in the general ranking, and it is most frequent cancer among females, and this is the most frequent cancer, the second most frequent cancer, which causes death among women, and postmenopausal age, female sex, benign breast diseases, experience, sedentary life, obesity, family history, ionized radiation, cigarettes, and alcohol increase the risk of breast cancer. And genetics is the risk factor which increases the risk as a standalone factor, and it has family history important. Family history is important, and it might happen before the age of 45 years old. Early onset breast cancer, we can think about genetics and BRCA. In clinic, we can have oozing or asymmetries or retraction of the nipples, and half of the breast cancers are happening in the upper outer quadrant of the breast. And clinical breast examination is the golden standard, is the basic instrument for us, and we use mammography, and its sensitivity and specificity is increased. And for breast ultrasonography, we can only find 4 patients out of 1,000 patients, and breast MRI can be used for risky groups, for genetic patients, radiation with those with radiation history, or advanced evaluation. Let's roughly summarize the stages of the breast cancer. We have the non-invasive part. The first stage is the tumor is lower than 2 centimeters, and the second is the tumor is lower than 5 centimeters. And we have the multicentric primary and advanced axillary involvement. And then in the fourth stage, we're talking about the distant metastatic disease. And we use mammography, breast ultrasonography, and breast MRI. And if the patient has a triple negative disease, and if HER2 is positive in those patients, and if the tumor is longer than 2 centimeters, we can use tomography and PET-CT for the staging of the disease. And the type morphology is understood with the biopsy, but the most important thing here is the estrogen receptors and progesterone receptors. And the treatment and the prognosis is determined by looking at those things. And we have cell line subtypes, and we have luminal B or luminal A. Luminal A and luminal B had better prognosis, and then if HER2 is positive, then we go towards worse prognosis, and we also have the triple negatives, which are the most aggressive ones. Let's talk about the treatment. So we have early stage, local, advanced, metastatic treatment. We have surgical radiotherapy and medical oncologic therapies. Surgery, I will just talk about surgery on general terms. We can have skin sparing mastectomies, nipple sparing mastectomy, basic mastectomy, modified radical mastectomy, oncoplastic breast surgery. We can talk about different types. Now I will talk about radiotherapy. We are generally using it as an adjuvant therapy for breast sparing surgery, and axillary therapy, lymph node field is treated, and it can be used for palliative treatment, medical oncologic treatment. We use neoadjuvant systemic treatments and palliative treatments. These are the 3 different types. We can use endocrine targeted treatments, HER2 targeted treatments, other targeted treatments, and cytotoxic chemotherapies and immunotherapy. Before the operation, we try to shrink the disease. This is called neoadjuvant therapy. Inoperable or in local advanced tumors, it can be used if there is inflammatory breast cancer, if there is CN2, CN3 tumors and T4 tumors, and inoperable tumors where we try to make the patient suitable for the breast sparing surgery, and neoadjuvant therapy if there's a subgroup which has a higher possibility to respond to the neoadjuvant. And when we have a good response, we can think about a cure. And adjuvant therapy is used after the operation. We consider the age, comorbidities of the patient, and pathological findings, and we try to remove microresiduals, and we try to increase the general overall survival and disease-free survival. We can use adriamycin, cyclophosphamide, docetaxel, or platins. Other agents can be used in a non-specific way in the systemic treatment of the breast cancer. You can see the endocrine-targeted treatments in the beginning of the 1990s. We started to use this therapy randomly with a coincidence, and then we start with tamoxifen. And we continue with the leuprolide, ovarian ablation agent, and then we have docetaxel and aromatase inhibitor that is synthesizing estrogen from fat tissue. It is inhibiting this and in endocrine cascade. We have this hormonal effect, and breast cancer is proliferated, and the mTOR pathway inhibition is done by everolimus, and we have CDK4/6 inhibitors. These are effective in terms of endocrine resistance, and they can be used in the endocrine treatment naive patients. And we have BRCA mutation hormone positive group, and we are using PARP inhibitors, olapolip, talazopolip. These are used, and for estrogen receptor regulators are combined with them, and PI3 kinase pathway inhibitors are used, and endocrine. These are the endocrine targeted treatments. We have HER2 targeted treatments. These clinical styles date back 1930s, but in 1993 we started to use a monoclonal antibody, and HER2 was quite aggressive. It was a short-term cancer type, and and then things started to change. We were able to treat those patients in 2007. The tyrosine kinase inhibitor HER2 affected lapatinib was put into market, and then we have another antibody. And in 2013 we started to work on different conjugates, and atotrastimab enhancing TDM1 started to be used. Then tyrosine kinase inhibitors were started to be used in 2016, and neratinib was used in 2019. Deristecam and trastuzumab was combined, and we had dramatic benefits from these HER2 patients. And now this agent is changing the practice, and ticatinib was also beneficial. And HER2 targeted treatments are quite dynamic, and their number is increasing, and guideline will be updated in the upcoming days about the HER2 targeted treatments. What we would do in the breast about these targeted treatments, we have other different instruments like immunotherapy. Immunotherapy can be used in different breast cancers, and it is also used for the triple negative group especially. And we have dendritic cell vaccinations or cell treatments. There are early studies about that, about these things. Endocrine can be used and combined with other molecular pathways and other biomarker target treatments. We have numerous trials that are still ongoing. I want to talk about our treatment approach, luminal A-type early stage tumors. For its division index is low, as we don't give statistic chemotherapy for these patients because it is not beneficial. It is not useful. In the last decade, we try to understand which group is not benefiting from this, and we looked at this gene signatures, and there are different genes who were studied, and based on these gene signatures, we try to understand the risks of the tumor. And for the low-risk tumors, we start endocrine therapies for those patients. Hormone positive HER2 advanced disease, we have inhibitors, new inhibitors, CDK4/6 inhibitors, and now this is a turning point, actually milestone. They improved survival. First, they were tried in the endocrine resistant groups, but then we saw the dramatic benefits, and then they started to be the first line therapy. And we know that hormone positive HER2 negative patients can have visceral crisis, or the tumor load may be really high. But if we use CDK4/6 inhibitors and endocrine combination, triple combination, this will be better, superior to statistic chemotherapies. We know that. And in localized HER2 positive disease, We used neoadjuvant therapies, and before the surgery, in our clinical practice, we have a certain combination transplant and chemotherapy combination, and these patients with these therapies, we are able to remove the tumor, and we also use anti-HER2 the therapies, and we can use conjugates, and in advanced stage HER2 disease, we can use new for the next generation agents, and guidelines are repeatedly updated. Transplant conjugate. So we have different combinations right now. These are all new agents, and they have significant efficacy. Hormone negative, HER2 negative. So this is triple negative. So for this patient, we were using stochastic chemotherapy. We didn't have any other way. And in 2010s, BRCA germline mutation was researched, and platinum group cytoxins found to be more beneficial in these kind of patients. Olaparib, talozoparib, BRCA mutation, the PARP inhibitors started to be used in the treatment of triple negative patients, and in the immunotherapy age, in the triple negative disease, we have neoadjuvant and the localized diseases and metastatic diseases, and PD-L1 positivity analysis is checked, and if it is positive, bir dakikanız var sadece. I will summarize the biomarker targeted treatments, PARP inhibitors, TNBC, or when alpelisib can be used. When PD-L1 is positive, we can, if we have the tumor mutational burden high, we can use immunotherapies. Therapies. If there is an anti-RK fusions, we can use entrectinib. So the number is increasing, and we have a large medical oncological portfolio, and it would be updated frequently. We need to increase the awareness about breast cancer, and self-examination of the breasts is important, and awareness should be increased. And we need to have a multidisciplinary approach, and ER, PR, and HER2 situations should be evaluated, and need next generation endocrine treatments look like they will prevail in the future when compared with the other types of treatments. And immunotherapy can be used especially for the triple negative disease, and when we are selecting the treatment, we can select the next generation biomarkers, and their prognostic values are increasing day by day. Thank you very much.
We invite Professor Dr. Fanda Atalay.
Hepinize bu öğleden sonra
I would like to welcome you all. And I would like to thank the organizing committee for giving me the opportunity to make a speech in this meeting. I will talk about the cervical cancer. According to 2020 data, cervix cancer is the fourth most frequent cancer in the world. And similarly, in addition to this, when we look at the mortality, it is also the fourth most frequent cancer which causes death. In all cancer cases, its frequency, its ranking is 7, and it is the fourth most frequent cancers among women, and it is generally experienced in least developed countries, and the mortality risk is also highest in those least developed countries. When we look at this table, look at this chart, you can see that in sub-Saharan Africa and Central America, it is really frequent, and mortality and the deaths are mainly higher in Africa and Central America. And you can see its incidence and the mortality risks as a whole, as you can see, among female cancers in terms of incidence and in terms of mortality, cervical cancer is ranking the fourth. And all around the world, according to the 2020 data, annually we expect to have about 4,000 new cancer cases, and almost half of them, more than half of them, is ending with death. 84% of these cases are happening in least developed countries, and in least developed countries, the second cervical cancer is the most frequent second cancer type among women. And when we look at the death reasons among women, it has a really important ranking. In Africa continent and in Central America, it is main reason of the cancer-specific deaths. Let's look at the distribution between world and other countries. Cervix cancer is not among the first 5 cancers in Turkey. In the world, it is ranking the 4th in terms of frequency. In the United States and in Western Asia, it is not in the first 5, but in Central Europe and Eastern Europe, it is among the first 5. When we look at the data of our country, the cervix cancer is ranking the 9th among the female cancers. And more than half of them are caught in the early stage, and 10% of them approximately has distant metastasis. So, as I said before, cervix cancer is ranking the 9th among the female cancers in Turkey, and its main factor is HPV, and it is less frequent in our country, but according to the analysis conducted by the International Cancer Research Agency, cancers related to HPV is responsible for 1% of the males and 5 or 10% of female cancers. And when we look at the data in our country, we have similar results, and female cancers possibility is 5 times higher because of HPV. Let's look at risk factors. Cigarette, multiple partners, multiple births, early age, sexual relation, but the most important factor is human papillomavirus infection. We all know that, and this is responsible approximately for 70% of these cancers. HPV and cervical cancer has a time period. It takes some years. It takes 2 years. Sometimes it regressed by itself, but most important ones are the persistent or progressed groups. In persistent group, we have about a 15-year process, and it can go from pre-invasive lesions towards cancer. And what about the cancers related to HPV? Annually, we have about 500,000 cases in females, and more than 90% of them, of those cancers, are cervical cancers. What about the factor and cancer relations? So what is the relation between cervix or HPV, hepatitis B, and liver cancer? We compared that. So HPV is a significantly higher risk. And you can see the HPV-related cancers, and most of them are cervical cancers. 5% of the cancers in all around the world, and 10% of the female cancers in all around the world. And it is the factor which has the highest correlation with cancer. HPV has about 140 different subtypes, and in cervical cancers, we have 15 different strands. They are high risk strands. These are HPV 6, 11, 16, 18, 31, 33, 45, 52, and 58. They are responsible for 90% of these cases. And sometimes we see adenocancers, and 16 and 18 are responsible for the 70% of the cervical cancers. Why is cervical cancer important? Of course, all cancers are important, but there are many important factors here because it can be prevented. And when it is diagnosed, it is treatable, 100% treatable. When it is treated early, the mortality can be totally prevented. Its pathogenesis is quite clear, totally cleared, and it takes a long time for this disease to turn into a cancer. And if we catch this before in the right time, we can save those patients. So cervix cancer is preventable, as I said, but how can we prevent it? It can be prevented in two ways: primary precautions, and secondary precautions. First one is protective prophylactic vaccination, and the second one is detection of the disease. And we have treatment and pre-cancer treatment and screening. So this is a rare cancer type which can be diagnosed or screened earlier. Why are we screening the cervical cancer? We want to decrease the mortality. We want to decrease the number of the patients which are referred to colposcopy, and we want to decrease the number of unnecessary interventions. So this is why we do cervical cancer screening. And you can see the example of UK in 1985. United Kingdom started national screening programs, and in about 8-10 years we can see the incidence is lowered significantly. In the UK is a great example. Another example is comparison between the countries which do screening and which do not. The green one is not conducting cervical screening, and you can see the high rate of cervical cancer. And in the other countries where screening is conducted, you can see the rate is significantly declined. And it is a frequent experience cancer, and if its mortality and morbidity is high, we need to, and we also have the treatment capacity treatment options. The test procedures should be acceptable, and it should be safer. So for these kind of cancers, the World Health Organization recommends screening for us. So that is suitable. Cervical cancer is suitable. In 1992, we started to use the cervical smear, and for more than 20 years, only 20% of the female population is screened. What is the reason for this? What is the problem here? The target population is high. We are talking about a population more than 15 million, and the people should be experts, and they should be specialists, and we need to have pathologists. There are some problems about human resources, and awareness is another problem. Geographic limitations is another reason, and quality control is one of the reasons, because pathologists checking, and they are making different comments for the same preparate. And for this reason, this screening program was not quite successful. But in 2012, we had a change in the strategy, and they decided to do this primary screening with HPV. And it is more rational because it has high sensitivity and high negative predictive value. It has an advantage of human resources and central quality control and automation. It can be used for the follow-up, and the results of the screenings can be gathered faster. And these screenings are done in ketams, and in every province there is at least one ketam. And as of 2020, as of the end of 2020, the number of ketam in Turkey is 244. Our number of provinces is 81. So in those centers, we have trained doctors, nurses, midwives, or X-ray technicians, or medical technologists. We sometimes invite our patients and do the screening. So how do we do this, and to whom do we do this? If HPV is positive, we also use a smear test too. Our target group is women between the ages of 30 to 65, and the screening spectrum is 5 years. You can see that. We also have the colon cancer and breast cancer screenings in ketams. I said before, we screen women between the ages of 30 to 65. We do this every 5 years. We are using HPV DNA profiling test, and if it is positive, we are using smear tests. And this is the summary of the program. We check the HPV, and if it is negative, we accept it as a normal, and we have screened them for every 5 years. And if the smear is abnormal, we refer them to obstetrician, and we refer them for colposcopy. And which type of HPV is positive is checked. If it is high risk, if it is like HPV 16, 18, we also refer them to the obstetricians, the gynecologists. And if HPV 16 to 18 is negative, we repeat the test 1 year later, and we follow up the patients. And if the specimen is not sufficient, then we repeat it 3 months later. So what are the other protection methods? HPV vaccines. Cervical cancer can be prevented, is actually the first only cancer that can be prevented by vaccination. It has a virus-like particle. It doesn't include DNA. It doesn't cause infection. It is not oncogenic, and it has a very strong immunogenic effect. Now we have 3 vaccines: bivalent, quadrivalent, and nonavalent HPV vaccines. We have only Cervarix, which is effective only for the 16 and 18 types, and for quadrivalent HPV vaccination, it is also effective for the 6 and 11 types. And we also have the nonavalent HPV vaccination, which is new. It is newly used in the world, and as far as I know, it has just arrived in our country, and this can be used for other 5 types too.
Aşılar
The vaccines are approved in 132 countries. In some countries, the males are also vaccinated, and in 87 countries, it is in the national program. You can see the effects, and you can see 10-year real-life data. It decreases the cervical lesions with low risks, and we vaccinate 11 to 12-year-olds, boys and girls, and preferably before the sexual relations start. And catch-up vaccination can be done between the ages of 13 and 26. And for all 3 doses, we don't have an upper threshold for women. We don't need a repetition dose, refreshment dose, but single dose is not sufficient. Should we continue screening? We should continue screening even though we have vaccination, because HPV does not because the vaccine does not protect from all types of HPV. There's something international. There's some important international popular society in Australia said that they will be the first country to eradicate the cervical cancer because in 2016 about 78% of females of girls and 72% of boys have been vaccinated, and HPV incidence is decreased. So I will talk about the treatments in a very short sentence.
Evrelere göre
Treatment depends on the stage of the cancer. In early stages, surgical treatment can be used, but in advanced stages, chemotherapy and adjuvant therapy may be necessary. Surgical therapy is more effective than radiation therapy in early stage cervical cancer cases if there are no local post-stage treatment is not available. Other treatment options are used. So how do we treat the patient? Fertility decision is indicative. And chemoradiation therapy and non-adjuvant chemotherapy and radiation therapy combination is still being researched, and in the future maybe we can get better results with the combination of non-adjuvant and radiation therapy. What are the new approaches in treatment? Radical tracheotomy, PLND, and there are new approaches such as minimal invasive treatments. There are infertility protecting surgical therapy, colonization and simple tracheotomy and PLND can be used, or chemotherapy, colonization, tracheotomy and PLND also may be combined. And there are new treatment options such as radiation oncology, and as I mentioned, chemotherapy combinations with different treatments are possible. According to World Health Organization, our hope is to vaccinate 90% of girls with HPV vaccine. We will screen 70% of women using a high-performance test, and 90% of women identified with cervical disease will be treated. And these are the targets of the WHO by 2030. Thank you so much for listening to me.
Fanda, for this valuable information. We invite Dr. Tarkan. We will ask you about lung cancer, inshallah.
Herkese merhaba. Öncelikle
Hello, everyone. I would like to thank the organizing team of the Congress for inviting me here. My subject is the lung cancer. I will try to summarize briefly the overview of epidemiology, etiology, histopathology, classification, symptoms, clinical findings, and diagnosis. In epidemiology, as in the rest of the world, lung cancer is the type of cancer that causes the highest number of deaths. And in Turkey, it is the first most common in males and the fifth most common in females. But the number of cases are the highest in both sexes. Almost half of the lung cancer patients are identified in later stages. 1 in every 4 patients can be identified, diagnosed in early stages. About 15% of the lung cancer patients live for 5 years, and 90% of all lung cancer cases are related to smoking. You can see the total number of deaths from lung cancer are make up for the 5% of all deaths. Here, life lost first 10 years, and the first reason is the ischemic heart disease. The second one is stroke, and the third one is tracheal, bronchial, and lung cancers. So it is like an infectious disease. It keeps increasing. The number of cases are increasing. 90% of them are related to smoking, and there are other situations that are related to lung cancer, such as COPD, IPF, and there are other chronic diseases that cause risk factors for lung disease. And histopathological classification of epidemiological tumors are here, and there are smaller cell types such as metastatic lymphohistiocytic tumors and ectopic tumors. Of course, the symptoms are important in lung cancer. Coughs are always present in upper respiratory system illnesses, but most of the time we don't attach much importance to cough because it always happens in respiratory diseases. But in lung cancer, one significant symptom is the weight loss. And if there's a shortness of breath that is not caused by any other illness, that is an indicator, and there are other symptoms such as body aches. And there are regional, local symptoms, pleural pericardial effusion, and there's chest pain, and the pain on the sides of the chest, and shortness of breath can be symptoms of, and there's also loss of voice. And there may be a difficulty of swallowing and arrhythmia in tumors near the heart can be seen. And there are also symptoms that may be related to metastasis. These are hepatitis, stomach pain, headache, and dizziness. There are also other symptoms caused by the agents the tumor itself causes. In diagnosis of the lung cancer, there are different instruments that we can use. Some of them are conventional PA and lateral graphics of the lung. And recently, there are more computerized tomographies are available, and a lot of patients come to us after being diagnosed with thorax imaging. We can see an X-ray of a lung. You can see the right side is normal, but the left part is just white. Tracheal column is moved to the left side. This is another X-ray. There's an increase of density depending on what's going on the right side. This is probably caused by the fluid on the left lung. This is a lung cancer patient. We can see that there's a loss of volume on the left lung, and this was identified bronchoscopically. And on the left side, there is a apparent lesion. This is a lung tumor. Sometimes it appears as an apical catch, but it is really apparent. There is a tomographic imaging on the left side, you can see that there's a tumor on the chest, thoracic left side. Here on this image, there's a lesion. On the left side, we detected this with tomography. This is a bit different from the other ones. There's not a specific tumor, but there are lines, interlobule thickening. These are the lymphangitic spread of the tumor. And not only in lung cancer, but we can see this in different types of cancers which spread to the lungs. And on the X-ray of the lung, we can't see any apparent symptom on the left side, but with tomography, we can see that the lesion is hidden behind the heart. The computerized thorax tomography should be done with contrast, and it should cover the upper abdomen too, and it gives us information about the size of the tumor, anatomic localization, nodal hold, and pleura, and it gives us information about adrenal metastases, post-obstructive situations. Bronchoscopy is very commonly used by the thoracic experts, and we can see the bending characteristics of the bronchial tree to 5 to 6 branches, and diagnosis is not very successful in tumors smaller than 3 centimeters, and if they are small and peripheral tumors, then we prefer aspiration imaging. PET scans are very common. They have become common recently. The metabolic activity of the lung cancer cells are really high, and with this method, we can identify the glucose high areas. You can see it on the right side. Not only this, but the glucose uptake increases if there's inflammation or infection, and we can not only diagnose the patients with cancer based on this PET scan. Pathological diagnosis is necessary. It's, of course, it may not be a different type of carcinoid tumors, uncontrolled diabetes, necrosis. So in normal, regular tomography is 10 millimeters of axis, the sensitivity from 57% to 61%, and specificity is between 79% to 82%. But in PET scan, the sensitivity may be higher, up to 96%. We also use EBUS, such as bronchoscopy, and we enter the body with this device. It is similar to bronchoscopy, and we can see the lymph nodes, we can see the tumors, the mass, if it's near the area where we located the device. And this is very valuable information for the diagnosis. If we cannot reach the tumor directly, and if it is near the thoracic wall, it's hidden, then we can use a transthoracic biopsy. Thoracentesis is very valuable for us. It is not, there are a good pathologist taking a sample of 20 to 40 milliliters of samples may have 80% correction level diagnosis. And there's a classification of tumors. If the tumor is 3 centimeters or smaller, it's called T1. And if there's invasion and if there's pneumonia, we can consider it 2 millimeters. And if the tumor is bigger than 3 centimeters and smaller than 5 centimeters, if there are different separate nodules in the area, then it is called T3. And if the tumor is bigger than 5 centimeters and smaller than 7 centimeters, and if there are separate nodules in the lobes, and it's called T4. If there are regional lymph nodes that cannot be identified, there's no lymph node metastasis, it's called N0. If there's metastasis in another organ, we used to call them all N1, but there are new classifications now. These are relevant to the survival chance of the patient. So this is a long list of classifications. We can say that after stage 3B, the patient has a low chance of survival by surgery. Of course, it depends on the organ. Even in stage 4, we don't have any chance of saving the patients with surgery, but we should do the evaluation based on the stage.
Tarkan, and I thank all doctors for their valuable information provided in their presentation. Dr. Adem, online, he's online. If he have any...
Evet, Doktor Muhammed Gerbi'ye çok
I would like to thank Dr. Muhammed Gerbi. This was very interesting. I met you before in different events. I am glad to see you here today. I don't know if we have time, but if we can have time, maybe we can ask questions. I would like to ask a question myself.
Tamam o zaman.
Thank you very much. Thank you very much to all participants. Thank you.
Audience, if you have any questions about this different type of topic.
Soru soran yok hocam.
No questions. But
vaccination of cervical cancer. At what age you beginning vaccination for the ladies?
Biraz önce de söylemiştim 11.
I just mentioned WHO recommends that European Medical Agency also recommends that it should be done between 11 and 13 years of age. This is the recommendation. But there is no age limit. It can be done as an atonement vaccination between 13 to 26. It can be also done for the male young people. Our minister promised that HPV will be included in the national vaccination program soon. We don't have an age limit. Any woman Well, mainly it's between 11 to 13 years of age, like all other children's vaccination. The schedule is between 11 and 13 for HPV.
هو معتمد في
It is not obligatory. It is not mandatory.
cervical screening. You do for cervical screening, frotty, FCV.
Smear? Yes. Biz smear testi.
We used to do the screening with pap smear tests, but now we have the HPV tests in our national screening program. Of course, gynecologists at private or public hospitals, they can also screen the patient with smear. If we do the screening with smear, we do it every 3 years. If we do it with HPV testing, we do it every 5 years. In our national screening program, we screen the patients at CATAMs, at family health care centers. We do this with HPV screening. But other than that, if we identify anything in smear, we do that too.
Sizden kopya çekmek için yani. هي في المراكز التي تتبع للدولة تقريبا هناك برامج يعني على في كل المدن وفي كل المؤسسات، لكن بالنسبة لك في المؤسسة التي
He's a gynecologist himself, so he wants to get that information from you.
الله يسلمك الآخر. Şimdi Adem hocam şey geldi.
We have Dr. Öztürk here. You can ask your question, Mr. Adem. Thank you very much, all participants. This was a fruitful Congress. I would like to thank everyone who made a contribution. Öztürk Ateş is here if you want to ask your question. Oh, here is my question. Treatment protocols have been changing, especially for those with lung cancer metastasis. What are the most up-to-date approaches? Thank you for the question. In our routine application, metastatic patients who are not available for the local treatments, we plan systemic treatments. Depending on the options we have, we do the genomic analysis, and we try to add other treatment options in addition to chemotherapy. I tried to mention them in my presentation. It starts with Prof and it continues with different types of treatments. And we plan our treatment depending on the location of the tumor, left or right. And if the patient is good for the local treatment, then we can also use them as booster treatments. Thank you.
I thank all presence. Inshallah, I think we have a break now. Shukran. Assalamu alaikum.
Mic test. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. We're going to proceed with our next session regarding current affairs in oncology in the world and Turkey. So our first speaker will be Professor Dr. Halil Bazar from Ankara Oncology Training and Research Hospital. He will be talking about prostate cancer.
Şurada bana bir evet herkese merhaba.
Hello everyone. This afternoon we are gathered here and I'm really glad to see you here. I'm quite honored to see you there, and I would like to thank those who have come from abroad, from Palestine, from Libya, from Afghanistan, from Malaysia. We have our siblings, sisters and brothers with us. I would like to welcome you all. So this is the 7th Congress of World Islamic Health Society, and we're really honored to host you in Ankara. And I would like to thank the organizing committee for this reason. And now I will talk about prostate cancers, and diagnostic approach and treatment will be the main focus of my presentation. Prostate cancer is the cancer which is most frequent experienced in males. Prostate cancers are the most frequent cancers in males, and in all around the world, 1.3 million new cases are found, and we have more than 40,000 deaths annually. Its incidence in the world is changing from 10 to 70 in every 100,000, and in Turkey its incidence is 35 in 100,000. Since 1980s, there is the lifelong prostate cancer risk, and this risk increased from 8% to 18%. So in 1980s, maybe it was 8%, or we were finding it as at 8%, but now we have changed the criteria of diagnostics, and now this figure has reached up to 18% and get close to the real figure. And every 6 or 8 men has a prostate cancer risk for in their life course, and in most of the cases happen in males over the age of 65. What is the frequency of prostate cancer in the world? You can see this here. 26% is the prostate cancer frequency in the world. And in males, this is the first, one of the first ranking cancers. And for mortality, for estimated deaths, it is just following lung cancers. You can see the frequency of prostate cancer in North America, in Australia, in Baltic countries. Prostate cancer frequency is really high, and in South Asian countries and in Africa, its frequency is lower. And all around the world, cancer deaths are coming first as the reasons of death, and ischemic heart disease. And in its etiology, prostate cancer is complex and heterogeneous disease. Genetic and molecular structures are defining this heterogeneity, and some prostate cancers, while they are aggressive, most of them are non-aggressive. For this reason, we can distinguish them as low risk, high risk. And in prostate cancers, what are the proven risk factors? Advanced age, race, family history, and genetic predisposition. And as a secondary factor, lifestyle, nutrition, and environmental factors. So is it possible to prevent prostate cancer? We don't have any proven treatment for prostate cancer. As in all cancers, healthy nutrition is something we can think of for the prostate cancer. Mediterranean cuisine can be summarized as a cuisine which is rich in vegetables and fruits. So, should we have prostate cancer screening because it is a high frequency in the world? And should we do this screening for prostate cancer too? When we are talking about screening, we are talking about an asymptomatic population, and we are testing these patients. And prostate cancer is not generally showing symptoms almost until local advanced stage. So should we screen it? The indications are debated about the prostate cancer screening, but maybe risk population can be screened, they say, the guidelines say. But we should also know some basic information. One of them, in almost half of those diagnosed cases, we don't need treatments. And if we do not diagnose him, for example, the patient will continue his life without knowing that he has prostate cancer. And in only 1 or 2% of the diagnosed patients, the mortality reason is prostate cancer. This slide is summarizing it quite clearly. We have hundreds of people, and we are doing the screening. And how many of them dying because of prostate cancer? It is approximately 3% in this study. So when we are making a decision about the screening, we need to be aware of these realities. And let's look at the advantages and disadvantages. If we screen, we can catch the prostate cancer at an early stage, and metastatic disease rate will be lower, and we will be able to use a curative treatment for the patient. What are the disadvantages? First of all, yes, you're carrying a bomb, but this bomb will not explode. Should not be said to the patient. This is something which has a negative psychological impact on patients. And so screenings, this is one of the disadvantages of the screening. And there might be complications about the biopsy, like hematuria or bleeding in vacation, and over-diagnosis and over-treatment risk is also high. So who should we screen? We don't have an already accepted universal screening protocol, but as a general approach, if we say that if the life expectancy for the patient is higher than 15 years, then we can screen them. So should we also screen those people who are below the age 40? So the most frequently experienced age is between the ages of 55 and 69. So the screening should be done at those ages. So how it is done in Turkey, when they come to us at those ages, we want to increase the awareness of the family physicians. We have the World Prostate Cancer Day on the 15th of September, and we had a webinar and symposium. We invited family physicians from all parts of our country, and we informed them about PSA tests. We said that they should check the total PSA, and its cost is very low. In addition to this, for the patients at the age of 40 years old, if the PSA is higher than 1, we should follow up these patients. For this prostate-specific antigen, these 3 letters can save our lives. Why do we say that? Because the prostate check can be done by the rectal examination with fingers, but in the rectal examination, in the rectal touch, we can detect the cancer, but when we are able to detect it, it is already advanced, local advanced. So maybe with PSA, we can detect this cancer risk for this patient 3-4 years ago, 3-4 years before we can feel this with our rectal examination. So this is why it is used it is the most frequent tumor marker in the world. We are talking about overdiagnosis and overtreatment all the time, and it has a rationale. So in prostate cancer, we both experience overdiagnosis and overtreatment for the patients, and this is one of the most suitable cancer types for overdiagnosis and/or overtreatment. Almost 50% of those patients will be able to continue their own lives without having any symptoms. Maybe their reasons of mortality will be something totally different. But the important thing here is to find the clinically significant prostate cancers. We have clinically significant and clinically non-significant prostate cancers. We want to categorize them in this way. In prostate cancers, the most significant risk indicators, risk determinants, are age and genetics and race. When we do the biopsy, the tumor Gleason score is important, its stage is important, and the PSA. pre-stage level at this stage, we can understand the prognosis, we can estimate the prognosis of the patient. And prognosis is dependent on the age and general status of the patient, the stage of the tumor, PSA, and Gleason score. Metastatic involvement is generally happening in bones in 75% of the cases. So if we have prostate cancer and if we think that it is moderate and high risk, so we should first think about the full body bone scintigraphy scan. So the path to diagnosis, rectal examination, PSA, and we can also have biopsy, transrectal biopsy, ultrasound guided biopsy. So we have the diagnosis, we put the diagnosis, what kind of a treatment are we going to give? We don't have a consensus about this. However, we have some certain criteria. Here, we have something from Whitmore. When we need to understand whether is cure possible when it is necessary or is cure necessary when it is possible. These are two questions really important from Willem Whitmore Jr. about prostate cancer. Actually, this is an euphemism quotation from Willem Whitmore about prostate cancer. So let's say that there was a study in Scandinavia, and mortality reasons were quite different, and patients over the age of 70, they didn't use any treatment. So what are the accepted treatment, recognized treatment methods? Watchful waiting is recommended if the life expectancy is longer than 10 or 15 years. Then, if it is clinically non-important, we are recommending active observation, watchful waiting. We can have PSAs every 6 years or every 6 months, or we can have rectal examination every year. We can have biopsies every 2 years. So this is called watchful waiting. And in the treatment group, in the group which should be treated, of course, we are surgeons. And when you diagnose cancer, if it is localized, we need to take it out. We want the surgical excision as our first choice. But, however, if the patient cannot survive a surgical operation because of comorbidities, you can think about the radiotherapy option. And with or without them, you can think about hormonal therapy, chemotherapy too. So we need to adopt a patient-centered approach and multidisciplinary approach. So surgeon, medical oncologist, radiation oncologist can make a decision together about this. And the life expectancy of patients and sexual and general health status should be also considered. Is prostate cancer an end? So while we are saying that, we have the tortoise and the rabbit and bird. Why am I talking about that? Because it is like walking of the tortoise. But there are some cancers like abdominal cancer or lung cancer. You cannot delay the treatment. But for prostate cancer, even if you are delayed for a few months or for a year, can be tolerated because it is like a walk of a tortoise. Its progression is like that, very small, slow. And they conducted a study in 2009, and 10-year cancer-specific survival is about 95%. So this is a really high rate. And when it gets to the metastatic stage, we have 3.5 years chance of living. So, and I will try to summarize the optimal treatment options in prostate cancer and finalize my presentation. If it is localized cancer in prostate, if it is a low-risk cancer, and if the life expectancy lower than 10 years, we use watchful waiting method. And if it is higher than 10 years, then we have active monitoring. We can check PSA every 6 months, and we can have different, we can add biopsies to them, or if it is localized, or if it is low risk or high risk patient, our standard approach is radical prostatectomy. It is surgery, in other words, and if there are comorbidities of the patient, and or he doesn't want to have the operation, then we can think about radiotherapy, radiation therapy, and there are new approaches or developments. They are not, although they're not still in the guidelines, and they're not recommended as treatments. We can talk about cryotherapy and HIFU, high intensity focal ultrasound. This is started to be used in our country too. What about the advanced stage and metastatic disease? In the local advanced stage, metastatic, this is also a metastatic case, we can use hormone therapy, delayed hormone therapy. And we can add chemotherapy by looking at the Gleason score. If it is 4+4 and or higher than that, then this is a young patient, and we can directly start with chemotherapy. This is what is recommended by the guidelines because it increases the life expectancy. And radical prostatectomy operation. In this operation, multimodal therapy can be used. I use radical prostatectomy, adjuvant radiotherapy, and then hormone therapy, and I will add chemotherapy when necessary. So it will be a part of multimodal therapy. We can start with this, or radiotherapy is recommended, and if these are metastatic, we can think about adjuvant hormone therapies. And the hormone, when they are hormone sensitive, they can turn to hormone resistant, and we can continue our treatments by looking at all these issues. And 10-year cancer-specific survival is up to 80%. What is the position of metastatic local treatments? In some cancers, in glioblastoma or kidney cancers, tumor burden is decreased. So steroidective treatment is known to increase the life expectancy, and we use the stokin or chemokines as primary resources. And in these patients, they say that we can recommend surgery. And as urologists, we can think, we divide patients into two groups, oligometastatic, and when these patients are oligometastatic, we can use this surgery for the well-selected patients. The radical the prostatectomy has its positive impacts, and we have significant publications. So as a result, I will finish my presentation with this slide: overdiagnosis, overtreatment, and undertreatment. These are really important pits for us, and the cancer disease group, cancer cancer types are experiencing these three most frequently. For every 6 or 8 males, we have the chance to develop a prostate cancer after a certain age. We need to avoid overdiagnosis, and for this reason, we need to follow the optimal screening principles. If we are going to do this, we need to make some limitations. And for every prostate cancer treatment diagnosis, we don't need treatment. We can use watchful waiting, or active observation, active follow-up, and for the course, sometimes we're not able to detect the prognosis of the disease, and we have almost half of these patients which are followed actively can be referred to surgery in the first 5 years. And as a final sentences, I want to say that high risk advanced metastatic prostate cancer, if we have we cannot say we can say that I will select this treatment for this patient because of this reason or that reason.
Olarak radikal prostat terapi, radyoterapiyi öneririm. Çünkü diye başlayabilirsiniz. Prostat kanseri.
So prostate cancer,
Tanısal yaklaşımı ve
diagnostic approach and treatment approach is personal, is based on patients, individual, and it requires a multidisciplinary approach. So now I would like to end my presentation. Thank you.
Thank you very much, for a very enlightening speech and lecture. Now we go to the next speaker. The next speaker will be speaking about brain and nerve cell cancer. He is a multi-awarded neurologist, also treating brain cancer patients. He headed the encephalograph unit in medical center in the Philippines. So may we call on Moqtadir A. Kalbi online from the Philippines.
Assalamualaikum. Good afternoon. In Turkey, it's already 8 p.m. here in the Philippines, so good evening from the Philippines. First and foremost, I would like to thank the organizers for the opportunity to be speaking in this esteemed Muslim doctors around the world. So my topic for this afternoon is about brain tumor in adults. So for the outline of my talk, I will discuss the epidemiology of primary and metastatic tumors. I will also be touching on the clinical manifestation and zero in on neuroimaging features of different types of primary and metastatic tumor. More importantly, we will be discussing initial evaluation and the screening for systemic malignancy, the role of steroids, the indication for anti-seizure medication, and I will end my talk by sharing to you this treatment algorithm for brain tumor. So if we look at the epidemiology of brain tumor, although this is a US data, the incidence rate is around 30 per 100,000 person. And nervous system tumors are divided into primary tumor and metastatic tumor. So for primary tumor, the most common are meningiomas and glial tumors. These are your glioblastoma, astrocytoma, and oligodendroglioma. So it accounts for around 2/3 of all primary brain tumors in adults. Let us now look at the incidence of primary brain tumor versus metastatic tumors in different age groups. So if we look at adolescent and young adults, primary brain tumors are more common than metastatic tumors. But the opposite is true for older adults, 30 to 40 above, because metastatic brain tumors become increasingly prevalent. And of the malignant primary brain tumor, the most common is glioblastoma multiforme with a median age at diagnosis of 64 years. So in this graph here, it just would like to show that primary tumors are common in younger population, while as you age, 30 to 40 years old, malignancy or metastasis is more common. Let's now go to clinical manifestation. I think one of the most common is headache. It is present in up to 50% of patients. Usually they are dull, constant, but at times it can also be throbbing. It can be bifrontal in location and worse on the side of the tumor. Another important manifestation is seizure, and it is focal seizure. When we say focal, it's only the stiffening is only involving one side of the body. It is in fact the most common symptoms of primary and metastatic tumor. So seizure affect 50 to 80% of patients with primary brain tumor and 10 to 20% of patients with metastatic tumor. And among primary brain tumor, low-grade tumors are more likely to cause seizure than high-grade tumors. Another manifestation is focal deficit. When we say focal deficit, it can be right-sided weakness, it can be left facial asymmetry. This is due to tissue disruption or mass effect or vasogenic edema. Another very important manifestation that we need to extract if we are thinking that our patient has a suspected tumor is cognitive dysfunction, which includes memory problems, mood or personality problems, and it's really common in primary and even in metastatic brain tumors. And another thing to look for in the signs and symptoms are increased intracranial pressure. If you see this in your patient, you need to admit your patient right away. So increased ICP is secondary to a large tumor obstructing the CSF flow, causing hydrocephalus. The symptoms may be subtle, or it can give you the triad of headache, nausea, and papilledema. So to summarize neurologic presentations of brain tumors, it can be generalized, it can be generalized such as headache, seizure, signs of increased intracranial pressure or cognitive dysfunction, or it can be focal symptom, focal seizure, right-sided weakness, left hemisensory loss, aphasia, and some vicious facial dysfunction. So we all know that if you are suspecting brain tumor in your patient, neuroimaging is warranted. But the question now is, what is the neuroimaging of choice? Is it CT scan or MRI? So the recommendation is now suggesting that MRI with contrast is the optimal study, the optimal or the diagnostics of choice for the evaluation of tumor. The downside of CT scan, if you do it, it has a much lower soft tissue resolution. It cannot really describe very well the tissue of the brain and even the contrast enhancement and even the vasogenic edema. You only do CT scan during emergency situation and or if MRI is contraindicated. So CT scan is really a more detailed view of your bony structure with a lower soft tissue resolution. So again, the diagnostic of choice is an MRI with contrast. On my next slide, I will now be discussing neuroimaging features of different primary malignant brain tumors, metastatic brain tumors, and also a primary benign tumor. So let's start with high-grade glioma. When we say high-grade glioma, these are a primary malignant tumor which is highly aggressive. The characteristic tumor for this is your glioblastoma multiforme. So if you do MRI, no, with contrast, on T1 weighted, you see hypointensity. When we say hypointensity, there is a blackish discoloration on the affected brain. And when you do contrast, there is contrast enhancement of the tumor, and you really see the vasogenic edema. So the clue there for high-grade glioma, the tumor is only small, but you have a very big vasogenic edema, and there is ring enhancement. If you see rim enhancement with central necrosis, then probably that is a glioblastoma multiforme. What about low-grade glioma? This is also a malignant glioma but less aggressive. So if you do MRI, no, there is on T2 or on FLAIR, there is actually hyperintensity or whitish discoloration. And when you do contrast, there is actually no contrast enhancement or less, and there is also less vasogenic edema, or at times it can be absent. Although you see calcification in some low-grade glioma like your oligodendroglioma. So that is the difference between high-grade and low-grade. So high-grade glioma will give you big vasogenic edema, there is contrast enhancement, there is central necrosis. As opposed to your low-grade glioma, there's no contrast enhancement, vasogenic edema is absent. At times, there may be calcifications in low-grade glioma. Another highly aggressive primary tumor of the brain is your CNS lymphoma. It's a rare form, no, of non-Hodgkin lymphoma. There's also contrast enhancement when you give contrast. But the clue for CNS lymphoma is really the location of the tumor. So CNS lymphoma is suspected if you have an enhancing lesion in the periventricular area, so around the ventricles, or in the basal ganglia or subcortical structure, or you can also see CNS lymphoma in your corpus callosum, just above your ventricles. So if you see that and there's contrast enhancement, think of a primary CNS lymphoma. What about the characteristic of a brain metastasis? No? So usually, brain metastasis will also appear to be rounded, well circumscribed. There is contrast enhancement. Majority of your brain metastases are multiple, although it's single in 20 to 30%. And you really see necrosis, and you also see a big vasogenic edema. So that is how we consider brain metastasis as a cause of the tumor. And another very important, no, primary tumor, but this is of a benign type. This is a primary tumor of the brain which is benign. This is what we call meningioma. So from the word meningioma, it arises from the meninges. So it's outside the brain. It's actually in the dura. When you do MRI, it's extraaxial, so it's outside the brain. When you give contrast, it's contrast enhancing, and you really see dural tail. When you see dural tail, it's connected, or it arises from the dura. So though it is a benign tumor, you still need to refer this to a neurosurgeon. The tumor needs to be excised because, again, it's still a space-occupying lesion. So what do we do if we have a patient with suspected brain tumor? Then we do a complete history and urologic examination. You order for MRI with contrast, which is the diagnostics of choice. And the urgency of the referral to neurosurgery really depends on the stability of the patient, symptom severity, the tumor size, and the location. And this is very important, the need to screen the patient for systemic malignancy, because again, brain metastases are more common than primary brain tumor in adults. No? So if you suspect of a brain metastasis, then you need to do metastatic workup. And the best metastatic workup is actually chest CT scan, because the most common primary tumor that metastasizes to the brain, it's either lungs, breast, melanoma, renal cancer. So chest CT is high yield, while abdominal CT and pelvis CT is actually low yield. So these are the typical neuroimaging clues that the lesions may be metastatic. It's multiple, it can be single, but it's well circumscribed. It has a very big surrounding edema, and the involvement of the tumor, you see it parenchymally, you see it in the leptomeningeals, and even in the dura. So what about glucoids? No, glucocorticoids. So we give steroids, high dose steroids to improve edema. So how do we give it? It's 10 milligrams IV, followed by 4 milligrams every 6 hours, or 8 milligrams twice a day. You just have to taper it because, again, of the complication. And you don't need to give glucocorticoids if the symptom is minimal or if there's no associated edema. What about anti-seizure medication? It's only indicated if your patient presented with seizure. So if you are to give, levetiracetam is the best because it has no drug-drug interaction. So generally, it's not warranted for you to give prophylactic anti-seizure unless it's a perioperative prophylaxis in patients with craniotomy. So I'm on my last slides. I would like to end my talk by sharing to you this algorithm. So again, if you have brain tumor, then you need to do MRI. You need to exclude if this is a meningioma or not. Then if it's not meningioma, are you suspecting malignancy? If yes, do systemic or metastatic workup. If no, is this CNS lymphoma? If not, then probably you're dealing with a primary brain tumor. Then you need to refer this to a neurosurgeon and even to a radio-onco specialist and even an oncologist for possible radiation and even chemotherapy. So with that, shukran, and thank you very much for your kind attention.
Thank you very much, Dr. Moqtadir Kalbi from the Philippines. And now we will hear from Associate Professor Dr. Semi Bagsa from Ankara Oncology Training and Research Hospital. He will be talking about hematological cancers.
Herkese iyi akşamlar. Değerli katılımcılar ve misafirlerimiz, hepiniz hoş geldiniz. Oturun başkanım.
Hello, everyone. The session moderator, welcome, everyone. Today, I would like to tell you about the recent developments in hematologic cancers. As you may know, hematologic cancers are a very widespread area. Generally, this is the overview of my presentation, and then I will give you a message to take home. As you may know, hematologic cancers make up 10% of all cancers, and the incidence changes by the age significantly. In pediatric ages, acute lymphocytic leukemia are very common. However, in adults, non-Hodgkin lymphoma is the most common. When we look at the 5-year relative survival for malignant hematologic cancers, chronic lymphocytic leukemia, Hodgkin lymphoma, and acute myeloid leukemia changes, and acute myeloid leukemia is 20%. There are different subgroups of hematologic cancers. We will talk about leukemia, lymphoma, and multiple myeloma, and I will tell you about the recent developments regarding these types. In the beginning of this year, WHO made this classification. This was the 5th edition of the classification of hematolymphoid tumors. There are no differences in the major groups, but in the minor groups that are rare types of cancer, there have been some changes in diagnostic developments. I can talk about the next generation sequencing, MRD. It has become more and more common, and treatments are now planned with MRD-based systems, flow method, and with flow methods, deeper responses are received, and WBMR are more and more used. And there's a new system that is usually called in clinical trials. It's called mass spectrophotometry. And there is also liquid biopsy. And this is tested by the blood of the patient. It's also called circulating free DNA. And this is used in the follow-up of the patients. And in imaging systems, there is MRI, and it is recommended in many cases. There's new research regarding the MRI, but it's not WB MRI is not recommended for daily use. In 2022, there have been some updates in MLA treatment classification. Before, there was a classification of ELN 2022, and the Runexpert and ACXH groups are now considered as negative risk groups. In AML treatment, new agents have been developed in addition to the classical conventional treatments. Today, we use these new inhibitors, such as FLT3 inhibitors, midostaurin, and IDH inhibitors are also used as agents. Gemtuzumab is also used for leukemia as an antigen, and this is used in medium-risk patients. CPX351 is used in leukemia patients in sposomal combinations, oral azacitidine, and there's also BCL2 inhibitor is also used in treatment. These are new agents used in treatment. In acute lymphoblastic leukemia treatment, there are new developments, new agents. Blinatumomab is used for specific T cell engager. Inotuzumab is used for antigen T22, and it is used in the treatment of ALL. In the treatment of ALL, there are new molecular agents, and there are some new research. They combined inotuzumab with blinatumomab, and they combined hyper-CVAD with blinatumomab. And there's also the use of dasatinib and imatinib combinations for the treatment of ALL. And I will talk about the developments in treatment of KLL. If there is no treatment indication, We prefer monitoring the patient. We use the method wait and see. If there are large lymph nodes, combinations of new agents is recommended, and before the treatment begins, new combinations can be tried. TP53, DAL17P, or IGHV mutations. We can also consider the inhibitors, ibrutinib, acalabrutinib, zanubrutinib, and there are new agents, and their combinations are used more and more. Let's talk about chronic myeloid leukemia. As you may know, survival of such patients have been increased with the use of tyrosine inhibitors, but recently the trend is towards reducing them in molecular response giving patients, and 40% to 50% of such patients did not have relapse, and there's promising research on that. Of course, the patients do well with the treatment with this medicine, but should they use it for their lifetime? There's also another medicine called asciminib, and it's usually used in BCR-ABL1 inhibitors. In tyrosine kinase resistant patients, we can also use TCI and T315L mutations. In the treatment of Hodgkin lymphoma, we have been using ABVD for many years, but it may cause toxicity. So instead of that, there are research on combining AVD and brentuximab. And also in treatment, there are research on checkpoint inhibitors, such as anti-PD-1 inhibitors. In the treatment of non-Hodgkin lymphoma, RCHP is often recommended in treatment. Instead of this, combination of non-GCB inhibitors and R-CHOP in Bruton kinase inhibitors may be combined with R-CHOP, and in refractory therapy, there are grafitamab, epruxitamab, polatuzumab, and if there's relapse, we can use these medications for the treatment. In the treatment of follicular lymphoma, we prefer monitoring in non-symptomatic patients. And if there's treatment indications, we can use R or R-bendamustine, R-CHOP. In patients who have EZH2 mutation, we prefer tazemetostat. And these are the popular agents that is used in treatment. In multiple myeloma treatment, we prefer bortezomib-based treatments. And daratumumab treatments is mainly used because it targets the CD38 on myeloma surface. And in refractory therapy, BCMA targeting MAB, belantamab, or BCMA targeting BITE, such as teclistamab, are also commonly used. One of the most recent developments in CAR T cell treatment. The cancer types where CAR T cell treatment are used are acute lymphoblastic leukemia, lymphoma, DBBHL, follicular lymphoma, multiple myeloma. These are all autologous CAR T cells. For allogenic, there is no cell treatment that was approved by authorities. So my message for you today is conventional chemotherapies are less and less used by the experts. There are new agents that can be used for the elderly, older patients, and they can tolerate these treatments better. With the genetic identification and MRI follow-ups, we must identify specific treatments for the patient, so individualization of the treatment is important. And minimal residual illness-based treatment processes should be preferred, and CAR T treatments are preferred more and more for RR diseases, and we can find more information from clinical research, and I hope that the clinical research will continue. Thank you.
Thank you very much, Doctor. And now to talk about pediatric oncology, let's welcome Professor Dr. Nariman Sai of Bilkent City Hospital.
Sayın Başkan, değerli misafirler, hepiniz hoş geldiniz.
Welcome, everyone. I would like to tell you where we are in pediatric oncology. Pediatric cancers make up for a little percentage of all cancers.
Döneminde tanınan
Only 3,000 of them have their diagnosis during the childhood, and they compose of 2% of these cancers. So the pharmaceutical industry is not quite interested in this cancer type, but in the early childhood, they are one of the most important reasons for deaths, for mortality and infections, congenital heart diseases, and the accidents are followed by cancers in childhood era. And during adolescence, this rate is higher, and in every 100,000, it is 15. Its prevalence incidence is 15. And in between 15 and 39, we are talking about a separate age spectrum, and it is seen in every 80 patients in 100,000 patients. Every year, 400,000 children are diagnosed with cancer in the world. Unfortunately, they are not preventable, and it is not easy to have an early diagnosis with screening. Maybe we can talk about retinoblastoma as an exception, and 5-year general survival rate is over 70% in the recent years. So when the situation is like that, we have a patient group which survived the childhood cancers. This is an important group because they are suffering from late onset side effects of the cancer treatment, and so we have a high number of patients. This group is including many patients. You can see the cancer incidence in the world, and you can see the Global Can 2020 as it is in our country. In the developed countries, childhood age cancer rate is 15. in every 100,000. In Africa and South Asia, these rates are quite low. We don't know whether this cancer incidence is really low in those countries, but there are some studies, projection studies, and almost half of these real patients are not able to be diagnosed in those regions. And childhood cancer groups are different, and we also have embryonal tumors, and when the child is a little bit older, leukemias come into the picture, and we have non-central nervous system embryonal cases, and bone sarcomas come to the fore. Generally, leukemia and lymphoma, the success rate was up to 95%, and mortality speed was lower than 5.1. Was lowered to 2.2 from 5.1, and brain tumors were the most important that reason in all around the world. What about the prognosis? It is important for us, and the most important prognostic factor is the stage of the patient disease, and income level is an important part here. And we all know that these are World Health Organization's research. Only 30% of those patients in the low income countries have an access to cancer treatment. And in order to increase the life span and the life rates or survival rates, there are some studies. 5-year overall survival rates are over 70%. And we, as I said, this is a sensitive group, prognosis is not good, and we need to consider them separately because they have a different type of tumor. In addition to that, what are the most important prognostic factors? The location of the tumor and the possibility of debulking is important, and chemotherapy and radiotherapy sensitivity of the tumor and its molecular structure is also important. We are also checking the molecular structure of the tumor. It is different from grown-up cancers, and we have carcinomas in the grown-ups, and we also have genetic factors, immune sufficiencies, and childhood cancers. Almost all of the childhood cancers have high grades. They grow really fast, and we generally detect them at the stage 3 or stage 4. But we are luckier because embryonal tumors and sarcomas, they are sensitive to chemotherapy and radiotherapy, so the survival rates is higher than adults. And we need to say that the same histopathologic tumor can have a different course in children and adults, and they have different molecular structures. And all around the world, there are two large groups. One of them is the Child Oncology Group, COG, and we have many working protocol. And it was based in North America, and they got together and formed the Child Oncology Group. And they have many prospective studies, and in our daily lives, they are shedding light. The other group is European-based. They started to work in 1960s. It was established in France, and we have the European school and American school in the treatment of childhood cancers. Both of them are effective in the world, all parts of the world. They have branches in Australia or other places, and we are working actively in a European group and American group. The Turkish woman is the Secretary General of the CEOPS. In Turkey, we have Pediatric Hematology Society and Turk Pediatric Oncology Group. These two are working on the childhood cancers. One is established in 1997 and the other one was established in 1999. And I want to also talk about the Global Cancer Control Society. This is one of the largest groups working on cancer epidemiology, and Dr. Tezer Kutluk was the World Cancer Control, Global Cancer Control Organization chair between 2014 and 2016 from Hacettepe University. Professor Tezer Kutluk also worked on pediatric oncology, epidemiology. He is one of the prominent people in this sector, and since 2002, we are collecting cancer registry, and he is closely following these activities. When we look at these data in general, as also in all around the world, we can say that leukemias have the first rank in the childhood cancers. And in developing countries, we have developed lymphoma, the second part. And when we look at the developed countries, central nervous system tumors follow leukemia, and then it is followed by embryonal tumors and sarcoma. I want to talk about survival rates. Overall survival, 5-year overall survival rate is 90% in leukemia, and 80% of them are ALL, and infant ALL and MLL. MLL's prognosis bad, and in ALL, as I said before, 5 years overall survival is 90%, and minimal residual disease is one of the most important risks. And generally, 5 years survival rate is 78%. And when we look at the developed countries' data, they can be compared. And on the second line, we have lymphomas. Non-Hodgkin lymphoma is about 60% of it, and different from the adults, they have high grade. We rarely see low grade lymphoma. We use multimodal therapies, and 5 years survival rate, it goes up to 5 years, 70%, sorry. And target-oriented treatments are used as a first-line therapy, and 5-year survival rate is about 84%. Hodgkin lymphoma, it has the highest cure opportunity possibility as a malignancy. Over 95%. The most important problem is the late onset side effects. We are trying to decrease these late onset side effects, and risk groups. And in the risk groups, we use multimodal therapies, and radiotherapy is limited, especially for the low risk group patients. We've stopped using this, and we decrease the dosages, and we are not using these toxic drugs, and our survival rate is about the same with other developed countries. And we see low-grade gliomas more frequently, and high-risk gliomas. Its location is important, and we have high degree gliomas or medulloblastoma, and standard risk is about standard risk patients 3 years overall survival is about 80%, and in the standard risk patients CSI dosage decreased from 36 to 23. And in this group tumors, we can use molecules, and we can detect the molecular structure in these tumors, and we are able to use them. Even though it is not in the first primary healthcare, in the recurrent disease, we can use these monoclonal antibodies. And we also have neuroblastic tumors. So these are specific for childhood cancers, and it is And the survival rate is 95% in low risk group, but the most important risk group is high risk group. And autologous stem cell transplantation is used for high risk patients, and anti-GD2s are now started to be used in our country, and 2-year survival will be over 80%. Sarcomas are really important for us. We have rhabdomyosarcoma and non-rhabdomyosarcoma, it's soft tissue tumors. But this is, we have osteosarcoma, Ewing sarcoma, and 70% of them are non-metastatic and 20% are metastatic. And in the primary healthcare services, we use conventional therapies, but we are also using tyrosine kinase inhibitors. And in Ewing sarcoma, we are using autologous stem cells. And in all around the world, overall survival is lower in bone sarcoma cases. Rhabdomyosarcoma is risky because of the metastasis. And so for the metastatic patients, overall survival, 2-year overall survival is 40%. And if it is high-risk patient, then overall survival for 2 years is lower than 20%. And we can use ATK inhibitor, mTOR inhibitor, and NDRK inhibitors. And we are focusing on the target-oriented treatments. We are using tyrosine kinase inhibitors and the receptor pathways, and we are frequently using this in our country. But there is a difference when compared with adults. We're not able to use this for indication off-label. We're using them as off-label. We don't have the licenses, and we are collecting some approvals from the ministry, off-label approvals. But we have pathways, internucleus pathways, but there are hundreds trials, studies, but some of them only are reflected in the clinical trials, and then we modify our treatments. Immunotherapy is inspiring, is giving hope, giving us hope, especially for the children. But during childhood, we are not able to benefit from immunotherapy, especially for immunocontrol point inhibitors. And in our country, it is not mainly used other than lymphomas, because the childhood tumors genetic structure is totally different. In order for them to be useful, we should have neoantigen on the faces of many tumors cells, and their microstructure is quite different when compared with adult tumors. So immunotherapy is not receiving the response we expected, but still studies are still ongoing. CAR T cell treatments are still ongoing for children and also for adults. The ALL is the first one they're working, but of course it is not a routine treatment. And we have CAR T cell therapy. It is still ongoing. So thank you very much for attention. We are working in Ankara City Hospital, the Child Hematology and Oncology team, and these are the largest reference center in Turkey, and we are serving the whole country. And from Africa, from your Middle East, we have many patients, and we are trying to provide service to those patients. Thank you very much for attention, and I would like to thank the organizing committee for their kind invitation.
It is such a heartbreaking seeing the young ones, the children, being burdened with cancer. How good it is if they can just avoid this menace or prevent it from happening. Thank you for the enlightening speech. And the next speaker is from National University of Malaysia, Associate Professor Dr. Hisamuddin Pusrawi. He will be talking online about the challenges in developing holistic healthcare services, in particular cancer services in Malaysia.
Öncelikle bu güzel organizasyon.
First of all, I would like to thank you for this great organization. And I would like to thank the World Islamic.
To thank the organizing committee for having me this afternoon to give a talk on the said topic. This is a slide of Kuala Lumpur. KLCC used to be the tallest building in the world. Now, in 1997, the Ministry of Health Malaysia has actually embarked on telemedicine in trying to address the challenges in healthcare, as shown on the slide. Capitalizing the information technology and information era, the government has actually embarked on telemedicine, trying to shift the focus on treating sick patient to educating the public so that one can partake in healthcare activity. In doing so, we can prevent from developing illness at the early age. This slide depicts the integrated telehealth, which has got 4 components, namely lifetime health plan. Integrate to that is actually the MACFI, or mass customized public health information and education, with the other 2 components, namely teleconsultation and CME. Now, when a patient sees a healthcare provider, the data is actually captured by a collective system called CSS, which has got several subcomponents, namely health information system, lab information system, radiology information system, pharmacy information system, and so on. With that, the EMR and LHR are created. Now, whenever a patient goes to another healthcare facility, the LHR could be retrieved with the consent from the patient. Now, a healthcare giver at the point of care could actually have access to another healthcare provider if the need arises. He can also grab a CPG from the CME portal in trying to manage the patient as the first line doctor. Now, relevant information could be sent to the patient with the portal specific for public health information education system. Now, based on our experience in developing and deploying telehealth systems, we found that the most important thing in managing this case is actually the handling loss and policy, which unfortunately is not within our control. Yeah, without the proper regulation, laws and policies, it's impossible for us to run the operation smoothly. Now, these were some of the partners who were involved with us in developing and deploying the system, namely Sun Microsystem, which is not in the market anymore, IBM, Cisco, Oracle, and the rest. This is actually a tool that has been used to gauge the readiness of telehealth deployment. I won't go into the detail. Now, as I mentioned, the most important thing that we were not able to run the system outside of the pilot project was because of the legal framework. This is some of the activities that we were involved while and after implementing telemedicine, one of which is actually writing books in relation to that and consultancy work. Now, the challenges in healthcare today are many. I will touch a few because of the interest of time. Now, cybersecurity threats. Now, patients trust securely hold on to the personal data, including medical records, payment methods, unfortunately are at risk of cybersecurity attacks, and endangers all the data and reputation of healthcare center as being compromised. For example, in 2021, cyber attacks against healthcare centers tripled. 50 million people had their protected healthcare data breached, which led to costly shutdowns and erosion of the trust. There has been a rapid growth in telehealth, especially in the backdrop of COVID-19 transmission. Now, virtual visits peak, for example, in April 2020, 78 times higher than the prior rate compared to the previous time, and stabilize at about 38 times higher than usual. Now, patient experience is very important. The aim is to boost care outcomes, retention rates, and profitability as far as business is concerned. Now, when given favorable care experience, the patients are more likely to adhere to medical advice, better healthcare outcomes follow up, boosting patient retention and lowering malpractice rates. Now, cancer services in Malaysia. The most common causes of cancer are shown on the slide based on the sex. The most common for male is colorectal, followed by the lungs. For female, it's breast is number one, colorectal is second. Cancer figures among the leading causes of morbidity and mortality worldwide, with approximately 14 million new cases annually. There were 8.2 million cancer-related deaths in 2016. The number of new cases is expected to rise by about 70% over the next 2 decades or so. The prevalence of cancer is 234 per 100,000 population, and the actual estimated figure is about 70,000 new cases. There's been an increase in about 11% in new cancer cases and nearly 30% more deaths from cancer reported in the 2012 to 2016, based on the Malaysia National Cancer Registry report compared to 2007 to 2011. Currently, there are 6 Ministry of Health hospitals, 5 University Hospital, and at least 44 private hospitals with cancer facilities in Malaysia, and about 150 practicing oncologists. It's a map of Malaysia. Again, there are 3 states without cancer services, namely state of Pahang, state of Terengganu, and state of Perlis. Now, this slide shows my personal experience over the last 10 years or so in the 2 private Islamic hospitals, with a total number of patients under N18. The most common is general medicine. Of course, I'm also a medical consultant. Followed by the general hematology and the blood cancer. Now, consultation skills using the holistic approach. In 1984, doctors talking to patient by Berna and Long, and the consultation and approach to learning and teaching by Pendleton Group were published. These are some of the questions that being recommended. Number 1 is, why has the patient decided to consult? Number 2, what does the patient think is the problem? 3, what does the patient fear may be the problem? 4th is what is the patient hoping to achieve from the consultation? Now, the verbal and non-verbal exchanges that take place between doctor and patient affect both participants and can result in a range of positive and negative psychological reactions, including comfort, alarm, irritation, and resolve. It goes without saying, good listening and communication skills during the consultation are essential qualities for a doctor using a holistic approach. The British Association of Holistic Medicine and Healthcare, established in 1983, encourages the practice, and in fact they've got a journal of holistic healthcare which have been published 3 times a year, focuses on evidence-based holistic practice, and includes research and service development. Now, all healthcare providers should aspire to the practice of holistic medicine and try to practice it. It is also valuable and important guidance to be given to the patient. Patients tend to be more satisfied in this approach, and doctor takes an holistic approach, feeling that their doctor has time for them and their problems. Unlike in general practice, which they only spend about 10 minutes for each patient. Now, from the Islamic perspective, it's important to merge this as part of the Maqasid al-Sharia, protecting the faith, life, intellect, and lineage and wealth in the healthcare of the patient. Now, we have embarked, Pusawi, with the foundation trying to provide good quality healthcare for the cancer patients. And now this is a group of consultants involved in the project, and this is a group photo after the signing ceremony. And we are very focused about human capital development. We have monthly lectures. We have got daily seminars trying to promote healthcare, holistic healthcare services to the patients. This is a patient from Indonesia who just had the first cycle of treatment for multiple myeloma. He seems to be happy post-treatment and due to come back. This is a standard flow of healthcare services, which are pretty standard in the any given hospitals. One of the challenges that we have to balance is between the consumer affordability and provider sustainability. Now we are collaborating with HUKM in terms of getting the expertise to provide the cell therapy or bone marrow transplant. So we have the foundation giving the fund, and we have got expertise for us to share locally from the universities. And eventually we will be deploying oncology not only within the KL setup, but also some other vicinities. This is actually the equipment that we use for telemonitoring. As a conclusion, telehealth is an enabler to provide quality healthcare for all, which are affordable, accessible with a built-in holistic approach. We need to apply some of the checklists for telehealth readiness, ensure relevant regulatory measures are in place, for example, Telemedicine Act, Personal ID Act, etc. Telehealth network services can be developed into a national health schemes network and services. Holistic approach to medicine includes not just the body well-being, but also the close interrelation between the psychological, emotional, social, spiritual, and environmental state. Now, smart partnership with other key stakeholders, for example, in our case, with the funder or the philanthropists, and expertise from the local universities, plus also eventually our network in Australia could be deployed. Now, cancer patients or patients with chronic illness are likely to benefit most from holistic medicine. With that, I would like to thank you. Once again, thank you the organizing committee for having me to give the talk. And if there's any question, please send an email. I'll provide the email to the organizer. With that, I'd like to thank you, and salam alaikum from Kuala Lumpur.
Thank you very much, Dr. Pusrawi. So there you go. We are enlightened on prostate cancer, hematological cancer, pediatric oncology, as well as the holistic approaches in particular cancer services in Malaysia. So if you have questions, you can address the speaker. So if there are no questions, we can have a coffee break.
Evet, kongremizin ikinci gününün 8. oturumunda
In the second presentation of our session, we will focus on oncological care. During the past 2 days, we had participants from up to 90 countries and academicians and medical workers of several hospitals have attended us, and it was a broad session. And from cancer treatment to methodologies, we have covered subjects from different perspectives. Dr. Hamid will take the floor first. He is joining us online. Hamid Bey, you can go ahead.
At the penultimate session of this at the outset, I congratulate leaders, Dr. Kasim Jason, Dr. Ahmad Oral, Dr.
teknik sorun yaşıyoruz galiba.
We have a technical difficulty. We cannot hear you.
Lives were sacrificed because of this illness. Can you hear me?
Unfortunately, we can't hear you. We have a technical problem here, I think. Maybe it's because of the internet connection. Could you maybe sign out and sign back in? Maybe you can disconnect and connect to us again, because we can't hear you. There are disruptions in the audio. Dr. Hamid, could you please disconnect and connect to us again? Dr. Hamid is connecting to us from India. He's working in psychiatry. We cannot hear you.
Can you hear me?
We can hear you now.
You can hear me?
Yes, we can hear you now. We can hear you, Dr. Hamid.
Okay, now our topic is integrated care oncology, a very relevant topic. As you know, many of our nations and even in spite of all all the modern scientific advances, the early diagnosis techniques and technologies, many of them have less access to these facilities. So many of them are approaching this terminal cancer. So they are in misery, they are in agony, and they are facing, in spite of these small facilities, they are facing numerous problems. Besides the physical morbidities and physical symptoms, they have a lot of other issues, like financial issues, social issues, psychological issues, and a lot of other spiritual issues, etc. So actually palliative care means it doesn't intend to prolong life, but it wants to fill in life in the remaining days of the patient. So it requires an integrative approach. We are addressing the patient and also the family as a whole. The family, the children, their parents, his spouse, all are affected psychologically, also socially and financially. So we have to address it like a team. This is the main theme in palliative care. But how will we implement palliative care? And what are the various models being practiced in the various parts of the world? Today we are discussing practical methods of implementation of palliative care, and also the major issue in oncology is the psychological issues due to cancer. Some may be due to heterogenic, that is due to treatment, steroid withdrawal, there may be mood disorder, sometimes confusion, delirium, anxiety, depression, adjustment disorders, and several other psychological issues are affecting the person. Also the caregivers, they are also sleepless, they are also depressed, they are also anxious. These issues should be addressed in a comprehensive way, an integrated way. That is our topic. So also we have to give this care to their doorsteps, to their home. How we will organize this? So the implementation of palliative care, it's home care mode of implementation, this hospice care of mode of implementation, and also we are also intending to give psychosocial support to the patients and the families, and also assistive devices and nutrition support to the families. So we are coming to the topic. I invite our honorable speaker of this session, Professor Murat, who is a gynec oncologist, to handle the session of palliative care implementation. I'll also add some points about the palliative care and its neighborhood network in palliative care, and a unique model which my part of the world is practicing and is showcasing to the world. That I will tell in the end. Thank you.
Değerli meslektaşlarım, öncelikle bu güzel organizasyondan ötürü
Valuable colleagues, I would like to thank you for organizing this event and everyone working in the field. And I would like to thank World Muslim Health Society for their kind invitation. Currently in South Asia, India and 7 or 8 countries have come together to work on the cervical cancer and vaccination. And we are here for this event, so I could not join you personally there. I hope you can see my slides. I would like to talk about the palliative care, its philosophy, and I will talk about the project Palliaturk and I will give you updates on the current situation of the project. You can see my email address. You can contact me anytime. I'm a professor of gynecology, but I also worked as the head of cancer treatment department, and I worked towards improving the palliative care in Turkey. When I first heard about this, I was excited to talk about the philosophy of palliative care, and it lies in the heart of the Islamic culture. Unfortunately, we were not aware of how important palliative care is, but it lies beneath our culture, and we try to increase the comfort of the sick, of the elderly. So I am sad because Muslim countries should be leading the palliative care field globally. So what is palliative care? There are 8 or 9 different definitions, but WHO made a final definition. Palliative care is the early identification of all physical, psychosocial, and mental problems which risk patients and their family members. So not only the patients, but the patient's relatives should be included in the process. And the main thing that we must come over is the pain. There are different physical, psychosocial, and mental problems, but the pain comes first. It is the first problem to be solved so that the quality of life can be increased. All physical, psychosocial, and mental problems are targeted. So you can see on the charts, cancer treatment goes like this. It has been like this for 40 years. The diagnosis, treatment, chemotherapy, and then the cancer progresses, and if no more treatment is available, it leads to death. The WHO updated its definition of palliative care for this process. Palliative care should begin in the diagnosis stage. Not only during treatment, it continues even after the death of the patient. Healthcare services and the supportive hand of the state must reach the patient and the family even after death. For instance, I always give this example. Let's say a kid, 10 years old, 15 years old, with leukemia, and we lose the patient, and there are traumas that are left behind after the death of the child. Even 1 or 2 years after the death, such healthcare and support should continue. Here's a research done by Hawley in 21st century. Primary treatment of the illness may be lessened, but the palliative care, rehabilitation for those who can heal from the cancer, and palliative care for those who continue to be ill. Especially during the illnesses, especially during the fatal illnesses, there are many aspects that threaten the patients. There was a research that was conducted in Berlin, an ovarian cancer patient who was hospitalized for 20 days contacted hundreds of people, doctors, assistants, medical students. There are different kinds of contact points from different backgrounds. Of course, the patient has a diverse range of problems, not only the pain, there are psychological, psychosocial problems. But in Turkey, before 2000s, only one doctor was responsible for solving all these diverse problems. But after 2000s, the system has changed. There are multidisciplinary approaches. There are different experts in different fields, so the patient goes into contact with different experts. That's why we emphasize the integrated healthcare system approach. Palliative care teams should embrace the patient in order to solve this diverse range of patient problems, except then the physical interventions. Palliative care teams can solve a large number of problems. This may be a team of 2 or 3 people, rather than patient applying to different doctors. Palliative care experts can solve many problems for them. Since the beginning of 2000s, our health ministry has attached more importance to palliative care, and there are patients from different parts of Turkey. If you take someone from a different part of country and bring them to the capital city, even if you provide palliative care, this may not be enough, so these services must be spread. And it doesn't matter if the patient has a fatal situation, if the patient can be cured or not. And the palliative care should cover not only the patients, their family members, and financial support through the intervention by social service experts is also important. I believe that there are some missing points in WHO's definition of palliative care. I believe that people should be accessing palliative care in the location where they live. They may be struggling with cancer or brain trauma, bleeding, but they must be receiving the care in a close location to their home. There are different palliative care service models in different parts of the world. In some countries, there are acute, subacute, and chronic sections. Sometimes they target the pain management or different parts of the situation. The palliative care can be given in polyclinic setting. There may be consultation services. In Turkey, we don't have that specialty. Home care is an indispensable part of the palliative care. The main philosophy is to provide the care at home or at a location that is closest to home. And daycare units are important. So a person, a caregiver, may be working during the day, so they may be dropping the patient at a daycare center, and they may pick up the patient in the evening. So we said hospice. What is the definition? This is a home that is built as a cozy, comfortable place for the patients. In Europe, they had these centers, these homes for many years. The patients are taken to this place when they have a terminal disease and they should spend the rest of their life in peace. But most of the time, people have prejudice against these centers, but because not only people with terminal diseases are taken to these centers. In the USA, hospice is defined as a center where people with not only terminal diseases, but people in need of care are taken to. In Turkey, maybe we can start pilot studies. There is not a standard sample of a hospice that is present in every country. But the patients who do not want to create a burden on their family members can be given care in hospices. When we first started the palliative care in Turkey, most of the people we provided care in Turkey were cancer patients, but when people learned about the availability of such care, the percentage of cancer patients who received palliative care decreased to about 45%. Before, home care was not common for cancer patients, but now it is more common. Palliative care is really important for us. And there are legislation approved by the parliaments around the world. The state may not afford to provide chemotherapy, radiation therapy to patients. It may not be financially available, but palliative care is easily affordable, and the states can afford that, especially in the terminal stage. Receiving this care is very important, and it is not difficult to build this system. And when we have the palliative care option, emergency services are less busy, and we can see that the recent research approved that the lifetime of the patients receiving palliative care are longer. I really like this slide. I will show you the details. In order to see how the palliative care systems work around the country, we did field visits, and we did this to Asia or the United States. In this picture, you can see a patient receiving palliative care. But the patient has someone with him who he misses the most, his dog. And you can also see in the picture that this room is designed in a cozy way, like his home. Maybe he can bring his pictures, so it resembles to his home. But this is a healthcare setting. So when we provide palliative care, we must also educate our doctors on this. Every year, we lose many patients, but how do we deliver the bad news? Do we directly tell them what is going on, or do we question their quality of life? Do we question their intentions, their wishes? Where would the patient want to be? Where would the patient want to die? The doctors should ask these questions, and this kind of communication between the patient and the doctor is really important. Of course, it may not be always possible, especially in surgical sections, but in palliative care units, you will have the time and the option to discuss these issues with the patient. You can see a palliative care, you can see the kitchen. Rather than giving the patient the hospital food every day, they decided to allow the patient's caregiver to cook what the patient likes, and they also designed a green yard just in front of the hospital, an area where the patient can play with her grandchildren. In the middle, you can see this. There's a package of painkillers. This is given to people who receive home care. If they have a pain crisis, they will have access to that. So the purpose is to create a center that resembles to home. This is a hospice center in the United States. There's internet, telephone, computer games, television. These are important because it touches their soul. These are examples from Asia. As you can see, cultural nuances are also added to the setting. And if you pay attention to that, maybe we can create a different specific type of palliative care environment. So after examining the world examples, we created the Palliative project, and we published Turkey's 5-year plans, 10-year plans. We also published articles in respectable journals. So what do we need in Turkey? There must be a palliative care center where the patient can go when there's an acute crisis. And there's also the healthcare staff who can give care at home, and also primary care physicians. And primary care physicians and those who deliver at-home care services should be closest to the patient's home, and they can refer the patient to palliative care centers. So we created this palliative care classification. The first level palliative care centers are the first places where they can reach, and the second level palliative care centers are for patients with more serious conditions. And there's the hospice, the support homes. And we recommended that these hospices should be built in the coming years. Legislation in Turkey, there are palliative care nurses and there are charities, foundations in Turkey who are involved in development of palliative care services, and most of them are voluntary, and we care for the problems of these patients. And we worked on the legislation that regulates the use of morphine, establishment of home care services. And we also work towards payments from the Social Security Institution of Turkey. And the one thing behind the success of Turkey is volunteer work of those who care for the patients. You can see how the home care services are given in Turkey. During the past years, the numbers of people receiving palliative care increased from thousands to 1 million. And there are also palliative care centers established inside the hospitals. During the past years, the number of these palliative care centers increased from 15 to 450, and the number of beds has reached almost 6,000. And in addition to adult palliative care centers, we have also established pediatric palliative care centers. And spontaneously, additional services have been included in existing services. There is no other example of palliative care service in the world that increased so sharply because we wanted to touch the souls of those. This was a humanitarian approach. In 2021, more than 300,000 people received palliative care. There's International Palliative Care Center, and they work in cooperation with the WHO. When we were in Group 2, there was almost nothing. Now Turkey is in Group 3, and soon we may join the countries in the green group, the best ones. Morphine is a significant part of the palliative care. When we look at the dosage of painkillers in the world per person, Turkey or other Muslim countries are not among the top countries. But without controlling the pain, palliative care is not possible. When we look at the use of morphine, painkillers, we are not among the top countries in the world. When we look at the need for painkillers and morphine, the need for pain management is met in European countries, but the red ones are so low in other countries. So in Turkey, there was a sharp increase in the provision of palliative care services, but it is still not sufficient. The amount of medical opioids used per person has increased, and oral tablets have been produced in larger amounts. I would like to thank the Middle East Cancer Consortium. We drafted an article together We conducted 35 international trainings and 450 staff trainings were organized. The trainings are high quality, and you can see the examples of palliative care centers, and they are becoming more common in Turkey. And as far as possible, we want to reflect the Turkish culture in these palliative care centers. We have more beds for pediatric cases, and we want to design these centers more like a living area with armchairs. And as you can see, in that picture with the patient with the dog, we want to make it more home-like. And there are response rooms or recreation rooms. This one is from Tokat City. So we are improving our palliative care centers. Dear colleagues, I would like to summarize. If we work hand in hand with patients, we will be successful. World Muslim Health Union will be working in cooperation with all of us, and I hope that with the support of all, we can become a leading country in the world. I would like to thank you all once more, and I am really sorry because I am not with you there. I would like to thank Professor Dr. Murat Gültekin. I did not want to interrupt his speech. This may be a bit long, but he made a broad presentation about the past, present, and future of palliative care. And hopefully the countries who are working with us will be giving the academic and technical support, and we will reach a better point. Our Congress has the theme of cancer, and palliative care is very important in that sense. I would like to invite Dilek Hamurcu for her speech. Unfortunately, she's not here. She will be joining us online, and she will give us information about psychological side.
Teşekkür ederim katkınız için.
Thank you very much. I would like to thank all those who have contributed for the organizing of this event. Can you please make your presentation full screen? Okay. Now, the floor is yours. I would like to thank those who have contributed for the organizing of this meeting. Cancer is a life-threatening experience of disease, and it is about some needs, some emotional, medical, social, and existential needs. In the last 40 years, there have been significant changes in the cancer treatments, and life expectancy and life quality studies has changed, but the emotions of the patients has not changed. For this reason, psycho-oncology is important in making this journey a bearable one. World Health Organization published a report in 2008, and it says that all oncological, psychosocial components should be a part of all national cancer care plans, and psycho-oncology services should be provided in all cancer treating clinics. If we are talking about good quality cancer care, we need to provide the psychosocial needs and we need to integrate this to the routine cancer care. And in the same report by World Health Organization, it is stated that psycho-oncology services and psychosocial support for the cancer patients and their relatives are important. We should inform them about their status, and we should respect their choices. And all around the world, let's look at the developments about the psycho-oncology. Psychosocial needs are important and they're underlined very frequently, but in most of the cases they are not realized or acknowledged, and their psychosocial needs are not met. And I would like to underline the need. This is a need also for the relatives of the cancer patient. It is not just about the patient, also the caregivers, the family should be also considered. And psycho-oncology studies should also focus on the cancer patient and the cancer patient relatives. Many patients in decision-making process for their treatments are not able to receive sufficient information and guidance. There are some services in some countries, but in practical implementation, there are some shortcomings. Sometimes the patient has fears about being stigmatized, and they fear that they might be stigmatized, but if they express their stresses or fears. And cancer patients there's a study about the cancer patients' psychosocial needs, and it says that they are afraid of being stigmatized, and they have a hard time about this. And about patients, they talked about their relations with the doctor, with the physician, and it is an important thing in their journey with cancer. And the cancer patients, when they asked about the unmet care needs of the cancer patients in the early stage. In the early stage, the resilience is lower in patient, and when the psychological needs of the individuals are not met, and when they are not able to receive supportive care, and when their information needs are not met, their resilience is decreased. And what does psycho-oncology? Cancer patients and their close relatives are important for psycho-oncology. And before the treatment, before the diagnosis, and all along the treatment, they might encounter psychiatric problems, psychological problems, existential, spiritual problems, and consultation and museum psychiatry is important. In United States, it is a department. We had received training. Unfortunately, it is not like that in Turkey. We generally focus on distress in cancer patients, and they have higher distress when compared with other parts of the other sections of the society, and they have chronic high stress, and this negatively impacts the course prognosis of the disease of the patient. Distress has a very large definition, and there are some differences in the translation of Turkish. Sometimes it is called distress, sometimes it is called stress. Distress is not the same thing with stress. Distress is something about a crisis like cancer, and feeling some vulnerability, fear, and depression, anxiety, panic, social isolation, existential and mental crisis. So this has a very large spectrum. It is defined in this one. The definition. On one hand, we have psychopathologies too. In 2010, distress was accepted as a sixth vital finding. So we are checking the fever, tension, blood pressure of the patients, and this is the sixth vital finding for cancer patients. American Surgeons College committees in 2015 said that if you want to accredit a cancer center, you need to have a program with which you can refer the cancer patients with distress. And after that, accredited cancer centers had to work on this. But there's a problem about here. The detection of the distress is important, but how are we going to manage this? We have problems about the management of this stress. This is a stress thermometer. And this is something quite simple. This is a simple scale. If it is 0, no stress, and if it is 10, the stress is at the highest level. We ask, how stressful did you feel yourself in the last week? Please check your stress level on the thermometer. After that, we have these items on the right-hand side, and we ask which one of them are the main reasons for their stress. And we have a reliability study, and cutoff value is about 4,000, and if it is if it is higher than this, we need to think about this. And stress thermometer is actually talking about the problems they might experience. For example, daily life problems. I am working in Ankara Oncology Hospital since 2010. I'm providing oncological services. I'm a psychiatric specialist. For someone coming from another province, woman has a disease. There is a suspicion that she might have cancer because of the mass in her breast. She didn't leave her own province before. She was never able to go alone, and they had to come to Ankara with her husband, and they have accommodation problems since day one, and they are daily workers. His husband is daily worker, and as he needs to be with his wife. They start to have financial problems. They have children, and they started to experience problems about the caring of their children, and there is suspicion of cancer on their mind, and they have anxieties, concerns about this, and then there are accompanying physical problems. These are all causing stress, and by looking at the stress fields defined by the individual, we decide upon the referral. And psycho-oncology requires multidisciplinary work in clinical disciplines like medical oncology, hematology, radiation oncologist, palliative care. These are surgical oncology. We are working together. We need to work together with all of them: psychiatrists, psychologists, social service expert, social worker, oncology nurse, and spiritual support. Psycho-oncological interventions include some problems defined here on the stress thermometer. We might have physical symptoms like pain. They are not able to cope with it, and they have psychopathology, and there might be psychiatric comorbidities too. And social problems, they might have social problems. And stress-related interventions might happen, and spiritual care. In the previous presentation, Murat said that palliative care is really important, and we are psychologists attend those visits. And during pandemic, of course, there were some disruptions in this program, but when we attend these regular visits, they might have some observations about the problems, and the psychologists come to me, and we discuss about the cases, and the relatives of the patient who is at a terminal stage might be also needing support, and we try to support them about the process they are going through. Life quality improvements and decreasing the stress, and adaptation to the new lifestyles are main issues, and we also support healthcare personnel. We need them to understand the psychological problems of the patients and their own psychological problems. So we want to support them in terms of coping with burnout and problems like that. We have in-service trainings. For example, our psychologists, when they talk about the coping strategies, they give trainings about coping strategies, and we have psycho-oncology symposiums, and with the support of International Psycho-Oncology Union, we organize psycho-oncology congresses, and we provide trainings in those activities too. There are some care standards in the distress management, and these are internationally developed. And cancer patients and stressing cancer patients should be checked, should be screened, and they should understand the nature of the distress. And we have guidelines for the management of stress, and interdisciplinary committees should decide upon standards in the stress management in our country. Ministry of Health had some studies about the comprehensive oncology centers. Now we have some criteria for those centers. One of those criterion is psychological, psychosocial support provision. If you are going to provide a comprehensive psychosocial care, it should be cost effective, and it should be adaptable to cancer care, and we should have a distress screening. And I checked what do we mean by cost effective. This is a study conducted in the United States. In cancer patients, they checked the costs, they checked the expenses, healthcare expenses, and if they have psychiatric morbidities, their costs are increased, according to this study. And in this study, generally, they have mood disorders and addictions, dependencies, and anxiety disorders are frequently experienced. We can have many comorbidities. We have compliance problems or anxiety problems, depressions. What kind of reactions we can have from cancer? About cost, what can we say? I had a previous case at the age of 18, and she came from Urfa, or from a southern city, southeastern city. She had a mass knee in her knee, and we wanted to have advanced checks, advanced controls, and she was 18, and the family was also informed, and she was saying nothing will happen to me. And the patient doesn't go to the doctor. 1 year later, the mass is growing really badly, and then she was admitted into a hematology clinic, and her leg was amputated. And the psychological reaction was denial. She was saying this cannot be happening, this cannot be correct, and she wasn't going to the doctor. This is something which is not reflected in the healthcare registries, records, but it is affecting the life quality and the cost of the treatment. So the psycho-oncology implementations are cost-effective implementations, in my opinion. The patient is denying the truth, reality, and trying to protect herself from something she cannot cope, and she's delaying this. But if you delay this for a long time, this is a negative psychological defense. So for cancer patients, we have psychosocial healthcare services model. This is a multidisciplinary study. The patient should be working together with the clinicians, and we need to detect the psychosocial needs, and we need to develop a plan. And this is a healthcare services model. We have layered care models. It starts from general care, and it goes up to acute care. General care is providing information by primary health care team, and we have supportive care like emotional, practical, spiritual, psychoeducation, and we have extended care like consultancy. I think that these are the last slides. About psycho-oncology, we are making publications. I use group psychotherapies. I do group psychotherapies for breast cancer patients, and we also have individual psychotherapies. And I wanted to write these words. We are trying to. If we are able to help each other, and maybe the destruction around us will be less. Cancer experience is at the jeopardy, but it is a crisis. But the psycho-oncological services is trying to turn a crisis into an opportunity. We are trying to change the perspective in life. Thank you very much. I would like to thank you very much. This was a really important topic for oncological cases. And you talked about this in your presentation in quite detail. Now I would like to give the floor to Associate Professor Dr. Ergün Hosgül from Health Sciences University. He is also the chair of the Medical and Social Services Society. He will talk about the social services and AIDS at home. Normally you had 15 minutes, but it will be 10 minutes. Thank you. Thank you, Director General. I'm already been introduced by our chair. I'm in health sciences, working in health sciences university. I will talk about social services with a different perspective, And social services, social aids did not start just yesterday. We were providing these social aids years ago during the Ottoman era too. And in my presentation, we will see some modern approach in social aids. I also listened to previous presentation. They were quite enjoyable, and they provided great contribution. And Murat Bey talked about the funds and some financial problems. He said that this is a teamwork, and grief consultancy was also mentioned. And Dilek Hanım talked about the social isolation, teamwork, existential problems, stress, distress. So these things are all related to home care, home social care, and social aids. And I want to talk about the social care, social aids activities from past to today. And of course, we should start with Mehmet the Conqueror, Sultan Mehmet the Conqueror. And I want to use some words from his vakfiye, his society for AIDS. He was working in the home care, nutrition, animal rights. This vakfi is including these kind of words. Of course, I will not read, but I want to share my notes. First of all, he says that we should go kindly to the poor and towards those who are in need. And the healthcare services, home care services are improved. And we need to check all doors from time to time in certain periods. We need to ask whether there are any patients. And if their conditions are severe, they should be able to receive all kind of medical services free of charge. And we have appointments for surgeons, for 10 surgeons, for 10 care workers. So about hunger. There are some parts, and there is a part about the animal rights too. And during food depression, during famine, people will not be left hungry. And when we're going for hunting, we should not do this during the offspring or birth seasons of the animals. So he is thinking about both sides. And when they are providing this food service, they should be kind to the poor. We should not invite them to the soup kitchens. We should go to their houses. So the timing should be done well, and they should not be feel embarrassed. And it should be done during the dark hours of the day. And it is openly declared, and it is quite interesting. So years and years ago, Ottoman Empire has started this home care activities, and we were able to carry this to the modern days. In Sultan Süleyman the Magnificent era, he says that these support aids are really important for Ottoman Empire and people and society. And this is also the case for Sultan Abdulaziz. He was important in the establishment of the Turkish Red Crescent, and Sultan II Abdülhamid. Sultan Abdulhamid II had some works for orphans, and there were some institutions for the children care, and these were for social aids. And we have this culture of foundations, societies, associations, and we try to carry this to the republic. And our late president, Turgut Özal, opened up social solidarity and social aid and solidarity foundations. In 1986, we wanted to have some permanent solutions for social aids, and we established social aid solidarity funds. And with the help of these foundations, we turned them into social programs. And the source of this fund was from zakat, taking its base from zakat. So there it was taking its basis from donations or traffic fines. They were all collected, and we wanted to establish this social aid, social support understanding. And in Turkey, we have more than 1,000 foundations of social aid and solidarity. Vakıf foundation in English. This word is really important, increasing the awareness and helping people. Foundations and societies, associations have significant importance. And I would like to thank the World Museum Health Union conducting these kind of activities, and they are conducting awareness, increasing awareness activities. And I would like to thank you for your invitation. What is happening? What is Turkey doing about the social aid? So in the last 20 years, the social aid amount has increased by 75 times. And 20 years ago, we were providing, we had 4 programs in 2002, and in this year it was up to 49 programs. So we are covering everyone. We were not leaving anyone behind. We have the elderly pensions, and this is an aid. And in 20 years, there was a 64 times increase. And we have conditional birth aids, pregnancy aid, and aids for the military officers. We have conditional education, cash transfers. for the girls and boys attending to school. We also experienced COVID period, and in the world we dealt with significant problems, especially for those who are in need, to the elderly, the disabled, the children, and I know that the Director General has contributed greatly, and we saw that the mortality rates were low in the elderly, and this was because of the projects that were conducted in the time period. And we have the support aid for the orphans, and we have SODAMs, social solidarity centers, and we have family support centers. SODAM number was increased. It was planned to increase to 47, and this year we want to increase Adem's number 327. This is another important topic about this home care allowance. We have national program, and this program is for the elderly, for the disabled. If you have some family member who is elderly, if you are not able to if you are providing care for one of your family members, we have a home care program, and it is now rolled out to 81 provinces, and we can manage these projects in through volunteers. And we provided 25,000 people service in the last year, and this year the targeted number of people is 90,000, and we have soup kitchens too for the home care, and for soup kitchens we can say that we are providing great support. Our model, Türkiye model, has taken its source foundation from Ottoman Empire, and we have now these social programs models, and clearly we are trying to keep the patients at home as much as possible, as long as possible, and we want to provide the home care to them, or to the home care allowance for the people who are giving, or their caregivers. We want them to keep at home. We want to keep them at home, and if they are not able to stay home, if their medical condition is not suitable, we institutionalize them, and we are not leaving any patient behind. I talked about the home care support. We have there are people who are going to support for the care of these people, and there are some people who are taking care of their own family members, and for staying home sometimes people need some support, and we are given 3,300 Turkish lira monthly for those people. We always say housing first. And we want them to stay at home. We want them to have the social, economic support for them to be able to stay at home. We are giving some housing support too. So to sum up, we can see the support or service areas of the Ministry of Family. We are providing project support, educational supports, and healthcare supports. In hospitals, additionally, I will share this information. In addition to social aids programs, we have units of social services. We have social service centers. Once the patients are discharged from the hospital, we are providing psychosocial support, and the necessary intervention models are prepared. Hopefully, we will have a program. The model studies are still ongoing, and hopefully they will be integrated, and we will have a Türkiye model for this. Thank you very much.
Çok teşekkür ediyoruz. Tabii evde sosyal hizmet
Thank you very much. Social services at home is a broad concept. Thank you for summarizing this in a short presentation. Now I would like to invite Derya Karakaya for her presentation. Unfortunately, she is COVID positive, so she's not with us. Yasemin Kılıç Öztürk from Izmir will be presenting. Thank you. I used to be taller, but today I don't have high heels. Maybe that's why I can't see you from behind here. Thank you for your trust. May I have a microphone, handheld microphone, maybe? That's maybe better. Welcome, everyone. It's really late. This is going to be a difficult presentation. Thank you, Orhan Hocam, for trusting me. And today I feel your trust. Unfortunately, Derya Karakaya is sick today. I would like to present her presentation, and I would like to she sends her regards, and I would like to thank EBSAT for their support too. And I will talk about the healthcare services given at home. Let's close our eyes. I know you are sleepy, it's late. Let's close our eyes and think about one person that you like the most. And think about how grateful you are for their presence. You want them with you in the most difficult times. And now open your eyes, and this is what patients feel when they are with home care personnel. They are grateful for their presence. It's really important for us to provide these services. Home care services have been given in our country for a long time. It dates back to 15th century during the Fatih Sultan Mehmed era. Doctors and officials would come together and they would make home visits to support the patient. Home care services was regulated by the public health care law of 1930, and the doctor visits are regulated with this law. Home care services targets providing examination, lab tests, and treatment, also care and rehabilitation to those who are treated at home. There are healthcare professionals who provide these services. Healthcare professionals include nurses, secretaries, drivers, and there are also psychologists, physical therapists, and dietitians, and that's how we handle the entire process. Daria, who could not attend, is the one in the front in the picture. She's not physically with us, but her presentation is here. Daria, Orhan Hocam, and we can have a picture together. Okay, let's continue. Home care services are currently provided under the Public Hospitals General Directorate, and we have home care providing units. There are also agencies that are affiliated with the ministry. There are research and training hospitals, and these services are also provided by the personnel from the oral health care centers. You can see the vehicles here, and there's a phone number 444-3833. This is a number where people can reach home care services. So I will keep reminding you, this is the direct number of the home care services. There's an appointment system, and this is how we manage the process. In 2005, a regulation on the provision of home care services was published, and this helped facilitate, speed up the process. So we closed our eyes when we thought about people we love. The most important part of home care services is to enable the patient to go through this difficult time with the loved ones. People feel more comfortable in their own field when they are at home with their loved ones. There is a saying in Turkish, on the corner of a hospital. It has a negative connotation, so it means that we are away from those we love. And at home, it is easier to detect what's wrong and to find solutions. And also, being at home enables them to move around the home rather than staying isolated in a hospital room. And another advantage is the facilitation of giving home care is that not many people would go to hospitals, so the workload would be less. And at home, family members are also involved in caregiving process, so the physical and mental changes can be identified more easily because more people are involved. And there are people who live in distant areas, and they have difficulty accessing the hospitals, the cities, and when we can provide them with home care, they can receive quality healthcare services. Of course, there are disadvantages too. The patient might feel alone at home, and the intervention may not be as smooth as in a hospital. And of course, it is more difficult for the healthcare personnel because when they give home care, they don't have access to necessary equipment all the time. And there may be security issues with the family members. At hospitals, we have security staff, but at the patient's home, they are responsible for their own security. But of course, they do whatever they can without thinking about their own security. And there's also the accidents that may happen on the road. This is another risk for the healthcare personnel. So the services are provided at home, but home is also a private area for the patient. We enter that private field that the patient creates for himself, herself. You don't want people to see you in your pajamas, and they may be sensitive in that sense. Another problem is we wanted to work on this, but we could not yet. Medical waste. Management of the medical waste created at home is another issue that must be considered. When we look at the general situation of home care services in 2021, we have 1,252 home care units, teams. And when we look at the number of team members, the doctors and nurses are sufficient, but the number of physical therapists who are involved in this program are low, and medical clerks are not involved as much as the doctors and nurses. And when we look at the different parts of patient types, cardiovascular and neurologic patients make up for the large part of the patients receiving home care. Almost 500,000 procedures were conducted in 2021. So what kind of medical equipment are available? Functional patient beds are available. It's important to move the patient and the caregivers who are family members who provide care at home need this because they may need to move the patient around the bed, and this is an important need. Home type medical invasive ventilators are also needed for patients receiving home care. These are not always provided by the ministry. The patients sometimes purchase them themselves, and these are the Federation of Healthcare and Social Services foundations. There are different foundations on the accreditation, patient rights, youth, sport academy foundation, resource management foundation, professional healthcare, rare diseases foundation. You can see there's a diversity of foundations. So what do? We facilitate the connection between the state, patient, and civil society, and we defend the rights of the patients and disadvantaged individuals. When we look at the holistic care understanding, there are different foundations working on the fields of palliative care, home care, hospice care. What did we do during the pandemic? We tried to provide for the healthcare, food, technology needs of the elderly, disabled, and disadvantaged groups, and we provided hygienic and medical supplies for them. For the refugees and migrant groups, we provided patient care trainings in their own language. And even our citizens were having difficulty in caregiving, and there was also the language obstacle. So we trained caregiving personnel who could speak the patient's language. And we also provided psychosocial support, and we purchased supplies for them. And for the social cohesion of refugee groups, we initiated cooperation projects, and we also organized seminars for women's health, substance addiction, mental health, and for the disadvantaged groups, we created training opportunities, and we also supported digital trainings, which was necessary, especially for the children during the pandemic, to support the elderly who could not leave their home. Our volunteers provided great services. Maybe we will summarize this in the end. We did not stop during the pandemic. Orhan Hocam is the one who managed the team, and he tried to reach everyone. He kept dreaming. And we had online meetings with university students. This is the logo of EVSAT Foundation. Sadafe is the foundation. Thank you. Thank you for giving us this presentation. This was really interesting. We are really delayed. I will give the floor to the next speaker. We will not have a break now. There's a 20-minute delay for the last presentation from Philippines, Dr. Mustafa. I'm sorry, I did not know that you were here. Nahide, please.
An internist and medical nutrition subspecialist. I am the current vice president of Islamic Medical Association of the Philippines. We'd like to thank you, President Qasim, and all the delegates of the World Islamic Health Union for coming in today despite the pandemic. And my topic will be nutritional support in cancer patients. To our interpreter, please tell me if I am talking too fast. Okay, just let me know. Okay, so my objectives for this lecture will be to present the common and emerging recommendations for nutrition interventions in oncology, and case discussion on cancer survival and nutrition support, which is actually my case, since I am a 14-year cancer survivor. And I'd like to also highlight the integration of Islamic health and nutrition. Now, we'd like to also thank Dr. Rokaya, who advised me to lecture on this topic. Okay, so of course, the role of environment and lifestyle. We know that it is estimated that 80 to 90% of all cancer cases are related to environmental and lifestyle influences. And this is a paper since 1980s. No, we already know this. And we are happy. We should be happy because as Muslims, we know what to do. We know the solution, right? Do you agree? Yes. And so, if you look at this paper on clinical nutrition, the European Society for Parenteral and Enteral Nutrition, you can just download this, and so it won't be too long. You can easily access the app. There's an app for S-Pen nutrition for cancer and other disorders. So if you look at the clinical nutrition, you have at least a lot of concepts in clinical nutrition in cancer. You're not just looking at one cancer at a time. You're not just looking at surgery. You're also looking at screening and assessment, energy and substrate requirements, nutrition interventions, exercise, and everything. So you also look at the different settings of cancer: surgery, radiotherapy. Yesterday we went to a cancer institute, and you saw all the machines in Turkey. And of course, we'd love to see also the effects, the nutritional effects on a cancer patient who can have difficulty swallowing, for example. So you have to also address this and have the medical oncology team to be there, and of course, nutrition team to be there. Okay. So screening, assessment, and interventions. This is our dream, that all hospitals will have nutritional screening upon entry of the patient. Upon admission at the emergency room, you will check already if the patient is not eating well, if the patient has weight loss, okay, for example. And you look at the assessment. How aggressive will we be? Will we put tube feeding? Will we put IV? Okay, so it's not enough that we just talk about the food that we will eat. Yesterday was a very successful topic. We are very happy because the diet, the foods that we should follow are already there. Now, there will be times that your patient will not be able to eat. Even if you present the best food, the most colorful food, the tastiest food, they will not be able to eat. So that's where clinical nutrition comes in, your enteral nutrition and parenteral nutrition. So there is hope, right? So you look at the general concepts of treatment relevant to all cancer patients. You always look at the energy and substrate requirements. How many calories will I give my cancer patient? Will I give 20 calories? Will I give 35 calories? So it depends. So my forte will be on refeeding syndrome. I love to treat patients, especially elderly patients who are coming in very cachectic, very skinny, and I don't want to start them in a very high-calorie diet. So you should start slow. You start slow and you gradually increase the calories from 10, 15, 20, 25, 30 to 35 calories. So never start at 2,000 calories right away. You have to start at a lower dose and then taper it up once needed. So never forget also the protein requirement of your patient. So most of your patients will already come with lesser muscle mass, okay? So there's muscle mass loss and the patient is not eating well. So definitely you have to give a formula that will increase the protein requirement of your patient so they will have better strength, okay? So it's not just about calories, you also look at the protein and you also look at the vitamins and the minerals, okay? So don't forget to do the screening and assessment. Do you have, when you go to your hospital, you look at the policies on nutrition. Once the patient is admitted, do I get to screen the weight? Do I get to check the weight loss? Do I get to check if the patient lost weight for the past 3 months? Okay? So always check if your patient was assessed. And that's the time that you can decide, okay, I need to just give oral nutrition or I can give IV nutrition because the patient doesn't want tube feeding. So I will not force the tube on the patient. I will give IV nutrition first. Once the patient is stronger, most of my elderly patients who come in do not want NGT. So I try the oral nutritional supplement first, and if they cannot eat, then I put the IV. So once I put the IV, they recover in 24 to 48 hours, I can send them home. So it makes things faster. And then you follow through the diet after 48 hours, okay? So this is part of the nutritional management. So you don't just look at the oral, you look at the medical nutrition factors, you look at the enteral nutrition, the parenteral nutrition, and of course, you have to compute, okay? So again, do not just follow the TPN bag. Usually the TPN bag will give you 1,400 calories or will give you a higher 2,000 calorie bag. So I know in Turkey, we have higher sizes, we have bigger sizes. In Philippines, we have smaller sizes. See, that's why I'm getting out of the podium because you won't see me, okay? So in Philippines, we are smaller. And of course, I have to adjust the calories for my Asian patients, okay? But if the patient is Arab, from Turkey, or from United States, from UK, I have to follow also the weight appropriate for them, okay? So again, pharmaconutrients, let's check on what you're giving to your patient. If you look at the protocol, you will see that fish oil is still top 1, right? I know everybody loves fish oil, but if you look at all the recommendations, your fish oil or your omega-3 is the only one that will not tell you to be aware of potential serious side effects. The rest, when you talk about steroids, when you talk about progestins, when you talk about other prokinetic agents, you will be told that, hey, you should take care of the side effects. But if it's nutritional management, omega-3, and it stabilizes and improves appetite, food intake, lean body mass, and body weight, there's no warning, okay? And you can add it up to your chemotherapy. So it's not going to be much of a worry. Now, agents with insufficient proof of effectiveness, of course, will be some cannabinoids, okay, non-steroidal anti-inflammatory drugs, and then you have your amino acids or BCAA. But of course, using your clinical eye, if your patient is very skinny, then you have to, of course, add the amino acids to your patient. So I usually recommend using also a parenteral nutrition with BCAA, because most of my patients who have been on cancer therapy are very skinny, not eating well. With the IV parenteral nutrition, they recover very fast, okay? So if you look at medical nutrition in surgery, medical oncology, radio, and palliative care, we are grateful to witness the projects of Turkey in palliative care and home care. We are impressed. And I wish we can do the same in Philippines using the zakat system. So I hope Iman can come up with something similar to what WIHU is doing and improve the promotion of zakat system in the Philippines. So just for trivia, Philippines is more or less around 20 to 30% Muslim right now. But day in, day out, I am being texted by our president in the Islamic community in Luzon that they are having shahada every day. Okay? So every day, you can never tell, maybe next year, we don't know if we are already 50% to 60% Muslim, inshallah. So please include that in your dua, okay? Inshallah. So we look at surgery. Again, I'd just like to highlight ERA's rules. The enhanced recovery after surgery is also important. If you are a surgeon, please do not put your patient on NPO for 48 hours or 72 hours. Try to add your parenteral nutrition just to make sure that you are achieving your caloric requirement. Okay? Try to avoid not allowing your patient not to eat too long, no, especially after surgery. You can allow them to sip a little bit of nutritional fluid after for clear liquids. And of course, if you have the general liquids, you can also use an oral nutritional supplement. Okay? So if you look at radiotherapy, the same. Try to do screening and check if your patient is having difficulty swallowing. So if your patient cannot swallow food anymore, we cannot force them to eat the food that we are preparing. We have to check what is the dysphagia level. If the patient cannot drink water anymore, that's an emergency. Then you have to use thickeners, then you have to use parenteral nutrition, then you can put an NGT, or if they don't like the NGT in the nose, you put it here. Put a peg immediately, okay? So inshallah, with nutritional support, there is always hope, no? MashaAllah. And if you look at medical oncology, it's the same. I have been to 8 sessions or 8 cycles of chemotherapy in my lifetime in 2008, and I know how it feels to have chemotherapy. After the 2 to 3 days of chemotherapy, you will vomit, you will not be able to eat, you have no appetite, you feel like it's the end na. Okay? You're going to be hopeless. But with the learning, after I trained in medical nutrition after, that's the time that I realized that we need to implement this in all hospitals around the world. Because without addressing nutrition, your patients will really die very early, okay? So again, nutritional therapy, exercise and nutritional therapy, and again, you have to emphasize the studies, but at the same time, because this study is not an Islamic paper, later on, we can incorporate our Islamic practices in the nutrition therapy, okay? So if you look at cancer survivors, you have to emphasize that they have to maintain a healthy lifestyle, okay? And it includes being physically active and a diet based on vegetables, fruits, and whole grains. And for the palliative situation, this was discussed already a while ago. If you are an Islamic practitioner, you're an Islamic clinician, then of course you incorporate Quran prayer, you play the Quran in the facility, and then you teach the patient on, of course, the Shahada every time when death is near. So these are all parts of our ibadah-friendly facilities, okay? So Alhamdulillah, in Philippines, we already have 3 centers who are actually doing ibadah-friendly practices. 1 in my center, 2 in Cotabato, in Mindanao, and 3 in Zamboanga. Okay? So Alhamdulillah, also with our clinician members in Iman, the Muslim physicians, they are already emphasizing the Islamic practices. Janaza, preparation for janaza is very important in palliative care. Okay? So maybe we can have a WIHU module on cancer nutrition, but Islamic perspective, inshallah. So to summarize, screening and assessment will remain mandatory in identifying cancer patients at risk for malnutrition. and interventions are individualized. Of course, not all patients will be the same. So there will be young, there will be old, there will be strong patients, there will be weak patients. And pharmaconutrition remains to be an essential and evolving modality. Now, there are emerging nutrition interventions, and I'd just like you to read on nutrigenomics. It may not be available yet for everybody, but I'm hoping that one day we can have a nutrigenomics center also in the Philippines. And if you're willing to support having a nutrigenomics facility in the Philippines, maybe you can also try to explore it with us. So here we also try to emphasize on methylation. It was also mentioned yesterday, and I'd like to emphasize the methylation because you have to remember that when you have cancer, you have something wrong going on in your DNA. So it's either exposed to a genetic predisposition or you're exposed to a heavy metal or environmental toxin, and that is the reason why your DNA structure is getting difficult. There will be difficulties and there will be disorders that will come. And it may not only be cancer, but it can also be other methylation problems in the immune system and in the metabolic system. All right, so I just like to insert this one. So the effect of fasting or calorie restriction. And in the Philippines, it's already trending. In the Philippines, they would say intermittent fasting is very good, no, for you. They recommend 12 hours fasting, 8 hours fasting. And at the back of my head, I would say, we've been doing that since we were 6 years old, 7 years old. We've been doing Ramadan. We've been doing fasting Monday, Thursday, for some during childhood. So intermittent fasting is not new to Muslims, correct? Do you agree? Fasting is already a well-known treatment. And me, when I was recovering also, I did fasting. When I was in pregnancy, I was doing fasting also. So it is not impossible that Islamic medical approach will be the answer to the many diseases that we have already in the country, globally. Yeah. So this is just a paper on traditional Islamic herbal medicine. And as I was eating yesterday and today, I was very happy because the last time that I ate a lot of fig was when I was staying in Saudi Arabia. So I was born in Saudi Arabia and I was eating a lot of fig. And now that I'm in Turkey, I am very happy because I'm eating also a lot of figs. And Alhamdulillah, did you know that the date palm fruit already has scientific evidence of its utilization for complementary therapies to your patients? So if you want an Islamic nutrition approach, put some dates, okay? And then put some, I can just go through this one, so at least you just know that the dates are very essential. And that there's scientific evidence about it. And then you have the fig. So that should be part of your package, your diet package in the morning. And of course, you have apricots here. Turkey is very lucky. So there are scientific evidences and there are bioactive components that are contained in your figs. So how many of you love to eat figs? Plenty, almost everybody. So congratulations because you just ate a lot of these antioxidants for the past 2 days. Alhamdulillah. So again, if you look at the fruit extract, they were able to derive a lot of tissue responses that you can see that it will be helpful in giving your immune system boost. Okay, so it has phytocomponents, and when you look at it, you have a lot of benefits, and maybe it will not be impossible if later on we will be having Ficus carica capsules in the regimen of your cancer patients, inshallah. And also, if you look at the black cumin, we all know this already. Did you know that there are bioactive components that are actually inside it that is actually the one giving you the assistance for cancer cells? This is why even before, Nabi Muhammad sallallahu alaihi wasallam was already telling us about the black seed. And we were wondering, how come he said it's a treatment for all diseases? Like Allah subhanahu wa ta'ala said, black seed is very good for everybody, even for death. But now we know, because now we know that there's thymoquinone, there's dithymoquinone, there's carvacrol. There are scientific components or bioactive components that will help us boost the immune system. Okay? And now, I think there's a company promoting a black seed oil. It's very common now, no? They're doing it now, and it had a high marketing value during the COVID-19. Okay, so I'm almost done. I'll just go to my case. My case is I was diagnosed at 26 years old. I am now 40 years old. And I was diagnosed with breast cancer. On biopsy, it was stage 1. But when they removed my breast, my right breast, it turned out to be stage 3A. Okay, so I was in residency training in internal medicine. I was a first year internal medicine training. And alhamdulillah, they even did, a bone scan on me. And they found out that I had metastasis on the clavicle, T4, and even the sacral bone. So that was stage 4, way back in 2008. Now, you might wonder, yes, I did chemotherapy. I had 8 cycles of chemotherapy. And I refused radiation, unfortunately, because my tumor size was 5.1 centimeters only. And the cutoff score for 2008 was 5. So I said, I can skip the 0.1, maybe I'll survive. So I had to skip the radiation therapy. I had to follow the proper nutrition regimen. And former colleagues, unfortunately, were diagnosed to have breast cancer and pancreatic cancer in our institution. In the same institution, 2 to 3 years after, yeah? So unfortunately, all my colleagues are dead. Astaghfirullah. No, inna lillahi wa inna ilayhi rajiun. Now, if we look at it, what was different was that I was already gulping antioxidants during my therapy. Now, I wanted to make my immune system strong, so I had to make sure that I had a dose of A, C, B, D, and other micronutrients and phytonutrients. So I had a diet modification, mainly plant-based. And doctors are busy. Sometimes they go on duty and they just eat whatever is easy to grab in the shop. So not all doctors are trained to pack their lunch and put vegetables and put some apricots every day in their duty lunch box. And so I was also given 1-year bisphosphonate infusion. So alhamdulillah, I had to return to my residency training after the 8 cycles of chemotherapy. And alhamdulillah, in 2010, after the last bisphosphonate therapy, I suddenly got married to an Ustad who is standing here, Ustad Mustafa Marzuki. He discovered me, and I told him, "Are you sure? I only have 1 boob." I told him. And then he said, "Subhanallah, well, we have to have tawakkul, tawakkul to Allah." And my physicians were actually telling me, "You cannot get married because your hormones will go up and you will die." So I said, "Okay, tawakkal to Allah. At least if I die, I can please someone. I can please someone who loves Allah." Okay. So inshallah, after that, there were Islamic health practices and du'as that were strengthened. He would read Quran all the time, even until now, 12 years after the marriage. And I had my first pregnancy and delivery, and had continuous monitoring, and I resumed residency training. So after that, this is my 2 sons in 2010 and 2011. Succeeding years, I had 2 sons, alhamdulillah. And 2016, I had another baby girl. So alhamdulillah. So we are very grateful for the miracle of Allah that even after stage 4, being diagnosed with stage 4, and I was already preparing for death. Within 2 years, I was really prepared. But alhamdulillah, this is the miracle of Allah. So I'd like to thank my ustads for sharing his life and his teachings in the Quran. And alhamdulillah, these are some of our team in the hospital. And I was currently assigned as head for nutrition team in one Christian hospital in Philippines, alhamdulillah. And after some time, they would ask me also, I also teach college students on clinical nutrition. And as you can see, we also teach doctors, doctors who are training in medical nutrition. And alhamdulillah, I would never take off my hijab. Okay, my hijab is my weapon in Philippines, alhamdulillah. And even during chemotherapy, I lost all my hair, but the hijab protected me, mashallah. So if you also look at the PCP, the Philippine College of Physicians, we are currently, this was just last month, we had research committee contests. So there are a lot of doctors presenting their paper, oral presentations, case presentations. And I hope we can do this also in the coming convention. So this is my brother-in-law from Adana, Turkey. And he stayed in Philippines for a long while. So alhamdulillah, he got married to my sister. And we will be visiting him this week, inshallah. So with that, I'd like to also thank the Iman and the WIHU for, there's Dr. Kasim for the special message during our National Assembly last November. And alhamdulillah, we'd like to thank World Islamic Health Union for adding us to the program. So last but not the least, I'd just like to share with you, there's a Google app that I'd like to promote. It's called the ENRX Calculator. You just go to Google Play, and then you type ENRX Calculator. And we designed this application because we wanted to teach our consultants, our doctors, how to utilize your formulas. So did you ever wonder if you are already exceeding the protein content of your tube feeding? So if you are using a commercial formula, you should click at the ONS or the tube feeding formula, and then you will look at the product. So if you have recommendations, like you have products in Turkey that we can add, or products in your country that we can add to the app, please feel free to message us so we can compute for the calories. We'll put the calories there and the protein. So the example is that you can use the app, to compute. For example, I'll give you an example. Okay. So for example, you want to use a certain formula. So this is not promotion, this is just for education purposes, because we have a lot of formulas in the market. And you have to understand what is inside. Just like medicine, you have to know what is inside before you prescribe it, before you order it in the doctor's order sheet. So once you click on the product formula, you will see, for example, one product, and you will check how many calories or macronutrients do I have in my number of scoops. So if I type 7 scoops, your computation will automatically appear. How many folic acid, how many biotin, how many vitamin C, how many glutamine. And you will also see in the app that if you are on tube feeding, if you have a patient on NGT or PEG, and you prescribe 1,400 calories, for example, of the formula, or you want 2,000 calories, you can compute for vitamin C, arginine, glutamine, and what is inside your formula, so that you will not exceed the protein. So if you exceed the protein, your kidneys might be in trouble, okay? So try to select the best formula that is safe for your patients and that will not push them further for renal failure. So you can also look at electrolytes in your rehydration drink. So you can check the sodium, magnesium, because sometimes our patients, if they get dehydrated, they just drink any rehydration drink they want. But it's also important to know that it has sugar, and if it has sugar, it's not allowed in diabetes, okay? So again, I'd like to thank everybody, and thank you for your time. And I know I'd like to also share with you, if you have research, we can send the slides also later on. You can use the calculator for your students. Tell them to do studies on amino acid, overfeeding, multivitamin delivery. And you can use this in the ICU. If you have an ICU case, you compute for the calories and you will see the protein and the calories right away, okay? So not just following what the company tells us. It should be us following what is right for our patients, okay? So again, I'd just like to share that in the Philippines, there's a medical nutrition fellowship. If you want to train in the Philippines, I can assist you. And if you want to train medical nutrition, it's a 2-year program. It's a fellowship training. You rotate in ICU, you rotate in surgery and pediatrics. And you can manage your patient on tube feeding, use the enteral pump, use an infusion pump. And we do this training in the Philippines. So inshallah, maybe we can have it also in Turkey. Jazakallahu khairan kathir. Thank you.
Çok teşekkür.
Thank you very much for this great presentation and your examples from your own life. Before taking a break, we will continue with the next session, and the question and answer will be done in the last part. And while we are being prepared, let's take a photo. The final session will be chaired by Associate Professor Dr. Kenan Taştan, and he will join online. And we want the technical team's support. So, welcome.
Aynı zamanda Anadolu Geleneksel Tamamlayıcı Tıp Derneğimizin Yönetim Kurulu Başkanı. Hocam sözü size bırakıyoruz. Salon şu anda sizi dinliyor. Çevresi de dinleyicilerimiz, uluslararası birçok ülkeden katılımcılarımız, sizleri baş başa bırakıyoruz.
Öncelikle bu fırsatı verdiğiniz için kongre düzenleme heyetine ve size teşekkür ediyoruz. Kongrenin son günü, bu son oturumda tüm katılımcıları selamlıyorum. Şimdi ilk konuşmalarını yapmak üzere Nuh Naci Yazgan Üniversitesi'nden doktor öğretim üyesi Mustafa Öner Küçük hocamızı onkolojik hastalarda magoterapi etkinliklerini sunması için kamera karşısına davet ediyorum. Buyurun hocam.
Kenan Hocam, size ve kongreden komitelere çok teşekkür ediyorum. Çok anlamlı, çok güzel bir kongre devam ediyor. Ben de Makka konusunda katılımcılara yapmaya çalışacağım. Sunum geliyor mu?
Evet. F5 yaparsan hocam, ekranı büyütürsen.
Geldim hocam.
Şu anda ekran büyümedi ama yani biz sunuyu görüyoruz. Bir ilerletebilir misin? İlerliyor mu?
Ben de ilerliyor. Sizde...
Yok. Bizde ilerlemiyor.
Nasıl yapacağım bile. Zaten.
Evet. Şu anda hocam galiba ilerledi. Bir ilerletir misin tekrar?
İlerliyor mu hocam?
Hocam bir iki ilerlet. İlk slayttasın şu anda.
Şu anda bende ilerliyor.
Hocam yok. Bizde ilerlemiyor şu anda. İstiyorsan açıp tekrar kapatabilirsin.
Belki. Paylaşıp durduğum tekrar başlayalım. Tamam, ekran. Ben ilk slaytı görüyorum.
Hocam ikinci slayta bir tıklar mısın?
Ben de geçti ama...
Tamam. Hocam üçüncü slayta da bir tıklar mısın? Bakalım oluyor mu? Tam ekran olmadan da izleyebiliriz. Evet. Hocam
ilerliyor hocam.
Buyurun. Buyurun.
Tamam, o zaman tam ekran olmadan ben
evet.
Vakti zaten hesapla kullanmaya başlayacağım. Terapi ben de ses yapıyorum. Tamam, ekran yapmadı. Sesim bana tekrar geliyor da.
Hocam.
Çözüm var mı bilmiyorum. Devam edeyim. Makoterapi bizim kronik yaralarda kullandığımız onkolojik hastalarda gerek yatak yaralarda gerekse bilmem kansere bağlı olan açıntılar, yatak yaralarında ve diğer yaralarda çok hızlı kullandığımız ve iyi cevap alıp tedavi yöntemi. Bu kadar sevimli bu bir lahmamızın görüntüsü. Görüntüsü aslında çok sevimli gözüküyor. Koyunculuk yapan ülkelerdeki insanlar çoğu biliyordu. Ben de çocukluğumda koyunculuk yapıyordum. Koyunların bahar geldiğinde günlerini kırpmak için bu kırpık dediğimiz alet kullanarak fazla günler kesilir ve koyun fazla yükle kurtulur. Ama bu arada kırklığın ucu sık sık hayvan derilerine keser ve o kesintilere benim görevimde elbette tutuyorlar. Yaraları dezenfekte etmekti. Çünkü o derlerdi ki bu yara kurt kapar, kurt olur. Onun için tedavi uygulanması gerekirdi. Bilmiyormuşuz ki aslında Rabbim onu bize tedavi için göndermiş. Larva terapi. Larvaların ayak sütünün olması nedeniyle makro terapi, cerrahi yaygın kullanmasıyla biyocerrah nekrotik dokuyu ortadan kaldırması etkine dayanarak da makro tedavisi gibi isimlerle anılıyor. Açık yaralarda larvanın sağlam dokuya zarar vermeden nekrotik dokudaki olumlu etkilerine faydalanmak için kontrol oluşturan bir niyaz aslında. Bir niyaz, larvaların üretilmesi. Olumsuz etkisi ancak beslenek nekrotik doku bulunmayan larvaların sağlam dokuya kaldırmalarında ortaya çıkabiliyor. Onun haricinde bir komplikasyonu yani çok görmüyoruz. Ve ulaşamadığımız yerdeki larvaların temizliğini yaparak yaraların iyileşmesini çok güzel sağlıyor. Tarihte kullanımı çok eski. Bakın burada bir doğal enfestasyon var. Kişinin ayağına sinek larvaları kendinden kontrolsüz bir şekilde oraya yumurtaları bırakmış. Bu yumurtadan larvalar çıkmaya başlıyor. Aslında bu larvalar büyürken de bu yarayı deprede ederek kişi aslında iyileştiriyorlar. Bakın sadece insanlarda değil, bu da bir hayvanın ayağında niyaz etkeni. Daha sonra bu yıllar kullanılmış olmasına rağmen 1940'larda yıllarda antibiyotik kullanılması, terapi başlanması farmakoterapi eski önemini kaybetti. 1990'lı yıllarda farmakoterapi enzimlerin açığa çıkarılmasıyla birlikte modern tıpta yeniden yerini almıştır. Burada Sghaier serikata dediğimiz bir sinen larvalarını kullanıyoruz. Tercih etmemizin sebebi canlı dokularda yüzeysel mikrofaj beslemeyle bu sinek larvalarının büyümesi. Larvalar tedavide septik olabilecek dezenfektelik yapılan kullanılan asıllarla steril larvalar bu üretim içinde sinek larvalarını temizleyerek antibiyotikler ilave ederek onların steril ortamda ölmesini sağlıyoruz. Steril larvalar 5-8 derece canlılıkla kalitede 5 gün kadar yaşayabiliyor. Dolayısıyla bu tedavi uyguladığımız yerde mutlaka larvalar bizim kendi üretiyor olmamız ya da en kısa sürede bize ulaşacak şekilde bir yerden larvaları temin ediyor olmamız gerekiyor. Larvalar yaklaşık 400-600 larva 24 saat içinde 15 gram kadar yarayı, nekroze, dokuyu yiyebiliyorlar. Burada kullandığımız larvalar birinci, ikinci grup larvalar. Yine biyobek yöntemi değil, gösterecek bir yöntemimiz var. Bu yöntemde direkt larvaları koymaktansa larvaları poşetin içerisine koyarak enzimleri vasıtasıyla ve nekroz vasıtasıyla doku yemelerini sağlayabiliyoruz. Yara diyabeti için sağlanıyor. İyileşme mekanizmalarına gelirse birçok mekanizması var. Gram pozitif ve gram negatif bakterileri öldüren enzimleri var. Bunlar dokudaki granülasyon oluşumunu artırıyor. Hem de oradaki organizmalar, özdeki yaradaki çalışan organizmaların azaltılmasını sağlıyor. Yine kan akımı ve oksijenasyonunu artırıyor. Endikasyonlarına geldiğimizde yara olan her yerde farmakoterapinin indikasyonu var. Burada bunların arasında neler var? Bölgenin hastalığı varsa, diyabetik yaralar ve konumuz olan tümörler ve onkolojik hastaların yatağa bağlı yaralarında gelişen teknik ülserleri farmakoterapinin çok rahatlıkla kullanılacağı alanlar. Kontraindikasyonuna gelirse çok kontraindikasyon yok ama yan etki diyebileceğimiz şeyler var. Bunlar ağrı bir şekilde azaltılabiliyor. Yöntemleri var. Çünkü burada da yerine sinir uçlarını uyarıyor. Bu nedenle biz pansuman ne kadar çok sık değiştirsek ortamdaki konsantrasyonu azaltır. Ağrı azalmaya başlıyor. Analjisine cevap veriyor. Bu bildiğimiz şişe sineği. Bunu kullanıyoruz. Bunlar doğada her türlü yarada ya da kayıtların üzerinde üreyebiliyor, çoğalabiliyor. Yumurtadan larva olarak çıkıyor. Dünyanın birçok yerinde kullanılıyor. Yaşam döngüsünde yumurtadan sonra beslenen larvalar var. Biz bu evreyi kullanıyoruz. Daha sonrası ve erişkin haline geçiyor. Laboratuvarda üreteceğimiz bunları genellikle karaciğer dokusu üzerinde dokusu bulunuyor. Orada üretiliyor. Yumurtalardan alınıyor. birinci dönem larvalar, ikinci ve ikinci dönem larvalarını kullanıyoruz. Gördüğünüz gibi. Üçüncü dönem larva dediğimiz artık yani haline gelirse yaklaşmış. Bunlar bizim için çok uygun larvalar değil. Bunlar steril besi yerinde, özel yapılmış besi yerinde çoğalan larvalar. Larvalar buradan alınıyor. Bir takım enzimleri var. Bu enzimler vasıtasıyla yarayı iyileşmesini sağlıyor. İki türlü etkisi var. Bir yaracılık öldürüyorlar, bir yarayı dezenfekte ediyorlar. Aslında mekanizma bu şekilde. Birinci, ikinci dönem larvaları birçok organizm rezistans, staphylokokus, enfeksiyon, yaraları çok hızlı bir şekilde iyileştiriyor. Kullanımına gelince kafes tarzı pansuman dediğimiz bir şekilde onu kullanıyoruz. Burada yara yerinin etrafını içerisindeki larvaların dışarı kaçamayacak şekilde izole ediyoruz. Çünkü larvalar çok hareketli. Buradan yara yerinden çıkıp başka yere gidiyoruz. Larvaların üzerinde larvaların hava alabileceği ama içine çıkamayacakları incelikte bir özel bezle kapatıyoruz. Etrafında çok iyi şekilde bantladıktan sonra larvalar içeride kalıyor ve büyümeye başlıyor. Bakın bu üstüne koyduğumuz bez, çok ince gözenekleri var. Kafes hazırlanması için de bu tür sert materyalleri kullanıyoruz. Poliüretan maddeleri. Daha sonra larva yara yeri ıslattıktan sonra içerisine larvaları koyuyoruz. Üzerine kapatıyoruz. Kapattıktan sonra en az 4 saat sonra açıyoruz. Ama bu arada yaradan çok fazla aktif pansumanı açmak için yani 24 saat bekliyoruz. Daha sonra 24 saat bittikten sonra larvaları oradan temizliyoruz. Eğer larvalar çok küçük ve halen beslemeye devam ediyorlarsa bir 48 saate kadar uzatabiliyoruz. Bahsettiğim paketler bunlar. Aynı çay poşetlerine benziyor. Üç tarafı kapalı. İçerisine larva konduktan sonra ağzı ve bize bu şekilde gelir. Steril bir şekilde. Biz bunu yara yerine koyuyoruz. Yara yerine koyduktan sonra larvalar sadece paketin içerisinde çalışıyor. Burada belirtmeler ve enzim salgılamasını oradan yapıyor. Bunu paketi yara yerinden almak biraz daha kolay. Yarasına göre paketli ya da canlı kullanılır. Burada derin tümleri olan bir yara, izi saklanan bunlara ne kadar cerrahi tepkman da yapsak, enjeksiyon sıvısı kullansak da temizleyemiyoruz. Bu tür yaralarda makul tedavi altı standart. Yaranın üzerindeki tepkmanı sağlıyor, ölü dokuyu diyor. Yaradaki granülasyonu sağlıyor. Yaranın hızlı şekilde bize sağlıyor. Bunlar diyabetik ayak uygulamaları. Diyabetik ayaklarda çok iyi. Bunların bir kısmını biz ozonla beraber yapıyoruz. Ozonla kombine ediyoruz. Tedavi birleştirerek. Bakın granülasyon dokusu başlıyor ve sonra yara çok iyi bir şekilde edilmiş oluyor. Üretildikten sonra ya da üreticiden kolay olduktan sonra uygulaması son derece kolay ve etkili bir tedavi yöntemi. Bu da işte bir topuk yarasında larvalar koyduktan sonraki ilk pansumanın açılış görüntüsü. Çok küçük bir şekilde koyduğunuz larvaları 24 saat sonra en az 2 kat büyümüş olarak, hatta 48 saat açarsa çok daha büyümüş olarak görebiliyorsunuz. Ama yaradaki granülasyon çok uzun süre gelişiyor. Birçok yönden avantaj diyabetik yaralarda diyabetiklerin faydaları çok oluyor. Burada komplikasyonlarda neler olur? Bazen kaçabiliyor. Onlar olur. Bir de ağrısı olur. Onun haricinde çok büyük komplikasyon olmuyor. En kısa zamanda bu şekilde çalıştım hocam. Diğer arkadaşlar da vakit kalsın. Allah hızlı bitirdiyse.
Hocam bu güzel sunu için öncelikle teşekkür ediyoruz. Zamanımızın sınırlı olması nedeniyle soruları Orhan Bey'in dediği gibi bütün sunular bittikten sonra varsa alacağız. Şimdi onkolojik hastalarda apiterapinin kullanımı ile ilgili Atatürk Üniversitesi Tıp Fakültesinden doktor öğretim üyesi Suat Sincan hocamızı davet ediyorum. Buyurun hocam.
Hocam teşekkürler ediyorum. Hocam şu an sesimde ve ekranımda hocam bir sorunuz hocam var mı, sıkıntı var mı?
Hocam sesin gayet iyi, ekranda da gayet iyi görünüyor. Buyurun.
Evet, bugün, bu gece onkolojik hastalıklarda arı ve arı ürünlerinin bilimsel yaklaşım açısından etkisini hızlı bir şekilde inceleyeceğiz. Arı deyince bizim aklımıza gelen Apis mellifera türü, bizim ülkemizde bal arısı şeklinde bildiğimiz arımız. Bu arımızın yaşam evreleri var ama bunlar şu anki konumuz değil. Bizim tıpta temel olarak kullandığımız temel arı ürünleri bal, arı sütü, propolis, polen ve bunun fermente olmuş hali perga, apilermil dediğimiz arı larvası ve en sonunda da arı zehiri. Balın ne olduğunu hepimiz biliyoruz. Kendisinin doğrudan antibakteriyel etkisi var. İçerdiği ozmolar yük sebebiyle dokudan su çekiyor ve bu şekilde bakterilerin üremesine engel oluyor. Hepimizin bildiği gibi ülkemizde iki bilinen bal çeşidi var. Çiçek balı ve çam balı. Arı sütü 5-15 günlük küçük arıların yutak üstü salgı bezlerinden salgıladıkları bir arı ürünü. Kraliçe arı sadece bununla beslenerek 2 yıl yaşayabiliyor. Tüm arı larvaları ise bunu ilk 3 gün kullanabilmekteler. Propolis ise kovanı değişik hastalıklara karşı, değişik sorunlara karşı korumak için kovanın içindeki işçi arıların oluşturduğu bir reçineli bir madde. Polen ise bildiğiniz gibi bal arılarının çiçek özlerini toplayarak kovana taşıdıkları bir ürün. Bunun fermente olmuş halinin ismi de perga ya da daha çok bizim ülkede arı ekmeği şeklinde bilinmekte. Arı larvası dediğimiz arı ürünü ise 3-7 günlük yaştaki erkek arı larvalarının toplanmasıyla elde edilmiş bir ürünümüz ve en sonunda da arı zehiri. Şimdi bu sunumda daha çok PubMed'deki yayınlanmış verilerde kanıt düzeyi yüksek olan meta analiz, randomize kontrollü çalışma ve sistematik review'ler üzerinden ilerleyeceğim. Güncel olması için son bir yıl, eğer son bir yılda veri yoksa son 5 yıldaki veriler üzerinden ilerleyeceğim. Tabii biz daha çok insanlar üzerinde bir çalışma var mı yok mu diye bir arayışımız olacak. Şimdi apiterapi ile yayınlanmış kitapları inceledikleri zaman kitaplarda kansere karşı kullanımıyla ilgili çok net bilgilerin olmadığını incelemişler 2020 yılında. O yüzden biz neden tıp veri tabanlarını daha sık kullanıyoruz? Doğru veriye erişebilmek için. Çünkü bir verinin bir kitaba girmesi için yaklaşık 10 yıllık bir zaman geçmesi gerekiyor. Biz PubMed'de bal ve kanser şeklinde bir search yaptığımız zaman 27 tane çalışma ile karşılaşıyoruz. Tabii biraz önce söylediğim gibi kanıt düzeyi yüksek olan meta analiz, randomize kontrollü çalışma ve sistematik review'lar insanlarda yapılmış çalışmalar üzerinde bu search'ü aramayı gerçekleştirdiğimiz zaman 27 tane çıkıyor. Bunların hepsini incelediğimiz zaman hemen hemen aynı şeyleri söylediğini fark edeceğiz. İnsan çalışmalarından bal, kemoterapi ya da radyoterapi sonrasında görülen mukozit olarak isimlendirdiğimiz ağız içi mukoza dokusunun inflamasyonunun tedavisinde son derece etkin bir ürün olarak karşımıza çıkıyor. Yine 2021 yılında bir yapılan meta analizde de bal kullanımının kemoterapi ve radyoterapi görmüş olan buna bağlı olarak mukozit mukozit çıkmış olan hastalarda son derece etkin olduğuyla ilgili bir meta analizimiz. Kanser ilişkili halsizlik, yorgunlukta da bal kullanımının etkin olduğunu kanıta dayalı tıp verileriyle insanlarda yapılmış çalışmalar incelendiğinde bu ile karşımıza çıkmakta. Bir de yine 2020 yılında rezistan enfeksiyonların tedavisinde de Surgery Honey isimli özel bir teknolojik balın teknolojiyle birleştirilerek oluşturulan bir balın son derece etkin olduğu karşımıza çıkmakta. Şimdi insan çalışmaları dememin sebebi şu, çünkü biz insanlarda değil de daha çok hayvanlarda yapılan çalışmalara baktığımızda yüzlerce hatta binlerce yayınlarla karşılaşıyoruz. Ama bizim buradaki mantığımız bizi izleyenlere doğrudan kullanabilirsiniz mesajını vermek olduğu için insan çalışmaları yapılmış kanıt seviyesi yüksek yayınlarla bu sunumu gerçekleştirmekteyiz. Arı sütünün yine birçok etkisi bilimsel olarak ispatlanmış. Bu etkilerden bir tanesi de anti-kanser etkisi. Yine arı sütü ve kanser diye insanlarda yapılmış kanıt düzeyi yüksek çalışmalara baktığımızda sadece 3 tane yayınla karşılaşırken bu sınırlamaları kaldırdığımız zaman 78 tane çalışma karşımıza çıkıyor. Bunlar nedir diye hızlıca baktığımızda yine radyoterapi ve kemoterapi gören hastalarda ortaya çıkan mukozit tedavisinde arı sütünün son derece etkin olduğunu söyleyebilme şansımız var. Hayvan çalışmalarında ise kolorektal kanserlerde son derece yüksek etkisi var. Fakat burada özellikle şunu söylemek istiyorum. İnsan çalışması olmadığından doğrudan hastalarımıza kullanın diyebilmek bir hekim açısından zor. Bu yüzden özellikle insanlarda yapılmış çalışmaları daha çok seçmeye çabalıyoruz. Tabii arı sütünün yine kanıt düzeyi yüksek olan çalışmalarda kanser olmasa bile diyabet üzerinde son derece etkin olduğunu biliyoruz. 6 ay boyunca sağlıklı gönüllüler arı sütü kullandığı zaman glukoz intoleranslarının daha da normale döndüğü, akıl sağlıklarının ölçülebilir bir şekilde daha iyi olduğu karşımıza çıkmış. Kolesterol düşürücü etkisi de var. Uzun dönemli kullanımlarda ise postmenopozal kadınlarda kardiyovasküler hastalıkları parametrelerini düzelttiği yine bilimsel olarak karşımıza çıkmış. Propolis dediğimiz zaman karşımıza bir reçine %50 oranında çıkıyor. Kimyasal en etkin ürünü kafeik asit fenil ester ismini verdiğimiz o bir madde. Yine bir sürü etkisi saptanmış. Bunlardan yine antikanserojen etkisi de karşımıza çıkan bir şey. Yalnız hayvan çalışmalarına baktığımız zaman 615 tane sonuç varken insanlarda yapılmış kanı seviyesi yüksek çalışmalar sadece 15 tane. Yine bizim radyoterapi sonrası görülen mukozitte de bal gibi, arı sütü gibi propolisinde etkin olduğu karşımıza çıkmış. Meme kanserine bağlı kemoterapide yaşam kalitesini arttırdığı şu an için bilinen bir gerçek. Yine aynı şekilde ağız içi mukoz dokunun inflamasyonunda karşımıza çıkıyor. Hayvan çalışmalarında ise o kadar çok farklı kanser tipinde işe yaradığı ispat edilmiş ki işte bunlar lösemiden, meme kanserinden, prostat kanserinden, servis kanserine kadar son derece değişik bir yelpaze ile karşımıza çıkıyor. Ama dediğim gibi şu an insanlarda bunu kullanın diyebilmek için henüz çok erken. Bu konuda daha fazla çalışmayla insanların üzerinde bunun bu şekilde sonuçlandırdığını ortaya çıkartmamız icap ediyor. Polenlere baktığımız zaman çok özür diliyorum. Burada bir slide yanlışlığı olmuş. Propolisin biz yine diyabette son derece etkin olduğunu biliyoruz. O yüzden diyabet hastalarımıza rahatlıkla tavsiye edebiliyoruz. Diyabetik ayak hastalarında da yara iyileşmesini hızlandırdığı bilinen bir gerçek. Propolis'te püf nokta ilk ürün değil son ürünün etkin olduğu. O yüzden de oradan arıcıdan alınacak olan topakların çok da etkin olmadığı şeklinde bu bilgiyi de vermemiz icap ediyor. Polen aslında bir vitamin deposu şeklinde karşımıza çıkabilir. Yine insanlarda yapılmış kanserle ilgili çalışmalara baktığımız zaman ne yazık ki kanıt seviyesi yüksek çalışmalar yok ama insan olmayanlarda yapılan çalışmalar yine karşımıza çıkıyor. Bunlarda yine hemen hemen yine her farklı tür kanser tipine etkinliğini gösteren çalışmalar var. Ama daha çok polenin antikanserojen etkilerinin var olduğunu gösteren daha temel tıp seviyesinde çalışmalar. Ne yazık ki perla ve apilarnelin kanser üzerinde şu ana kadar yapılmış bir çalışması yok. Ama sonuçta perla polenin fermente hali olduğu için biraz daha perlanın da antikanserojen etkilerinin var olduğunu söyleme şansımız var. Arı zehiri ise yine arı zehirinde de ekranda gördüğünüz etkilerin yanında antikanserojen etkisi de var. 470 tane çalışma O yüzden hangisini hastalarımıza daha bir güvenle yan etkisi olmadan tavsiye edebiliriz dersek sanırım burada propolis biraz daha ön plana çıkıyor. Bal ve arı sütü yine tercih edilebilir ama burada en az yan etkili hangisi diyecek olursak sanırım propolis ve bal bu anlamda karşımıza daha çok ödevin çıkmakta. Hocam benim sunumum bu kadar. Teşekkür ederim.
Suat Hocam bu güzel ve doyurucu sunum için biz teşekkür ediyoruz. Zamanımızı efektif kullanma adına şimdi Atatürk Üniversitesi Tıp Fakültesi Aile Hekimliği Anabilim Dalı'ndan Doktor Öğretim Üyesi İdeal Bera Kartal Yılmaz hocamızı onkolojik hastalarda ozon terapisini anlatmak üzere davet ediyorum. Buyurun hocam.
Hocam iyi akşamlar diliyorum herkese, katılımcılara. Sesimde problem yok herhalde.
Yok, gayet iyi geliyor hocam.
Evet hocam. Şöyle paylaşayım ekranımı da. Herhalde sorun yok hocam şu anda.
Şu anda görüyoruz. Büyütülebilirse, büyütülebilir değilse böyle devam edebilirsin hocam.
Şöyle ilerlerim diye düşündüm.
Evet, ilerliyor.
Herkese iyi akşamlar diliyorum. Aslında biraz sunumumun başında ozon terapiden bahsedecektim ama zamanımız açısından direkt onkolojide ozon terapiden bahsetmek istiyorum. Aslında onkoloji tedavisinde ozon terapi primer bir tedaviden ziyade tamamlayıcı fonksiyon görüyor. Ozon tedavisi düşük riskli ve genellikle standart medikal tedavileri ek olarak uygulanan tamamlayıcı, destekleyici ve yeniden yapılandırıcı bir metot. Bütünsel tıp anlamında tamamlayıcı ozon terapi hastalarda önemli ve anlamlı ölçüde iyileştirilmiş bir genel durum oluşturuyor. Kemoterapi ve radyoterapinin yan etkilerini azaltarak yaşam kalitesinde anlamlı bir katkı oluşturuyor. Bu etkileri 97 yılından itibaren yayınlarla ispatlanmış. Yine 2005'te bununla ilgili çarpıcı bir yayın var. Şöyle mekanizmasına bakarsak tümör hipoksisi neoplastik hücrelerin antikanser ilaçlara ve radyoterapiye karşı direnci hakkında iyi tanımlanmış bir mekanizma. Warburg'un 1920'lerdeki çalışmasında hipoksi durumunda bile kanser hücrelerinin glukozu yoğun bir şekilde laktik asite çevirdiğini fakat hücreler anokside kalmadıkça interstisiyel sıvıda pH hafifçe asidik iken hücrelerin intraselüler pH'sının nötral kaldığı ortaya konmuş. Yani tümör hipoksisi aynı zamanda neoanjiyogenezisi ve metastazı artıran bir faktör. Hem primer hem de metastatik tümörler ortalama oksijen basıncının normal dokulardan daha düşük olduğu ve konakçının fizyolojik seviyelerinin yeniden oluşturulması için gereken reaksiyonu gerçekleştiremediği alanlarda çoğalıyorlar. Anarşik vaskülarizasyon, değişken kan akımı, permeabilite artışı, ödem, hiperkoagülitebilite, metastatik ilerleme bunların hepsi aslında kötü prognoz anlamına geliyor. Her ne kadar farklı tümörler arasında ve aynı tümör içinde oksijen desteği bağlamında belirgin heterojenite mevcut ise de neoplastik dokuların hipoksik ve asit mikroçevreyi tercih ettiğine dair zaten genel bir uzlaşı mevcut. Normal dokular ile karşılaştırıldığında tümördeki ortalama oksijen basıncının normalin 1/4 seviyesinde olduğu bilinmekte. Normal dokularda hipoksemi metabolik bir dezavantaj yaparken deneysel gözlemler bu durumun neoplastik hücrelerin büyümesine avantaj sağladığını göstermektedir. Tümörlerin malin gelişimini önlemek için en fazla yapılan bu konudaki çalışma yapılan alanlardan birisi anjiyogenezisi inhibe etmek. Hipoksi bu durumun tabii ki en önemli stimülanı. Hipoksinin direkt olarak önlenmesi kanserin ilerlemesini durdurmada çok ama çok önemli. Ozonun antitümöral etkisine yönelik hem in vitro hem de birkaç hayvan deneyinden elde edilen bilgilerde medikal ozonun farmakodinamiği hakkındaki bilgilerimizden faydalanırsak sistemik ozon uygulamasını yani majör terapinin veya rektal infüzyon şeklinde uygulanmasıyla ozon molekülleri tarafından saldırıya uğrayan tümör veya kanser hücrelerinin kendileri değildir. Ekstrakorporeal şartlar altında kandaki ozonun kısa zincirli peroksitler ile reaksiyonu çok kısa bir sürede gerçekleşir ve bu peroksitler glutatyon sistemi tarafından indirgenerek sağlıklı hücrelerin ve organların biyoregülasyonu ile sonuçlanır. Sistemik ozon etkileri her zaman indirekt etkilerdir. Sistemik olarak uygulanan ozonun yüksek veya en yüksek konsantrasyonlarında bile doğrudan antitümöral etkiler aslında doğrudan bir etkiyle elde edemeyiz. Yani indirekt etkilerle. Ancak yine de düşük ozon konseptiyle ozonun spesifik etkilerini elde ederiz. Bunlar immün modülasyon, bozulmuş bir redoks sisteminin düzenlenmesi ve olası bir hipoksemi regülasyonu olarak sıralanabilir. Biraz antioksidan stratejiden bahsedersek kanser ve kanser hücresi metabolizması en azından parsiyel mitokondriyal yetmezliğin bir sonucu olarak özellikle tümör hücrelerinin kendilerinin fazla süperoksit radikalleri ürettiklerini baz alırsak çoğunlukla yüksek oksidatif stres ile bir araya gelmektedirler. Çoğu kemoterapik ilaç antitümöral etkilerini yine bu hidrojen peroksitler, ROS'lar, ozonun parçalanmasıyla ortaya çıkan ve nihayetinde de hidroksi radikalleriyle radikalleri yoluyla açarak aynı zamanda sağlıklı hücrelere ve sağlıklı organlara da zarar veren etkileri bildiğimiz gibi oluşuyor. Ozon tam da bu noktada etkisini gösteriyor. Sağlıklı hücreler ve organlardaki hücre içi antioksidanların regülasyonları ile onları koruyor ve karaciğer ve böbreklere yönelik önleyici ve tedavi edici koruması ile oksidatif stresin yönetilmesinde büyük bir azalma oluşturuyor. Tümör hücreleri çoğunlukla yetersiz antioksidan sisteme sahip. Bu yüzden hem majör otohemoterapide hem de rektal infüzyon ozon uygulaması ile bunlar aktive edilemiyor. Yani bu bizim için bir şans. Tümör hücreleri bu yüzden artmıyor. Bir hayvan deneyinde sisplatin kaynaklı nefrotoksiteden korumak amaçlı 10 ila 70 gama ozon konsantrasyonu 15 seans rektal infüzyon ile koruma sağlandığı görülmüş. Dozun 50 ila 70 gamaya çıkması toksik etkiyi anlamlı şekilde artırmıştır. Yine antioksidan kapasite ve serum kreatin değerleri 20-30 gama dozlarında fizyolojik sınırda olurken yüksek dozlarda patolojik sınırlara ulaşmıştır. Şimdi neden ozonu kullanıyoruz tamamlayıcı onkolojide? Çünkü kronik oksidatif stres süreçleri rektal infüzyonla veya majör terapiyle antioksidan regülasyonu yaparak düzenleniyor. Başka bir gerekçemiz kemoterapi ve radyoterapinin sağlıklı organlarda aşırı ROS ile hücre hasarı üretmeleri düşük ozon uygulaması ile önlenebilir. Bu da yine yayınlarla yanında belirttiğim gibi gördüğünüz gibi yayınlarla ispatlanmış. Yine tüm kanser hücrelerinde bir bağışıklık eksikliği var. Bunu biliyoruz. Buna interferonlar, stokinler veya endojen indükleyiciler gibi immünmodülatör maddelerin uygulanması immünostimülan terapi yapıyor. İşte sistemik ozon endojen stokin üretimini aktive ediyor. Başka bir yandan tümörler hipoksik bir ortamı tercih ediyorlar. Anjiyopoetinler üreterek neoanjiyogenezisi ve dolayısıyla büyümeyi ve metastazı indükliyorlar. Tümör dokusu hipoksik dokuyla benzerlik gösteriyor. Sistemik uygulamayla dokuyu oksijen temini ve açığını iyileştirerek aslında anjiyogenezi de regüle ediyoruz. Yine kemoterapinin uzun süreli ve yüksek dozajlı kullanımı tümörde bir direnç oluşturuyor. Özellikle düşük doz ozonlu 5-fluorourasilin in vitro sinerjisi artı kemo dirençli tümör hücrelerinin sensitasyonuyla bunları aktive edebiliyoruz. Düşük dozlardaki ozon tümör hücrelerini in vitro olarak yok ediyor direkt bir etkiyle ve diğer hücreleri de kemoterapiye duyarlı hale getiriyor. Sonuç olarak onkolojide ozon ile ilgili toparlarsak kan dolaşımının iskemik ve neoplastik dokulara oksijen dağıtımının düzelmesinde, genel metabolizmanın düzelmesinde, antioksidan sistemin daha iyi düzenlenmesi ve kronik oksidatif stresin düzeltilmesinde, selüler redoksun aktifleşmesinde, immün sistem aktivasyonuyla, immün modülatör etkisiyle ve nöroendokrin kaynaklı aktivasyon ile hastalarda iyi halin oluşmasında çok etkili ozon terapi. En uygun zaman ne zaman peki? Özellikle minimal hastalık kalmış hastalarda, yani cerrahi sonrasında başarılı bir ameliyattan sonra uygulayabiliriz. Hem ameliyat edilemez hem de cerrahi tedavi uygulanmış hastalarda ilk grup kemoterapi veya radyoterapi ile kombine olarak verebiliyoruz. Bunlarda hiçbir kontraindikasyon içermiyor ve terapötik etkiyi artırıyor. Yine radyoterapi ve kemoterapinin tipik yan etkilerini azaltarak daha iyi bir tolerans oluşturuyor. Tedavi stratejilerimize bakarsak önce tek başına majör terapi, ardından gerekli infüzyon, örneğin işte ortomoleküler terapi denilen vitamin destekleri alanından bir uygulama bunu takip edebilir. Bu tedavi özellikle yüksek doz vitamin C infüzyonu olabilir. Fakat burada dikkat etmemiz gereken ozon terapinin ve yüksek doz vitamin C'nin birbirini yok etme etkisinden dolayı birlikte verilmemesi. Öncelikle ozon, daha sonra vitamin C infüzyonu ile takip edilebilir. Majör terapide 10-20 gama dozunda başlıyoruz. Mümkünse kemoterapi ve radyoterapi öncesi 6-10 seansla tedaviyle başlayarak ardından haftada 2 kez olarak devam ediyoruz. Rektal infüzyonda yine 10-20 gama ile bu sefer 150-300 mililitre ozon hacmiyle. Yine kemoterapi ve radyoterapi öncesi 6-10 seans ve ardından haftada 2 kez tedavimize devam ediyoruz. Sonuç olarak ozon terapide önemli bir otör olan Bocci'nin son birkaç yılda ozon terapinin farklı mekanizmalarla kansere düşman bir çevre oluşturabileceğini gösteren birçok çalışması zaten mevcut. Önemli olan doğru zamanda ve doğru dozda ozon terapi ile onkolojik tedavilerde tamamlayıcı olarak bir rol üstlenebilmesi ve altını çizerek vurgulamak gerekiyor. Doğru zamanda, doğru dozda ve yetkin kişiyle bu tedavilerin yapılması gerekiyor. Hocam teşekkür ediyorum.
İdeal hocam, öncelikle bu kadar kısa sürede bu kadar geniş bir bilgiyi çok güzel bir şekilde özetlediğiniz için biz teşekkür ediyoruz. Soruları zaten daha sonra alacağımızı söylemiştik. Şimdi kongrenin son konuşmasını yapmak üzere ben kendimi davet ediyorum. Dolayısıyla onkolojik hastalarda hipnoterapinin etkinliği konusunu işleyeceğim. Hipnoterapi aslında tıbbın kötü isim yapmış iyi bir çocuğuna benzetebiliriz. Ve bizim hipnoterapide ana temel argümanımız kelimeler olduğu için ben kelimeler üzerinden öncelikle girmek istiyorum. Bir hadisi şerifte beyanda mutlaka sihir vardır diyor Peygamber Efendimiz ve Yuhanna İncil'inde de önce kelam vardı diyor. Yani kelimeler bu kadar önemli. Ancak yüzyıllar öncesinde İbn Sina hipnozu o kadar güzel tarif etmiş ki ruhsal bir hayal gücü vardır. Bu güç hastalıkları oluşturabileceği gibi var olan rahatsızlıkları da ortadan kaldırabilir. Beden ruhsal hayal gücünün emirlerine itaat etmek zorundadır diyor. Peki o halde hipnoz nedir? Hipnoz aslında yüzyıllardır değil, bin yıllardır tanımı farklı farklı yapılmış bir olgu. Doğaüstü, mistik, mucizevi bir süreç olarak nitelendirilmiş. Günümüze kadar birçok dönemde şarlatanlık, kandırmaca, illüzyon olarak değerlendirilmiş. Kimisi tarafından sanat olarak değerlendirilmiş, kimisi alternatif tedavi demiş, kimisi psikoterapi demiş. Aslında hipnoz disosyatif fizyolojik bir süreçtir. Ve yine hipnozun kelime anlamına baktığımızda aslında mitolojik olarak uyku anlamına gelen ve bu anlamda da Apollo'nun oğlu olan Asklepios'tan geldiğini biliyoruz. Asklepios'un 3 tane çocuğu var. Bunlardan bir tanesi ölüm ve kötülük tanrısı Hades, bir diğeri temizlik tanrısı Hijyen ve bir diğeri de uyku tanrısı Hipnos. Hipnoz ismini bu uyku tanrısından almış. Peki hipnozun diğer tanımları arasında neler var? Baktığımız zaman hipnoz aslında bakışla, sözle, imajinasyonla ya da bazı yardımcı nesneler kullanılarak telkinle oluşturulan özel bir bilinç durumudur. Yine kişinin bilinçaltının onun isteği doğrultusunda telkin alabilir hale gelmesi, yönlendirebilmesidir. Veya beynin iki yarım küresinin tek bir alanda işbirliği yapmasıdır. Veya sol beyinden ziyade yani analitik düzlemden sağ beynin, hayali düzlemin kontrolü altına alınmasıdır. Kısaca hipnoz bir telkinin kabul edilmesidir. Jung şemaları değiştirmek için 4 çeşit müdahaleden bahsetmiştir. Bilişsel müdahale, duygusal müdahale, davranışçı ve kişiler arası müdahale. Hipnoz burada duygusal müdahaleye girer, duyguları harekete geçiren mekanizmaları tetikler, bilinçaltı ve aradaki kritikal faktörü bypass ederek bilinçle bilinçaltı arasındaki kritikal faktörü bypass ederek bilinçaltına bilgilerin ulaşmasını sağlar. Ve yine şekilde görüldüğü gibi dışarıdan gelen bir telkin. Bu telkinin olumlu veya olumsuz olması çok önemli değil. Eğer bir telkin bilinçaltına uyumlu bir şekilde verilirse otomatik olarak bilinçaltı bunu kaydeder. İşte buradaki uyumlu hale gelmesi tekniklerinin adıdır hipnoz ve kritikal faktör soldaki şekilde gördüğünüz gibi aslında burada bir bariyer oluşturur ve bu bariyer bilinçten gelen bilgilerin, telkinlerin bilinçaltına girmesini büyük oranda engeller. İşte buradaki bariyeri kaldıran yine hipnozdaki uygulamadır sağdaki şekilde gördüğünüz gibi. 1993 yılında enteresan bir çalışma yapılmış ve bu çalışmanın sonuçları hakikaten bizleri çok aydınlatır nitelikte ve bu çalışmayı çok kısaca özetlemek gerekirse beyinden kalbe bir uyarı geldiği zaman kalp buna 3 şekilde tepki veriyormuş. Ya buradaki beynin verdiği komutu olduğu gibi kabul ediyormuş, ya kesinlikle reddediyormuş ya da bunu modifiye ederek, değiştirerek kendine uygun bir halde cevap veriyormuş. Ama enteresan bir şekilde yapılan çalışmada eğer kalpten beyne bir uyarı gittiğinde beynin bunu modifiye etme veya reddetme şansı yokmuş. Bu ispatlandı ve yine yapılan çarpıcı çalışmada kalbin elektriksel akımının beyinde oluşan akımdan 100 kat daha kuvvetli olduğu ve kalbin manyetik alanının da beyinden 5000 kat daha kuvvetli olduğu ispatlanmış. Buradaki kalple duyguları, beyinle de düşünceleri kastettiğimizi özellikle vurgulamak isterim. Bu kadar hipnozun tanımı veya hipnozla ilgili bilgiden sonra literatür eşliğinde onkolojik hastaların hipnoterapi etkinliğini çok kısaca gözden geçirebiliriz. Şimdi burada yapılan bir çalışmada kanserli bireylerin tedavisinde bu bireylerin semptomlarının kontrol altına alınmasında ve bunların nötralize edilmesinde hipnozun etkinliğiyle ilgili yapılan çalışmada özellikle ağrının, stresin, anksiyetenin gibi semptomların hipnozla ilgili bu yan etkileri azalttığı tespit edilmiş. Yine yapılan bir çalışmada baş boyun kanserli hastalarda radyasyon sonrasındaki kserotomi için hipnoz çalışması, bir pilot çalışması yapılmış ve bu çalışmadan sonra da radyasyon tedavisinden sonra meydana gelen komplikasyonların ve aynı zamanda da semptomların azaltılmasında hipnozun etkin olduğu aynı şekilde ispatlanmış. Yine buradaki çalışmada meme kanserli kadınlarda ateş basması ve ilişkili semptomlar için hipnoz yapılmış. Bu hipnoz esnasındaki kadınların ateş basmasının, anksiyöz bulguların ve yine sıkıntı, stres bulgularının azaldığı tespit edilmiş. Yine kanser bakımında hipnozla ilgili yapılan bir çalışmada kanserden sonra kansere yakalanan insanların bakımlarında ve kanserden sonra meydana gelen komplikasyonların, ağrıların, sıkıntıların, stresin, kaygıların, uyku bozukluklarının hipnozla çok daha rahat bir şekilde elimine edildiği tespit edilmiş. Yine çocuklarda kronik ve kanser prosedürlerine ilişkin ağrının yönetimi için yine hipnozla ilgili bir çalışma yapılmış. Yine çocukların kanserlerinden sonra meydana gelen yine komplikasyonlarda hipnozun etkin olduğu tespit edilmiş. Kanser bakımı için hipnozun 200 yıldan beri devam eden bir terapötik etki olduğu ve bu anlamda kullanıldığı yine yapılan çalışmalarda gösterilmiş. Kanser tedavisinde hipnozun rolüyle ilgili yapılan bir çalışmada kanserin hemen hemen birçok semptomunda çok etkin bir şekilde kullanılabildiği yine tespit edilmiş. Stanford Üniversitesi'nde yapılan bir çalışmada sujelere bir şeyler yediklerini hayal etmeleri istenmiş ve bu hayal imajinasyondan sonra gastrik asit oranlarının %70 oranında arttığını tespit etmişler. 2000 yılında Lancet dergisinde yayınlanan Harvard Tıp Fakültesi'nde yapılan bir çalışmada ameliyattan önce sadece 15 dakika hipnoz yapılan insanların ameliyattan sonraki ilaç ihtiyaçlarının daha azaldığını ve ameliyattan sonra daha kısa sürede iyileştikleri tespit edilmiş. İsveç'te yapılan 2 tane farklı çalışma var. Haftada 1 saat 12 hafta boyunca bu insanlara hipnoterapi yapılmış, irritable bağırsak sendromu nedeniyle ve bu hastaların %40'ının iyileştiği ve bu iyileşme durumunun da 7 yıl süreyle devam ettiği yine tespit edilmiş. Kısaca şunu söylemeye çalışıyoruz. Hipnoz birçok yöntemde olduğu gibi, birçok hastalıkta olduğu gibi onkolojik hastalıklarda da çok etkili bir yöntemdir. İnsanoğlunun iyilik halinin veya kötülük halinin temel mekanizmasını düzenleyen olaylardan bir tanesi kognisyon ve duygulardır ve hipnoz kognisyon ve duygulara direkt olarak müdahale eden bir tedavi yöntemidir. Bu fırsatı verdiklerinden dolayı ben kongre başkanına ve emeği geçen herkese teşekkür ediyorum. Bu arada muhtemelen salonda olabilir diye düşünüyorum. Sorular varsa salondan sorular alınabilir veya kapanış bildirgesi okunması üzere ben salona bağlanıyorum. Tekrar teşekkür ediyorum.
Değerli arkadaşlar, kıymetli konuklar, toplantımızın sonuna geldik. Kapanış bildirgesini ben önce Türkçe, daha sonra İngilizce olarak sizlerle paylaştıktan sonra toplantımız sona eriyor. Akabinde birlikte yemeğe geçeceğiz. Sonuç bildirgemiz: değerli katılımcılar, Onkoloji ve 4.0 Sağlık Teknolojileri temalı Dünya Müslüman Sağlık Toplulukları'nın 7. Kongresi ve fuarı şu an itibariyle başarıyla tamamlanmış bulunuyor. Öncelikle etkinliğin hazırlanmasında, koordinasyonunda ve yürütülmesinde emeği geçen herkese Dünya İslam Sağlık Birliği adına teşekkürlerimizi sunuyor. Kongremize aktif olarak katılan değerli dinleyicilerimize ve deneyimlerini cömertçe paylaşan panelistlerimize özel olarak teşekkürlerimizi sunuyoruz. Bilindiği üzere kongremizin teması onkoloji ve 4.0 sağlık teknolojileri idi. Onkolojinin tanısal, önleyici ve tedavi edici unsurlarını, bu konuların güncel sorunlarına ve gelecekteki beklentilerine vurgu yaparak bu süreçte tartıştık. Her yıl yaklaşık 8,2 milyon insanın kanserden öldüğü ve bu durumunda bu hastalığı, bu patolojiyi dünyadaki en yaygın ikinci ölüm nedeni yaptığını biliyoruz. Bu ölümlerin çoğu da düşük ve orta gelirli topluluklarda meydana geliyor. Küresel olarak kanser, mortalite ve morbiditeye katkıda bulunan önemli bir halk sağlığı sorunu. 2030 yılına kadar da yılda yaklaşık 21,6 milyon insanın yeni kanser vakalarından muzdarip olacağı bildirilmiş durumda. Risk faktörüne maruz kalma, taramaya elverişlilik, erken teşhis ve zamanında ve etkin tedavideki fırsat eşitsizlikleri nedeniyle bazı demografik gruplar için kanser sonuçları daha ağır seyrediyor. Riski düşürebilmenin tüm malinitelerin, tüm tümörlerin yaklaşık yarısında hastalık açısından önleyebileceği olduğu bildirilmiş durumda. Kanser hastalarının prognozu ve yaşam kalitesi, erken tanı, hızlı ve etkili tedavi, ağrı yönetimi ve palyatif bakım ile iyileştirilebilir. Kanser tedavisinde yenilikçi girişimlere yönelik yapılan son yatırımların bir sonucu olarak geliştirilen ürünler umut verici, ancak hastalara ve sağlık sistemlerine yönelik olarak artan maliyet konusu ise bir sorun oluşturmakta. İnsan kaynakları dahil olmak üzere ulusal sağlık sistemlerinin ve uluslararası işbirliklerinin geliştirilmesi, güvenli, yüksek kaliteli, uygun maliyetli ve zamanında sunulan bir sağlık hizmeti için sağlanmak durumunda. Belirli kanserlerin tedavisi için mükemmeliyet merkezlerinin kurulması, bu amaçla bölgesel işbirliklerinin geliştirilmesi gerektiğini anlamış durumdayız. Kanser tedavisinde cerrahi, radyoterapi, kemoterapi gibi alanlarda doğru karar verme ve doğru tedaviyi planlama için kılavuzlara uyum çok önemli. Bu amaçla sağlık profesyonellerinin her aşamada eğitimine ağırlık verilmesi gerektiğini anlıyoruz. Ayrıca kanser kontrolüne yardımcı olmak için sürdürülebilir insan kaynağı ve finansal durumun devreye sokulması önem taşımakta. Kanserin önlenmesi ve kontrolüne yönelik kanıt temelli, tedavi sonuçlarını irdeleyen, yaşam kalitesi ve maliyet etkinliği üzerine yapılacak olan çalışmalar bu noktada teşvik edilmek durumunda. Yaşam boyu kapsamlı bakımın çok önemli bir parçası olan ağrı yönetimi ve palyatif bakım ise ayrı bir dikkati hak etmekte. Kanserden iyileşen hastaların ve ailelerin aktif katılımıyla hastaların takip, geç etkilerin yönetimi ve koruyucu önlemler gibi aşamalar desteklenmeli. Diğer bir konu başlığımız olan Sağlık 4.0'ın arkasındaki temel fikir ise sağlığı geliştirmek için en son teknolojiyi kullanmak. Erişilebilirlik sayesinde toplumun sağlık hizmetine erişiminin geliştirilmesi ve tıp uzmanlarına hastalara daha iyi bakım sunabilmeleri için daha basit ve daha kullanışlı bir çalışma ortamının sağlanması Sağlık 4.0'ın temelini oluşturuyor. Kurumsal kapasitenin çıtasını yükselten modern teknolojiler sayesinde daha iyi kararları almak artık mümkün. Ayrıca Sağlık 4.0 işletme maliyetlerini önemli ölçüde azaltarak potansiyel ekstra sağlık sigortası ihtiyacından kaçınmaya da imkan tanıyabilir. Dolayısıyla sağlık sektöründe teknolojiden faydalanmak, çeşitli ihtiyaçları karşılamak açısından hem bireysel olarak hastalar hem de kurumsal olarak klinikler ve hastaneler için çeşitli avantajlar sunmakta. En son teknik imkanları uygulamalara dahil etmek için güncel gelişmeleri sürekli olarak izlememiz gerekiyor. Çünkü dünyada olduğu gibi birçok Müslüman ülkenin artan açlık, yoksulluk ve adaletsizlik gibi riskler nedeniyle onkolojik hastalıkların yükünden daha fazla muzdarip olduğunu maalesef gözlemliyoruz. Özetle etkin bir sağlık hizmeti sunumu için yapısal bir ekonomik dönüşüm ve yeterli mali kaynakların yanı sıra ulusal ve uluslararası işbirliklerin geliştirilmesi elzem bir durum oluşturmaktadır. Bu amaçla kongremizin yeni bir sürece ve yeni işbirliklerine fırsat sunacağını umuyoruz. Bu doğrultudaki çabalarınızı saygıyla takdir ediyor ve çalışmalarınızda başarılar diliyoruz. Bir sonraki kongrede buluşmak dileğiyle hepinizi saygıyla Dünya İslam Sağlık Birliği adına ve Kongre Düzenleme Kurulu adına saygıyla selamlıyorum. Allah'ın selamı üzerinize olsun. Now I'll read the final declaration report in English. Honorable participants, the 7th Congress and Fair of the World Muslim Health Societies with the themes Oncology and 4.0 Health Technologies is successfully over. We would like to thank everyone who contributed to the preparation, coordination and execution of the event on behalf of World Islamic Health Union, with special thanks going to our distinguished audience for actively participating in our Congress, as well as our panelists who generously shared their experiences. In this Congress, we discussed the diagnostic, preventive, and therapeutic elements of oncology and the concept of Health 4.0 with an emphasis on current problems and future prospects for these topics. Approximately 8 million people die from cancer each year, making it the second most common cause of death in the world. Most of these fatalities take place in low and middle income nations, and globally it contributes to morbidity and mortality and is a major public health concern. By 2030, it's predicted that there will be about 21 million new cases for cancer annually. The outcomes for cancer are worse for some demographic groups due to the disparities in risk factor exposure, availability to screening, early diagnosis, and timely and effective treatment. We observe that lowering the risk may be possible for about half of the malignancies, and cancer patients' prognosis and quality of life can be enhanced by early diagnosis, quick and effective treatment, pain management, and palliative care. We appreciate the development of novel pharmaceuticals as a result of recent investments in innovation in cancer treatment, but we are deeply concerned about the rising cost to patients and health systems. By enhancing national health systems and international cooperation, access to safe, high-quality, cost-effective, and cutting-edge healthcare service must be addressed. It's essential to create and put into practice evidence-based cancer management regimens, including palliative care, and to establish centers of excellence for the treatment of certain cancers. We must put a strong emphasis on collaboration. It's crucial to promote guidelines that promote clinical decision-making and referral based on the efficient, safe, and economical use of cancer diagnostic and therapeutic services such as surgery, radiotherapy, and chemotherapy, and to facilitate the training of staff at all levels of health systems. In order to assist cancer control, sustainable domestic human and financial resources must be recruited, and novel financing ways must be provided on a voluntary basis. Pain management and palliative care are important elements of cancer care. With the active participation of cancer survivors and their families, follow-up, late effect management, and tertiary prevention must be foreseen and supported. The idea behind Health 4.0 is to use cutting-edge new technology to enhance health. With the help of a secure, moral, and sustainable technology, it may contribute to the development of public health policies at the local or government levels. Health 4.0 also emphasizes avoidance of the potential need for health insurance, which significantly lowers running costs. Utilizing the technology in the healthcare industry provides for a wide range of needs and has various advantages for both patients and clinics and hospitals. Therefore, we need to continuously monitor contemporary changes and recent advances to incorporate cutting-edge technical facilities in their practice, because many Muslim countries suffer from the burden of oncologic diseases that are linked to increasing risks of hunger, poverty, and injustice. In addition to a structural economic transformation and sufficient financial resources, this necessitates a sustainable national and international effort. We want to collaborate on other initiatives as catalyzed in their Congress by WIHU, and we respectfully appreciate your efforts and wish you success in your endeavors. Thank you very much. Evet, kongremiz kapanıyor galiba. Son bir şey söylemek ister misiniz yoksa direkt sonlandıralım?
Fotoğraf çekildik. Fotoğraf çekilmişiz. Bütün katılımcılara teşekkür ediyoruz. Hepinizden Allah razı olsun. Hepinize hürmet ve muhabbetlerimizi sunuyoruz. Selamünaleyküm. Abdüllatif Bey, selam vermek ister misin? Gel bir selam ver.
Selamun Aleyküm. Hem Arapça, İngilizce, Türkçe konuşuyoruz. نشكر جميع الحضور على قدومهم وعلى مشاركتهم في هذا المؤتمر. نسأل الله سبحانه وتعالى أن يكون فائدة كبيرة لكم ولجميع المسلمين. Mesdames et messieurs, j'espère que cette conférence et cet congrès sera utile pour notre Ummah et notre population. Ladies and gentlemen, I hope that this Congress and this conference was fruitful for all of the Ummah and for our nation. Sayın misafirlerimiz, katılımcılarımız, umarım bu toplantı ve kongre çok verimli ve